हीरा अपना म्यूट कर लो, यही तो प्रॉब्लम है कम से कम। ये कैसे म्यूट करेगा? Dr. Anupriya, are you there? Can you unmute and can we check?
Okay. Okay.
Dr. Anupriya, are you there? Could you please unmute your microphone and video so that we can see, because we are, it's about 1 minute away. We have to start the program.
Hello. 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 Hello, sir. Am I audible? Hello. Hello.
Yeah, Dr. Anupriya. Hello.
Can you hear me, sir? Am I audible?
You are audible, Dr. Anupriya.
Yes, yes, sir. So shall we begin the session, sir?
Just wait for a while.
Yeah.
I think your phone is, we are getting some echo and all. So, is there any other device you are logged in? No.
Just a second, sir. I'll just a minute, sir. I'll just check it. So is my voice clear now?
Yes, your voice is clear.
Okay,
So,
sir.
Dr. Anupriya, because we are the people who are joining from US and all, they are very punctual on time. So, without wasting any time, please start our program.
Yeah, okay, so we can start. I'm all set. So as a famous Buddhist proverb goes, pain is inevitable and suffering is optional. But how true this quote stands, even when it comes to orofacial pain, an entity which is most often underdiscussed, underdiagnosed, and under or sometimes overtreated. Despite being the most common complaint presented by the patient to the doctor, knowledge about precise and appropriate management and novel innovations in the field is still evolving, and there is still so much more to explore. Also, with the growing ease of availability of the over the counter drugs and the readily accessible internet quack consultations, the so called self diagnosis and self treatment is the problem of the hour. So, with that thought, I welcome you all to the second National Orofacial Pain Congress, Nopcon 2023. A very good evening and very warm welcome to all the dignitaries and speakers who have joined us today virtually for the national webinar on recent advancements in the diagnosis and management of orofacial pain. So I sincerely hope that all the audience participating today would greatly benefit from today's lectures and presentations and implement the practice of referring patients to the concerned specialty for management of orofacial pain. So next, I would like to invite Dr. Nurul Anwar sir to deliver the inaugural speech. So regarding Nurul Anwar sir, so he is an alumnus of AMU, Aligarh Muslim University, Aligarh, and BITS Bilani, and is also an author, public speaker, health evangelist, and entrepreneur working in the management sector of the healthcare industry for the last 2 decades. His specialty domains include health education and communication strategy. He has maneuvered many public health programs and projects all across India. In addition, he is a policy wonk and a keen reader. So presently, he is the Chief Executive Officer at MedSkill, an online learning portal in medicine and dentistry, and he is also a principal consultant to the National Health Academy. So I would like to invite you, sir, to begin the session. You can unmute, sir.
Yes, yes. Thanks, Dr. Anupriya Lakshman. Thanks, Dr. Anupriya. We have privilege that dental surgeon, orofacial surgeon, Dr. Anupriya. She is joining from Chennai. The weather of Chennai was not, proper, because there is some cyclone is there. So we are interacting, 2, 3 days earlier, and we are expecting that whether will she will able to connect live on. But fortunately, the weather is settled now, and Dr. Anupriya is with us, and she would be moderating whole day our sessions. Thanks, Dr. Anupriya, for giving your precious time and joining in our second edition of NOPCON 2023. So with this, introduction note of Dr. Anupriya, I welcome all NOPCONians. I term that this is National Orofacial Pain Congress, and all the delegates who are joining this program are all NOPCONians. And this is NOPCON 2023. Last time we did it in the month of April 2022. But this time we are doing on the month of November is a TMJ awareness program. So on that, we thought that we should, make such a program, a platform where all the orofacial pain specialists, those who are dealing in orofacial pain, whether they are, anesthetist or a neurologist or the oral maxillofacial surgeon, oral radiologist, oral physicians. So because orofacial pain is there are the when the patients are coming to the OPD of any dentist, there are 40% patient has the complaint of orofacial pain, and of this orofacial pain, there are the pain due to there's a two pain like nociceptive pain and neuropathic pain, and there is odontogenic and non-odontogenic. So main basically pain is 40%. Pain is basic. The 60% is toothache, and 15-14% and PMJ and facial pain. So these are the the prevalence of these orofacial pain. Any patient who is coming to the OPD of any dental surgeon. And our, most of the attendees today are dental surgeons, oral maxillofacial surgeons, oral radiologists, oral physicians, and oral pathologists as well. So they are all dental health, oral health procedures. Apart from that, we have some, radiologists and face specialists also who join across India. So this is the platform where we are, coming together. We have there are very handful of, orofacial pain experts in India, and this is the upcoming specialty in India. And it has started say 1.5 decade back, and people are going abroad and getting, the specialty from, American universities, and coming back and practicing in India, and they are imparting their skills to the, the dental surgeons who are working in India. So the basically the problem with orofacial pain is that any patient who are coming to the dental surgeons, the main problem is diagnosing the orofacial pain, because we have to find that from where the pain is originating. And if we are misdiagnosing the pain, then it would be mismanagement. And if the mismanagement is there, there would be great problem like social, psychological, and economical consequences of this. And if we are not treating it thoroughly, and if we are not able to alleviate the pain, the patient is suffering from depression, sleep deprivation, and their reduced quality of life. So keeping these in mind, that we made this program, making an awareness among dental surgeons who are working across India, so that they are, diagnosing the orofacial pain well and diverting the patient to a proper specialty, whether it should be sent to oromaxillofacial surgeons, oral radiologists, or anesthetists, and what should be the, the management regimen. So it is all about that we should not waste the patient time, and make a proper diagnosis and try to refer the patient to the proper specialist, so that he can get easily manage their sufferings and all. With this note, because we have the next speaker with us, Dr. Anupriya, can you take it forward? And thanks all for joining. You would be getting very wonderful 2 days. Today, in the end, we are having the few presentations of the faculties. Tomorrow, some PGs are presenting their papers. We have the specialties across India. People are joining across, the people, the specialists who are joining from US, 2, 3 speakers who are joining from USA late evening today. And then we have very two special speakers, Dr. Sandesh Maikar and Dr. Ajit Shetty. They are a stalwart in this orofacial pain. They are pioneer in this field. And actually, they would be putting forward that, what is the actual scenario of orofacial pain and what is the specialty which is emerging in India. Then we have other speakers. We start with this, physiopathology, then anatomy of, orofacial pain. Then we have the speakers who are joining in. So we'll go till 6 o'clock today, and then the faculty presentation. Then tomorrow we have very, long session. We'll start by 10 o'clock and we'll conclude by 5 o'clock. And there are, all specialties we have covered. We have anesthetist, we have, orofacial pain experts, we have orthodontists, talking about what is the problem of occlusion due to chronic pain. And there are multiple, regimens and way of, managing the orofacial pain. So you would be, enhancing your skill, knowledge and all. And so be connected with us, and you can, after, today's program, you can share your experience among your known ones, so that maybe they might be join tomorrow. There are more, attendees would be joining tomorrow. With this note, over to Dr. Anupriya to take it forward. Thank you.
Thank you so much, sir. And it's actually a great pleasure for me to be a part of this second National Orofacial Pain Congress. So now to begin with our speakers and with our session. So our first speaker is Dr. Varun Surya, who is an alumnus of GDC Mumbai and Maulana Azad Institute of Dental Science. And he has been a scientific coordinator and organizing secretary for various workshops and national conventions. So Dr. Varun Surya has been pioneer in establishing forensic odontology labs in Center for Dental Education and Research, AIMS, New Delhi. He has published over 15 articles in both national and international journals, and currently he is supervising 2 ongoing research projects. So now up to Dr. Varun Surya to enlighten us on the topic of pathophysiology of pain. So I welcome you, sir.
Thank you, Dr. Anupriya. I hope I'm audible. Am I audible?
Yes, sir. Yes, sir. You're audible, sir.
Yeah, actually, I'm taking this lecture from my histopathological lab, and 2 patients are waiting outside. So my camera is not working, I think. So I think it will work. Okay. So I hope you can see my slides. Are they visible to you?
Sir, slides, no, sir,
Okay.
it is not showing yet.
Just a second. Okay. Just. Now it is visible, no?
Yes, sir, it is visible, sir.
Okay, so I will be starting my lecture. Just a second. Okay, so good evening, everyone. So I will be discussing pathophysiology of orofacial pain in brief. So obviously, we all know, we have all felt pain. So basically, pain is a sensory modality that is an unpleasant and emotional experience. So we can also define orofacial pain. Orofacial pain is basically the pain which is associated with the hard and soft tissues of the head, face, and the oral cavity. So what is this oral facial region is composed of? The orofacial region is composed of oral cavity, which includes teeth, gingiva, oral mucosa. Then we have face, we have jawbones, and we have temporomandibular joint, TMJ. So the orofacial pain commonly, originate from teeth and TMJ. So as you can see, these are the 2 main sources of orofacial pain, the TMJ and the dental pain, or you can say the pain arising from the tooth. So we will discussing the pathophysiology of orofacial pain in brief, although it's a very big topic, but I will go according to the time allotted to me. So let's start. So this pathophysiology of orofacial pain include basically the primary efferent neurons and the pathological changes in the trigeminal ganglion, the brainstem nociceptor neurons, and the higher brain function regulating orofacial nociception. So let's see one image, okay? So before discussing, we should have some basic knowledge about the nerves. So we have 12 cranial nerves in our body, like we have olfactory, optic, oculomotor, trigeminal. So the nerve which is interest for us for today's topic is trigeminal nerve, which is the 5th cranial nerve. As you can see on the right side, it contains 3 branches, the ophthalmic branch, the maxillary branch, and the mandibular branch. So let's start with the discussion of the pathophysiology of the orofacial pain. So as you can see at the peripheral nociceptors in the orofacial region, after receiving repetitive noxious stimuli or an excessive uncontrollable inflammation, the first order neurons, as you can see here, the first order neurons in the trigeminal nerve will develop increased pain signals that are projected to the trigeminal ganglion. For example, suppose there is some caries or some inflammation in the tooth. Now, these pain sensation will be carried by this trigeminal nerve primary efferent to the trigeminal ganglion. After that, the pain signals are sent to the second order neurons in the trigeminal nucleus caudalis, which is located in the brainstem. I hope all of us knows what is brainstem. Brainstem is basically structure consisting of the midbrain, the pons, and the medulla. Now, for the trigeminal nucleus, there are 3 groups of nuclei located inside the brainstem. So these are the 3 groups of nuclei. The first spinal nucleus of the trigeminal ganglion, trigeminal nerve, is the pars oralis. So this area corresponds to the pars oralis. The second is the pars interpolaris. So this is the area corresponding to the pars interpolaris. Now both of them convey a tactile sensation in the orofacial region. The third spinal nucleus of the 5th nerve is the pars caudalis. This is the pars caudalis, and this is the area which is corresponding to pars caudalis, which carries the pain perception of the involved area. Then these signals will be projected to the 3rd order neurons. So first is the 1st order neuron, then they convey the signal to 2nd order neurons, and then to the 3rd order neurons. So these signals will be projected further to the third order neurons in the thalamus via the ventral trigeminothalamic tract. So this is in brief about the pathophysiology of the orofacial pain. So now let's discuss about the classification of the orofacial pain. So we can classify the orofacial pain based on the duration. It can be acute, it can be chronic, and also by the cause. It can be nociceptive pain, inflammatory pain, and the neuropathic pain. So let's discuss first of all about the difference between the acute and the chronic. Let me give an example. For example, the tooth arising from the pain arising from the tooth comes under acute orofacial pain, whereas pain associated with trigeminal and TMJ comes under the category of chronic orofacial pain. So as the name suggests, the acute orofacial pain is obviously have shorter duration, where if the pain subsides more than 3 months, then it can be considered as chronic orofacial pain. Now, acute orofacial pain is caused by inflammation or injury of the tissue, whereas the chronic orofacial pain is caused by inflammation, nerve damage, and excessive or uncontrolled inflammation. Now, when you remove the stimulus, obviously the acute orofacial pain will disappear. But in case of chronic orofacial pain, the pain is persistent, excessive, and it can be sometimes uncontrollable. Now, if you compare the signs and symptoms of the acute orofacial pain and the chronic one, the acute orofacial pain shows sudden, sharp, intense, and localized sensation. Whereas in case of chronic, it is aching and diffused. Now, physiological response of acute orofacial pain is acute pain affects increased cardiovascular function, such as increased blood pressure and heart rate via sympathetic response. Whereas I think someone is writing on the screen. So now second, in case of chronic orofacial pain, the chronic orofacial pain affects physiological response with adaptation behavior or psychological response such as depression and anxiety. So as I told you in the initial part, the examples we can take, like for example, dental pain, pulpitis, and mucogingival pain, it comes under acute orofacial pain. Whereas neuropathic pains, for example, trigeminal, peripheral trigeminal nerve injury, post-therapeutic neuralgia, they comes under chronic orofacial pain. The chronic inflammatory pain, for example, chronic pulpitis and apical lesions, TMJ pain, they also come under category of chronic orofacial pains. Also, the neurovascular pain such as migraine, tension, headaches, they can also be considered under the category of chronic orofacial pain. After that, we can discuss the differences between three main kind of pains based on the cause, like nociceptive pain, inflammatory pain, and the neuropathic pain. Now, in case of nociceptive pain, the noxious stimuli is the main cause at the peripheral nerve and transmitted by the normal component of the sensory trigeminal nerve. Now, in this category, obviously the nerve structure is not involved, so it is normal. It is in response to the noxious stimuli for the protective and withdrawal response. For example, if you have eaten something hot, hot soup containing the oral mucosa, immediately you want to throw it out. So this is an example of the nociceptive orofacial pain. Now let's discuss about the inflammatory orofacial pain. So strong noxious stimuli causing lesions in the tissue leading to local inflammatory response, increased inflammatory mediators comes under inflammatory orofacial pain. Again, in this condition, the nerve condition is normal and the stimulation in this case is response to noxious stimuli and increased activity of the peripheral nociceptors. For example, pain because of pulp necrosis with periapical abscess or the TMJ joint capsulitis or synovitis is caused by joint inflammation. Joint pain and limitation of jaw movement developed afterwards. So these are examples of the inflammatory orofacial pain. Now, neuropathic pain. Now, this neuropathic pain is caused mainly by the nerve damage, as the name suggests, or injury and increased peripheral sensitization structure changed by the increased sodium activation, calcium activity of the nerves leading to ectopic discharges and glial cell activation. Now, as the name suggests, it is neuropathic pain, so there will be abnormal nerve structure. Response to non-noxious and non-noxious stimulation occurs in this condition. Spontaneous pain without stimulation because ectopic discharges occurs in nerve damage. Now, in this category, we can take the example of trigeminal neuralgia. So, peripheral trigeminal nerve injury is caused by nerve damage such as facial trauma, accident, or trigeminal neuralgia, contributing to abnormal nerve structure and expression of severe shooting pain. and intermittent pattern and feels like electric shock. So we all know the history of, the patient who are reporting with neuralgia. They always give this history that they feel electric shocks. So these are the differences between the nociceptive, inflammatory, and the neuropathic pain. So with this, I think my part is finished. So thank you very much.
So thank you, sir. You have enlightened us regarding pathophysiology of pain in a very detailed manner, and it was a much needed revision session for all of us.
Thank you.
Thank you so much, sir. Is there any questions from the audience? No, sir, there are no questions as of now, as it was a very detailed session. Thank you so much, sir. So now, moving on to our next topic about neuroanatomy of orofacial pain. So, from being an alumni of AMU to becoming the professor in the Department of Anatomy, Jawaharlal Nehru Medical College and Hospital, Aligarh Muslim University, Dr. Muhammad Salahuddin Ansari's 20 years of journey has been an inspirational one. Beyond being a teacher and nurturing students for past 2 decades, Sir has displayed academic excellence in the form of 33 plus publications, 5 research projects completed and ongoing projects, and 2 textbooks. And he has chaired numerous scientific sessions in state, national, and international conferences. Now over to you, sir, to enlighten us regarding neuroanatomy of orofacial pain.
Okay, hello, good afternoon. Am I audible?
Yes, yes, sir, we can hear you, sir.
Okay, now.
Hello.
Okay. Are my slides visible?
Oh, yes, yes, sir. It is, so no, sir, your slides haven't started yet.
Okay, just yes.
Yes, sir.
Okay, yes. Yes, is it visible?
Yes, sir, it is visible, sir.
Okay. So, as the good afternoon to one and all. My previous speaker has already focused on the pathophysiology of the orofacial pain, and just I have to focus on the anatomy of the orofacial pain. So now we are knowing from the previous presentation also that the one and only nerve, or mainly the nerve responsible for the orofacial pain, is the trigeminal nerve through its different branches. Okay, he has discussed the pain in detail, but now we are just moving on to the topic. So, barring very few, most of the orofacial pain is carried by branches of the trigeminal nerve. Now we can see from the overview of the sensory nerve supply of the head and neck region, from the forehead to the chin, from the right tragus to the left tragus, the sensory sensation are by the different branches of the trigeminal nerve, that is ophthalmic nerve, maxillary nerve, and the mandibular nerve. So trigeminal nerve is the main sensory nerve of the mouth, oral cavity, and the facial region. Now we can see here that these 3 branches with their further branches are supplying the forehead region by the supratrochlear, supraorbital, infratrochlear, extranasal, and lacrimal nerve, and maxillary nerve is supplying the region of the maxilla through the infraorbital, zygomaticofacial, zygomaticotemporal, and the mandibular nerve through its mental branch, buccal branch, and the auriculotemporal branch. Now we can see here the territory supplied by all these 3 nerves. And now we can see clearly it is visible and the name of the branches. In the next slide we can see the whole oral cavity, mouth and the oral cavity, we can see the upper jaw is mainly supplied by the branches of the maxillary nerve, and the lower jaw is supplied by the mandibular division of the trigeminal nerve. Here we can note that some of the somatosensory sensations or from the basically from the posterior one third of the tongue, posterior one third of the tongue are carried by the glossopharyngeal nerve, and posterior most part of the tongue are carried by the vagus nerve, and some of the sensation are also carried by the facial nerve through its greater petrosal and greater
Sir,
Hello, sir. Your voice is not audible, sir.
actually, sir got disconnected from the session, sir. Sorry for the inconvenience. We'll revert back shortly. Just kindly participants, please stay. We'll revert back shortly. We're just trying to connect with sir again.
Could you please start once more?
Dr. Anupriya, are you there?
Yes, sir. Hello.
The speaker get disconnected. What happened?
Yes, sir, the speaker got disconnected, sir.
Okay.
Sir is not on the
I'm
this
I'm
line.
just allowing you.
Yes, I think sir has joined us again. So kindly unmute, sir.
Am I audible to you?
Yes, yes, sir. Yes, sir.
Okay. Because of, sorry for technical fault, there was connectivity issue. Am I audible?
Yes, sir. We can hear you, sir. Yes, and the screen is also visible, sir.
So, trigeminal nerve, as we are knowing that it is originating or having its origin in the pons, and then from there it is entering into the middle cranial cavity, and in the Meckel's cave it is having its ganglia, and after that it is having three branches, that is ophthalmic, maxillary, and the mandibular. Now we can see the branches here also, and we are going to see the branches one by one. The ophthalmic division is basically exiting the middle cranial fossa through entering into the superior orbital fissure, and then it is supplying the structure of the orbit and adjacent to it. Now we can see here branches ophthalmic nerve, the frontal division, lacrimal, and the nasociliary. Now here in this picture we can see the green, and the nerve seen in the green is basically are the branches of the ophthalmic division. Then the next is the maxillary division. The maxillary nerve exit the middle cranial fossa through the foramen rotundum, and then it is entering into the pterygopalatine fossa. From the pterygopalatine fossa, it enters the orbit through infraorbital fissure, through the infraorbital, and then in the infraorbital groove, and through the infraorbital foramen it is coming out. We can see here the branches in simplified version. Here just mainly highlight the branches which are concerned with the orofacial pain. The zygomatic branch, which is having the zygomaticofacial and zygomaticotemporal branch, and then the posterior superior alveolar, middle superior alveolar, and anterior superior alveolar nerve, which are supplying the teeth and the adjacent structure. We can see here also the diagram, and then we can see here the territory that the molars are supplied by the posterior superior alveolar nerve, and the premolars are supplied by the middle superior alveolar nerve, and the canine and the incisors are supplied by the anterior superior alveolar nerve. And then the next, the one of the three branches is the mandibular nerve. It is the middle cranial fossa through the foramen. Here, exiting the foramen organ, it is giving branches from the trunk. Then it divides into the anterior and posterior division. And from the anterior, the branches are basically supplying the muscle substitutions. And the posterior and then the auriculotemporal, and then the inferior alveolar, which is supplying the lower jaw. Now we can see here also the branches of the mandibular nerve, and here we can see that the premolars are basically supplied by the dental branches of the inferior nerve, and then the canine and the incisors are supplied by the incisive branch of the inferior alveolar nerve. Okay. Then now coming to the part of the pain, as of that all the pain stimulus, irrespective of the nature of the pain stimulus, it is the branches of the trigeminal nerve which are being irritated or basically stimulated, and then the pain sensation from the branch, from the different peripheral branches are coming to the trigeminal ganglia. Here the processes are trigeminal nerve. Then this spinal tract, these neurons are synapsing in the spinal nucleus of trigeminal nerve, and from here, second order neurons are forming the trigeminal meniscus, and this neuron are basically carrying to the ventroposterior nucleus of the thalamus, and from the thalamus, the third order neuron are basically taking the sensation to the somatosensory cortex of the brain. Okay, now we can see here over which is the first order neuron. From the first order neuron, then there is the second order neuron, which is forming the trigeminothalamic tract, and then the thalamus, the VPM nucleus of the thalamus, and the third order neuron from the VPM nucleus of the thalamus to the somatosensory cortex of the brain. So now we can see here the different regional blocks. Basically, you people are more aware, so not to discuss this slide. At last, we can remember that orofacial pain is carried by the trigeminal nerve, then a spinal tract of the trigeminal nerve to the trigeminal meniscus, to the meniscus, the ventral, and from the thalamus to the somatocortex of the brain. Thank you.
Thank you so much, sir. It was an honor to listen to your lecture, and also the importance of neuroanatomy in orofacial region pertaining to pain can never be underestimated. Thank you so much, sir. So our next topic of discussion will be on neuropathic orofacial pain management and evolution. So regarding the speaker, Dr. Shrishti Todi practices in Mumbai and is the founder of the Orofacial Pain and Sleep Clinic. She graduated from Nair Hospital, Dental College, Mumbai in 2013 and completed a 2-year postgraduate residency in orofacial pain and dental sleep medicine from the University of California, Los Angeles, USA in 2007. Dr. Shrishti was one of the youngest diplomates to be board certified by the American Board of Orofacial Pain. Her practice is exclusive to pain and sleep patients, and she consults with eminent ENTs and pulmonologists in Mumbai. Dr. Todi has presented on orofacial pain at various conferences and also has published a lot of articles in internationally renowned journals. Now, ma'am will shed some light on the topic of neuropathic orofacial pain management and evolution. Up to you, ma'am.
Hi, thank you so much for the introduction. Let me just share my screen first. My slides are visible, right?
Yes, ma'am, it is visible.
So my topic for today is neuropathic orofacial pain and evaluation management. Now, the reason that I chose this topic is because neuropathic pain is often ignored in dental school. It's not something we really learn about. We mainly hear about trigeminal neuralgia and how to manage it. And we just know one medication, that is carbamazepine. And we don't really learn how to do a full workup and, how to really find patients who are, suffering from this disease and correctly manage them. Because a lot of time these patients, go from door to various dentists and other specialists looking for a solution without really finding a good, management protocol. So the aim of this lecture is to basically introduce this topic to dentists and, make it a part of their routine examination to look for neuropathic orofacial pain. Now, what is orofacial pain? Orofacial pain refers to the pain in any oral, facial, and related structures. It could be pain in the tooth, it could be pain in the gingiva, pain in the TM joint, or in the associated structures in our muscles of mastication, nerves, and so on and so forth. Now, orofacial pain is usually divided into two parts. One is a somatic pain and the other is neuropathic pain. Somatic pain is very protective in nature. It's a warning system. It tells the body that something is wrong in some part of the body and we must take some action. For example, if you have caries in your tooth, the tooth hurts and you go to the dentist and you get it fixed and the pain goes away. Similarly, if you have arthritis in your TM joint, the joint hurts and you take some corrective steps to prevent the pain from occurring. You eat soft food, you don't sleep on that side, or you just step adaptations around protective pain. Now, neuropathic pain, on the other hand, is pathological in nature, and it by itself is not warning us of something being wrong with some part of the body. The pain itself is the problem. Now, the IESP definition of neuropathic pain is defined as initiated or caused by a primary lesion or dysfunction in the nervous system. That means at some level of the nervous system, something isn't quite working correctly, and hence this pain is occurring. It can be in the peripheral or the central nervous system. So orofacial pain is classified on two axes. One is axis 1 is the physical conditions, and axis 2 is the psychological condition. You have to evaluate for both to arrive at a correct diagnosis for any patient. Now, axis 1 has somatic pain and neuropathic pain, and today we'll only be looking at the neuropathic pains. Now, this is just sort of a simplified slide of the previous one. Neuropathic pain is divided into two types: episodic pain and continuous pain. Episodic pain is further divided into neuralgias and neurovascular pain. Neuralgias is what we are most commonly familiar with. That includes trigeminal neuralgia, glossopharyngeal neuralgia, auriculotemporal neuralgia, or nervus intermedius neuralgia. Neurovascular pain, as the name suggests, is part nerve pain and part vascular pain. It's a combination which creates this pain. For example, in migraines, pain is caused by the contraction and expansion of blood vessels around the meninges, and this usually leads to migraine pain. Continuous pain can be centrally mediated, peripherally mediated, or metabolic polyneuropathies. So centrally mediated pain is like complex pain, regional pain syndrome, or post-herpetic neuralgia. Peripherally mediated pain is burning mouth syndrome, occlusal dysesthesia, dentoalveolar pain, neuritic pain, and deafferentation injury. Now, the reason BMS, occlusal dysesthesia, and dentoalveolar pain have an asterisk on them is because at times these pains can turn into centrally mediated. If they go on for long enough and there's a change in the mechanism, they can become centrally mediated over a period of time. Now, coming to the mechanism of neuropathic pain, the actual mechanism is very complex and it's not fully understood because the nerve, as you can imagine, is a large structure. There is a neuron situated at one end of the body and the nerve that is at some other end of the body. So along this long line, there can be an injury anywhere. There can be like something can go wrong at any point and it can cause pain. Sometimes there are multiple lesions in multiple levels of the nerve which give rise to pain. So it's very, it's a bit challenging in that respect because until you really know the cause of the pain, it becomes more difficult to treat the pain. And there's no single etiology for neuropathic pain. It can be because of something very innocuous, like a patient comes to you, you would simply place an implant or you extract a wisdom tooth, or sometimes even just with oral prophylaxis, a patient can develop neuropathic pain. And of course, it can be something more sinister like a tumor or a hemorrhage or a vascular compression in the central nervous system, which is giving rise to these pains. So that's why a thorough evaluation is very important to arrive at a correct diagnosis. So I've again broken it down just for sake of simplicity into peripheral mechanisms and central mechanisms. Peripheral mechanisms of neuropathic pain can be because of local nerve injury or nerve demyelination. Local nerve injury can be because of, again, trauma to the face, tooth extraction, implant placement, and degeneration as well as regeneration of the nerve are very variable. There is no saying how much of the nerve will degenerate, and there's no saying how much of the nerve will regenerate. At times when nerve regenerates, it sort of sprouts more axons and more receptors and becomes a little tangled mass of nerves and gives rise to what we call a traumatic neuroma. And usually when the nerve is injured, it releases neuroinflammatory mediators like substance P, CGRP, and IL-6, and all of this gives rise to persistent pain. And there's often upregulation of sodium channels, and these are atypical channels that are very hard to block and they keep on firing. And it also leads to ectopic neural discharge, which Dr. Surya has already covered. But basically, it is the sensitive mass of neurons that is regenerating, and it just fires because it has a very low threshold for activation. Nerve demyelination is when the myelin sheath of the covering the nerve is degraded because of some reason like chronic mechanical contact or just inflammatory pressures sitting on top of the nerve. And this can also lead to leaking of electrical nerve impulses, which is called epiphactic nerve firing, where the impulse spreads to adjacent nerves and a lot of nerves start firing. And again, as you can imagine, that leads to pain for the patient. Central mechanisms, they are usually due to damage to the trigeminothalamic pathway. and this leads to sensitization of neurons in the central nervous system. Again, can be more sinister reasons like a hemorrhage or an infarct or a tumor, or neurodegenerative disease like multiple sclerosis, which leads to multiple sites of basically white matter lesions. And again, in this, the site of the lesion determines the pain perception, and it leads to more diffuse and circumscribed symptoms. Now, coming to the evaluation of neuropathic pain, it's very important to correctly evaluate the patient so you do not miss anything, because at times you need to make sure you aren't dealing with something that requires more extensive therapy or more extensive imaging, and you've got to make sure you cover all your bases. So the first and the most important part, I would say, is patient history. You have to make sure that you take a very comprehensive history from the patient and ask the patient to describe the symptoms in their words. The most commonly used words to describe neuropathic pain is electric shock, like burning, tingling, itching, prickling, and cold. And it's very important to get an understanding of how often the patient has the pain, how long it lasts, what it feels like, where it is on a visual analog scale, and understand whether the patient has any positive symptoms or negative symptoms. Positive symptoms are like pain, allodynia, hyperalgesia. Positive symptoms, anything that is added, and negative symptoms are anything that is subtracted. So anytime the patient complains of numbness, anesthesia, dysesthesia, that is a negative symptom. And always identify the location, quality, and quantity of the pain. Now, what are allodynia and hyperalgesia? These are two commonly used words in orofacial pain that are important to understand. Allodynia is when a normally non-painful stimulus evokes a painful response. For example, if someone simply touches their face or brushes their hair and that is painful for them, that is allodynia, because that should not be painful. And hyperalgesia is exaggerated or an overly intense pain response to a normally painful stimulus. So as you can see in the graph, it's the shifting to the left of the curve, because the stimulus intensity has gone down, but the pain intensity has gone up, both for allodynia and hyperalgesia. Now coming to episodic and continuous pain. In episodic pain, there's complete remission between two attacks. So a patient will respond, give a history of completely of zero pain between two attacks. And this pain can be spontaneous, or it can be triggered by a stimulus like brushing your teeth or putting makeup on, or like simply touching your face. And the episode intensity and frequency may vary. It may be sometimes a patient may complain of pain 5 times a day. Sometimes they may complain of pain 5 times a month, or so on and so forth. So you have to really understand the pain symptomology. And very often, patients of neuralgic pain obviously have episodic pain, so they complain of sudden volleys of electrical pain, and it's more paroxysmal in nature. In continuous pain, there is no total remission of pain. The patient will never report a pain of 0. It will always be there. There'll be a dull, aching sensation in the background, and they may have superimposed episodes of very sharp and electrical like pain. And it may be provoked by normal stimuli, or it may again be spontaneous. Now, it's very important to know whether the patient is having episodic or continuous pain, because that definitely changes your diagnosis and hence the management. Next, we come to physical examination. A thorough physical examination is imperative for these patients. This includes a general evaluation of all orofacial structures, looking for any obvious lesions or swellings, lymphadenopathy, tumors, abscesses, anything of that sort. Then there's a musculoskeletal examination where you examine the TMJ, the facial and cervical muscles, the masticatory muscles, and you look for any musculoskeletal disorder like internal derangement or osteoarthritis or muscle spasm. Very often they can refer pain into the teeth, and it can mimic a neuropathic pain. So thorough examination is very important here. Similarly, with intraoral evaluation, like a toothache very often can be paroxysmal in nature, and it can be provoked by certain stimulus. So it can get mixed up with a neuropathic pain. But it is very important to rule out teeth before you jump to a neuropathic pain diagnosis, because more often than not, it's likely to be a toothache. Next is the cranial nerve screening. This is especially important when you're dealing with a suspected neuropathic pain patient, because you want to, again, not miss out on any of the cranial nerve abnormalities because of a central lesion. And because for us, we claim ownership of cranial nerve 5, so we should definitely be well aware of how we should examine it. And similarly with facial nerve, we should know how to examine it very well. So this is a table that summarizes how to perform a cranial nerve examination, a quick cranial nerve examination. It's quite extensive, so you can read it and sort of go through it. But we'll just talk about the trigeminal nerve examination. So as we all know, it's a sensory and a motor nerve. So for the sensory part, we have to test for a light cotton wisp sensation as well as a pinprick sensation. So for the light A beta fibers, we use a cotton wisp, and we rub, and we basically, you take the wisp and you go over all 3 divisions of the nerve very lightly. You usually ask the patient to close their eyes, and you ask them to compare the right side and the left side simultaneously, so they can tell you if there's any difference in sensation. Similarly, with the pinprick, you gently prick on, and again, all 3 divisions of the nerves, and ask the patient to compare the right side and the left side, and if there's any hypo or hypersensitivity to this. And for motor testing, you usually ask the patient to clamp down the teeth, to clench, and you feel for masseter contraction. Or you can ask the patient to move their jaw to the left and right, and you just sort of push against their jaw and give them a bit of resistance, and you see how they respond. Now coming to diagnostic tests. So for neuropathic pain specifically, the way to diagnose it is we start with anesthetic blocks. Now the thing to remember with anesthetic blocks is that odontogenic pain is also blocked with these blocks. But musculoskeletal pain usually is not, because it is a referred pain. So that's where your history taking comes into play, where when you've taken the history of the patient and you do your imaging, if the pain has been blocked by anesthesia or not, you sort of arrive at a conclusion. And for the blockage, we usually start with the most distal branch first, and then we move medially. So you would block the mentalis nerve first before you go on to the inferior alveolar nerve. And you start with the lower level of anesthesia, and then you work your way up. So you first probably just use some topical lidocaine, then you do a local infiltration, and then you do a full nerve block if the pain is still not being blocked. And another way is sympathetic blockade. That is if you are suspecting sympathetically mediated pain. Sympathetically mediated pain, again, by itself is a whole different topic, but at times in some patients, the pain is mediated by the sympathetic nervous system, and they require a different type of medication and different type of ganglion blocks that's more better handled by a neurosurgeon or a neurologist. So it's better to know if you're dealing with it or not, because you may give all the medication, but the patient may still not improve. So it's always a good idea to have that at the back of your mind and refer the patient out if it's not being managed. And quantitative sensory testing helps determine the threshold of the nerve. So basically, if the nerve is hypersensitive or hyposensitive, this will tell us how the nerve is behaving. Next, lab tests and imaging. So your usual blood work and urine analysis, looking for any abnormalities in both of them. Also, blood work is important because many medications that we give for neuropathic pain can actually affect our platelets or our electrolyte levels. So it's important to have baseline blood work before you administer these medications, so you can track it. Then MRI and CT scan of the brain. If you're suspecting a neuralgia or a neuropathy, it's always best to get an MRI. 9 out of 10 times, you will not find anything significant on an MRI. But in that 1 out of 10 patient, you may find a neuroma, or you may find a nerve contact or blood vessel contact with the nerve. So it's always better to order that and just have it clean. And MRI, you can order with a nerve tracing just to see if anywhere along the length of the nerve there's an abnormality. And X-rays and CBCT of dental structures are important to make sure you aren't missing something, especially a CBCT of a tooth that is very painful, is because you want to rule out cracked tooth syndrome, and you can't see that with the naked eye, but a CBCT of the tooth will let you know if the patient's having that. Again, this is just sort of reiterating what types of neuropathic pain you can be dealing with. So based on your evaluation, you will come to a conclusion that the patient has one of these conditions. And again, each of these conditions needs like a lecture for its own, but we'll just sort of this is more like a guideline of a lecture to help you understand the different pains and their management. Now, coming to the management, management can be challenging, and correct diagnosis is key, because if you don't have the correct diagnosis and you administer the wrong medication, the patient is not going to benefit from it at all. And it's very important to even manage patient expectations, because it's a long road sometimes with neuropathic pains, wherein one medication does not work and you try it for 30 days and you then switch to another medication and you hope that works, or the dosage is low and you have to increase the dose. So you and the patient both have to be quite well patient when you're dealing with these conditions. So we can do a medical management, we can have a surgical management, or a non-surgical management. So in the medical management, there are two routes of treatment. One is a topical or a local application of medication, and the other is systemic medication. Now, sometimes a combination therapy may be needed, where you give the patient a local and systemic medication both. And you have to always consider the patient history before drug selection. So you make sure you don't give them something they're allergic to, or something that may harm them just because of the way the liver or kidney functions. And you should always complete a drug trial of 4 weeks, 6 weeks, or whatever the drug calls for, before you reject it, saying that the drug is not working. And again, always go at a lower level, and then you titrate these drugs up, because most of the drugs, as we will discuss further, are anti-epileptic drugs. So we don't want to start at a very high level. We want to give them as little of the drug as possible, but we have to titrate it up if the patient doesn't respond to low-level medication. So topical medication, you can use the compounded mix of capsaicin, lidocaine, gabapentin, carbamazepine, ketamine, and this is applied to the painful area. And you can even fabricate a stent to sort of hold the medication in place. And it is mainly for peripherally mediated conditions, where you're pretty sure that the pain is blocked by local infiltration or a topical medication, and that it is not obviously odontogenic. It usually patients do very well, but at times after a few years, or months, if they're still having some episodes of pain, you may have to switch them over to systemic medication. Coming to systemic medication, anti-epileptic medication is most widely used. As you're all familiar with carbamazepine for trigeminal neuralgia, it still remains a drug of choice. And it's almost diagnostic in nature. If someone responds to carbamazepine, most likely the pain is trigeminal neuralgia. It's very, very unlikely to not be trigeminal neuralgia in that case. Another favorite now is gabapentin and pregabalin, very, very safe drugs, and not a very huge side effect profile. Like, for example, carbamazepine can cause a severe drop in platelets. So, you have to be very careful and you have to monitor the patient. And oxcarbazepine, for example, can drop sodium levels. So, carbapenem and pregabalin are a lot more safer to use, especially in older patients. Lamotrigine is another anti-epileptic medication that is very widely used. Other drugs include TCAs, that is tricyclic antidepressants, like nortriptyline and amitriptyline, very useful in cases of trigeminal neuropathies and not neuralgias. And like benzodiazepines, clonazepam, and you have your selective serotonin reuptake inhibitors like citalopram and escitalopram, and SNRIs, which are serotonin and norepinephrine reuptake inhibitors like venlafaxine and desvenlafaxine. SSRIs and SNRIs aren't the drugs of first choice, maybe second or third if the patient doesn't respond to the previous drugs. So again, start at a low level and titrate it up. Avoid polypharmacy, because then you don't know which drugs really worked on the patient and you don't want the patient to be overdrugged. And no abrupt discontinuation of these medications, because especially with the anti-epileptic, it can actually precipitate a seizure if you just stop taking the drugs one fine day. So drug monitoring is very important. You have to educate the patient well, and you have to keep on monitoring the blood work too, to make sure you aren't harming the patient. Next is surgical management. It's never the first therapy of choice in these patients. Medical therapy is always indicated first, and surgical management is for select cases only. And even then, the patient may need to be on medication for some time after. After the patient has had the surgery, we usually keep the patient on the medication for maybe 3 to 4 weeks, and then gradually start titrating them down and see if the pain returns. And depending obviously on the cause of the pain and what we are operating for, the type of surgery differs. Like you can have microvascular decompression, where you basically lift the blood vessel that's in contact with the nerve and causing the demyelination to take place, or transcutaneous stimulation, or like it could be a tumor resection. So again, depending on what you're operating for, the type of surgery will differ. And of course, a neurosurgeon is the person you refer your patient out to, and then they decide whether the patient is a candidate for surgery or not. Then non-surgical management, these are more adjunct therapies. They aren't first-line therapies, which includes Botox, phenopalatine ganglion blocks, and behavior modification. For none of these treatments do we go off the medication. We ask the patient to continue the medication, and results are very variable. These can be used in cases that are refractory. There are times patients, stop responding to medication. So, and they have very painful trigeminal neuralgia. You may inject Botox into the trigger zones or at the painful site in a neuropathy condition. And sometimes the pain does, settle down a bit, but you keep them going on the medication because they will still need it. If you take them off the medication, it is likely to precipitate, a bad case of or episode of the pain. Now, the key takeaways from this is that a very thorough evaluation is important for correct diagnosis. These medications are not to be taken very lightly because they have a long-standing effect on the body. So you have to be confident about the medications you are using. And you have to manage the patient expectations and explain to them about their condition very well. And it can be clinically challenging for the patient as well as the clinician. So it's always better to educate yourself as much as you can. And there is no cookie cutter management. Each patient is different, and you have to, no lecture can be taken as a cookbook of, you see these symptoms, you prescribe this medication. Each patient is different, each symptom is different, and sometimes the same symptom can be caused by different causes in different patients. So you can't have a one-stop treatment for everyone. And whenever in doubt, please refer out. That's the way to go. If you don't know what you're dealing with, if you feel a bit over above your head, just refer the patient out, ask for a second opinion because you want what's best for the patient. So that's my lecture for the day. Thank you very much to the organizers for having me in Nopcon 2023. And if there are any questions.
Thank you, ma'am, for an eye-opening session on the evaluation and management of neuropathic pain. As you said, diagnosing correctly and treating the patients in neuropathic pain and seeing them relieved of pain is purely a bliss. There are no questions, ma'am, as of now.
All right, thank you.
Hello,
Yeah.
excuse me, ma'am.
Thank you.
I have one question. Hello.
Yes, sir.
Can I ask one question? Dr.
Yes.
In analysis, as you told, ma'am, urine analysis. So what we have to check it for? Or
For which analysis?
in orofacial pain related, how will you relate with that? Urine analysis.
So a urine analysis is more, you look for like kidney function or liver function or electrolytes. It's to get just to get an overall health evaluation. Nothing specific, but because these medications can have a long-standing effect, so you want to make sure you're not harming the kidneys, for example. So you check.
Okay, fine.
Yeah.
Drug-related things. So.
Correct.
Ma'am, we have one question, ma'am. So
Which
can you
one
tell
you
us
want
the
to
dosage
question?
and sequence of carbamazepine?
So carbamazepine, we usually start at 200 milligrams. We started at night, and you can go up to 1200 to 1800 milligrams also of carbamazepine, but you should be very careful. You start at TDS and you slowly titrate it up.
Okay, thank you, ma'am.
Right, thank
you. Now the next question. We have two more questions coming up, ma'am.
Yeah.
So they are telling you to enlighten little about topical medication and compounded mix.
So unfortunately in India, I can see the question here, you don't really get compounded mixes in India. You can ask a patient to use lidocaine and you get capsaicin, that's still available. So you can ask the patient to just mix capsaicin and lidocaine again in like correct amounts, because capsaicin in large amounts can like really burn the oral cavity. So in small amounts with more lidocaine, you can ask the patient to mix capsaicin and lidocaine and use that as a topical medication.
Okay, thank you, ma'am. And
Thank you.
Next question is, there are questions coming up, ma'am.
Yeah.
So the next question is about topical intraoral medication brands available in India.
Yeah, as I said, you don't get you get capsaicin and you get lidocaine. Again, those are the only two medications really available in India, and nothing else. Yeah.
Yes, yes, as you said. Thank you, ma'am. And the next question is, which cases to use the SSRI and SNRI drugs?
SSRIs and SNRIs aren't very commonly used, but like in a patient who's completely refractory or cannot, for some allergic related reasons, have carbamazepine or any of the TCAs, that's when you will give SSRIs and SNRIs. And also, if they're having the very anxious patients, they're having symptoms of anxiety and depression, then to sort of take care of all of this together, you can prescribe SSRI and SNRIs. But again, if you're not very comfortable with it, leave that to a neurologist.
Thank you, ma'am. And I think this is the last question. Kindly few words on auto-induction.
Auto-induction of the nerve.
Auto-induction of carbamazepine, how it affects the dose calculation.
Well, I mean, you have to. So some patients, when you give them, say, 800 milligrams carbamazepine, they do okay with it, and they're okay with it for maybe, I don't know, months at times. And in some patients, even within the first few days of 800 milligrams, they're just hyper responders, so they hyper metabolizers, so they metabolize it very fast. So you have to increase the drug dosage. But even after a point, if the patient is not having enough relief, then you have to add, say, maybe a gabapentin just to sort of, combat that effect.
Okay, ma'am. So, and the next is, so they are asking, like, so the first line of treatment to use the SSRI or SNRI. So it won't be the first line,
It
right?
is SSRIs and SNRIs are not the first line. They're the second or even third line. Yeah, not the first line.
Yes, ma'am. So then, how much pain relief in terms of percentage we consider for orofacial pain to be success? The patients get cured completely? Kindly share your experience.
Unfortunately, depending on the condition, there is no cure. I would say it is a management. Because so what we usually do is, I want the patient to have at least 80 to 90% pain reduction. And if you ever want to take the patient off the medication, they should be completely pain-free for at least 3 to 6 months. That means in the 3 to 6 months that they are on the medication, they don't even have a tingling sensation. Like, it should be completely normal, and then you can take them off the medication. That also slowly you titrate it down. Because there are cases when, the patient wants to go off the medication, they've not had the pain, but once you start titrating them down, they again start getting the tingling sensation and it starts getting sensitive. Then you've got to put them back on. So it's not a cure. That's what I talk about, managing patients' expectations. There is no cure, unfortunately, at times. It is just management. Like, for diabetes, you don't really have a cure. You're just on the medication for a long time. Similarly, here, sometimes the patient just has to be on the medication for years also if needed.
Yeah, thank you, ma'am. I think the questions, that's all. Thank you so much for patiently answering all our queries.
Not at all, not at all. Thank you so much.
It was a great session. Thank you, ma'am. Now, next, we'll move on to the next session by Dr. Vijay K. Asrani, sir, who is actually a prominent figure in the field of oral medicine, diagnosis, and maxillofacial radiology, renowned for his remarkable achievements and unwavering commitment to dental healthcare. Dr. Asrani's educational journey began at Civil Hospital, Ahmedabad, followed by completing a PhD focused on orofacial pain and temporomandibular joint disorders. As a true visionary, Dr. Asrani is the founder of Gujarat's pioneering TMJ and orofacial pain clinic, Heal Orofacial Pain and TMD Clinic in Ahmedabad. Dr. Asrani's passion for sharing knowledge is evident through his role as an enthusiastic speaker, tirelessly spreading awareness and insights in his field. Dr. Vijay K. Asrani is a true luminary in the world of oral medicine and maxillofacial radiology, setting standards of excellence for the future of dental healthcare. So now Doctor will enrich us about his knowledge on the topic of muscle versus disc disorders of TMJ. Up to you, sir.
Thank you, Dr. Anupriya, for the lovely introduction. I hope my screen is visible to everyone around.
Yes, sir. Thank you, sir. Yes, sir, it is visible.
Thank you so much. Now let's begin the debateful thing about muscle, whether it's a muscle disorder, it's a TMJ disc disorder. Now, before going, very good evening to all of you. As Dr. Anupriya already introduced me. Now, the most important thing to focus around is the disc or the TM joint, specifically the disc of the TM joint or the muscle associated with the TM joint. The most common confusions occurs that either the disc is affected or the TMJ affected. So we need to first get a good amount of knowledge that which structure is affected first, and hence we need to do the management accordingly. Dr. Srishti nicely focused on the point that we must focus on the etiological aspects, then only we'll be able to focus on the diagnosis, and then only we'll be able to focus on the management. So here we are with the muscles versus disc disorders of TMJ. Now, this is just a thing that there are certain types of patients with disc conditions, even with disc conditions, but they don't have pain. They don't report with pain certain times. So there is a factor that what's actually TMD, why it is so surprising we can say, or why it is so confusing we can say. So there are many things which to look about, and there is this ideal class 1 occlusion probably. Sorry, on the right side it's class 2, but this patient has pain. So there was thing going around like this since long, which led to the finding of, or which led me to lead to this. Now, the basic etiological factors related to the temporomandibular joint disorders are occlusal factors, trauma, emotional stress, deep pain input, and parafunction. So we must focus on each and every etiological aspect to diagnose the temporomandibular joint disorders. Now, the TMDs lies around these points, that is protective muscle splinting or protective co-contraction, local muscle soreness, muscle spasm, myofascial pain, articular disc displacement, disc perforations, and degenerative joint disease. Now, the main important point is that how we'll be able to differentiate whether it's a muscle pain or a disc pain lies in this 8 factors. First and foremost is a clinical history. Second is mouth opening limitation. Third is an end field. Fourth is eccentric movements limitation and opening interferences. Fifth is acute malocclusion. Sixth is joint loading. Seventh, investigation. And eighth is diagnostic blocks. Now, coming to clinical history. Yes, history. The more time you spend on history taking, you will be probably having a good amount of knowledge about the etiological aspect as well as the diagnosis. Probably in India, we don't use the diagrams related to the pain diagrams, but in US, as Sir and Dr. Srishti would be knowing that they frequently use pain diagrams. Now, in case of disc disorders, that is anterior disc displacements with reduction and without reduction, the patient will typically point out to this point, that is just anterior to the tragus. I'm having pain at this point. That is characteristic and indicative of disc displacement or a disc disorder. Like muscle, the patient would be, so it is spinning like here, it is spinning like here, it is spinning like here, it is spinning to each and every other aspect. So this matters, the site of pain. Again, origin to the present status, that is we refer to as history of present illness also. So how did it started? Was there any history of trauma or not? I have found in many cases around, suppose if there is a history of trauma to the chin, and if you can ask the patient at that time that whether the chin was open or not at that moment. So I'm not sure whether the patient would be able to recall that moment or not, but if the chin is open and at that time the person receives the blow, and there are likely chances the disc would be involved. See, I'm not telling about regarding the research aspect, but this is the presentation which I have found in many of my cases. Again, chewing efficiency. Yes, this is also a good point. In muscle disorders, the patient would be like, I'm not able to eat properly, like in the way of, okay, my joint gets sore after eating just normally for 5 hours, so minutes. While in case of disc disorders, the patient won't be able to eat. The patient will be like, I'm not able to eat hard, not only normal food. And the patient won't be able to do normal food, that is mainly in disc disorders, and the patient will be able to eat food, but the chewing efficiency is reduced, that is the muscle becomes sore, and that would be muscle disorder. Joint sounds, the one which we are aware of while opening or closing, that is more of likely of subluxation, that is the joint, the condylar head translates much anterior to the articular eminence, while in muscle disorders, that is muscle pain, usually we don't hear certain amount of sounds. Now, but in cases of disc displacement with reduction, there is double click, or we often refer to as reverse click, that is we'll be able to hear the sound once patient opens and once the patient closes. Now, there would be an opening click and a closing click. That is characteristic of anterior disc displacement with reduction. In without reduction, we rarely hear sounds, but with reduction is characteristic of certain amount of sounds. Second important, mouth opening limitation. Yes, as we know that the till 20 mm there is rotation movement, and rotation plus translation of the mandibular condyle leads to entire 40 mm of mouth opening. A normal mouth opening range varies from 35 to 40 mm. No doubt in Indian population there is up to 45 mm also. Certain cases are found where the mouth opening is up to 45 mm. We consider it as normal also. When we'll consider that as abnormal, that is hypermobile, if it's more than 45 and we can feel that the condylar head translates anteriorly, and if it's less than 35, we'll definitely we'll tell that it's a hypermobile joint. Yes, less than 40 mm, 25 to 30 mm. When the mouth opening is usually in the range of 25 to 30 mm, it's likely disc displacement without reduction. In cases of disc displacement with reduction, the mouth opening is usually normal. In muscular pain, there is limited mouth opening that is less than 20 mm, but it's a softened field. The patient won't open because of pain. The patient can open the mouth up to 40 mm, but patient won't because of pain. We'll see just an example of these two cases. End feel, that is when you use your index finger and the thumb and you try to open the patient's mouth and you feel that it can't open more than that, that is an hard end field. That is typically characteristic of disc displacement without reduction. And if the patient is able to open it, though there is a minimal or there is some amount of discomfort or pain, that is a muscular pain, soft end field. Now let's see this patient. She is able to open the mouth, but because of pain, she is restricting it. Yeah. Now see, what I did is, I tried to push and see the patient is able to open her mouth. Yeah. See, yeah, that's characteristic of soft end feel. Now, this is a characteristic of hard end feel. See, I'm pressing a bit more, but the patient is not able to open. I'm just playing it one more. You see, this is hard end feel, and the mouth opening is approximately 23 or 24 mm in this case. Okay. Eccentric movements, limitations, and opening interferences. This will definitely help in knowing disc displacement disorders, specifically without reduction cases. If there are reduced contralateral movements, as for example, if left side of the temporomandibular joint is affected, the patient won't be able to move his or her joint towards the right side. That is, right eccentric movement should be affected. And there are two below, we can see two figures of deflections, deviation and deflection. The one mentioned, yes, the one here, you can clearly see that how the mouth opens. This is characteristic of a deviation thing, and this is of a deflection thing. Deviation you will find in anterior disc displacement with reduction also, or many times in muscular disorders also you find deviation, while deflection, that is towards the side which is affected, that is characteristic of anterior disc displacement without reduction. I will show you the clinical features of a case, showing probably all the features. When she is opening, there is minor deviation towards the right side and pain while opening. The amount of mouth opening she is able to do is 2 fingers. So she is able to take right side the jaw more nicely as compared to left side. Again, while protrusion, there is deviation of the mandible towards the right side. You can see, we can clearly say by this that is right TM joint disc is affected. This was typically a case of anterior disc displacement without reduction involving right temporomandibular joint. Acute malocclusion, this is again thing which I have gathered after asking so many patients. Whenever a patient says, sir, on right side or the affected side, it feel high while chewing. My teeth are touching first on this side as compared to this side. Without undergoing any dental restorative treatment, it is likely the thing that muscle inflammation is there on the affected side, which has led to high point. And in cases of disc displacement without reduction, many times we have found that the patient will say, sir, I'm not able to eat properly on the affected side because there is some amount of space. The patient will clearly say that I'm not able to eat soft and probably we can say finer foods, thinner and finer foods. Okay, so that is also a characteristic thing. One more investigation, joint loading. We use separators in it. This is the best test probably we should use to rule out disc and muscle disorder. We use this type of separator, and when we place it on the right side and there is decrease in the pain on the right side and there is increase in the pain on the contralateral side. Okay, there is decrease in the pain on the same side and increase in the pain on the contralateral side. It is clearly indicative of a disc displacement thing. While if there is ipsilateral pain, that is when we place a separator and the patient is having pain on the same side, it is likely of a muscle pain, and there is decrease in pain on the opposite side, that is likely of a muscle pain. I will show you this demonstration also. You see, when the patient is biting on the right side, the patient is having pain on the left side, left specifically TM joint region. So left TM joint is affected, specifically disc. So this case was a left anterior disc displacement without reduction. One more factor to rule out muscle versus disc disorders. Yes, there are OPGs, TMJ OPGs, EMG, that is electromyography, MRIs, arthrography, CT, CBCTs, T-scan, arthroscopy, and muscle injections. The main for us would be initial investigations could be EMGs or TMJ OPG and MRI. Arthrography, arthroscopy can be carried out, but I feel when we are thinking of disc disorders, MRI is the gold standard and which should be done. Probably, luckily in India, the MRI cost is less. People can afford it, so we can go for this type of investigations. I feel TMJ OPG could be a bit of helpful. We can get a rough idea about the disc by just judging the movements. But again, in certain painful conditions where muscle is sore, the patient won't open much wider mouth and hence TMJ OPG won't be diagnostic. In rough, we can get to know about by OPG the disc, the bony changes. We can come to know about the flattening or certain amount of erosions, which can help us to know it's a degenerative bone disorder or not. Now, TMJ OPG, close and open mouth, this can give a rough idea about reduced movement or reduced anterior translation of condyles. This EMG, along with T-scan, probably tomorrow there are many speakers who would be speaking on EMG also, that how EMG is helpful in determining it. This determines the various activities. Yes, the gold standard MRI. Frankly speaking, MRI interpretation, it's not an easy task. You need to see as many as scans as possible, which will definitely make you a pro in diagnosing disc disorders on MRI. There is an articular anterior band here, and eminences here. There is an intermediate zone, the condylar fossa, and the posterior band. This is a closed mouth view, and there is an open mouth view. What we usually consider how to determine whether the disc is in normal position or not, we draw a straight line from the center of the condylar head, we can say, and up to this point, we consider this as a 12 o'clock position, a straight line from the center of condyle, and a line from the at the junction of anterior band and the intermediate band. We draw a line going like this point, and we can say that if it comes at approximately 11 o'clock position, then it's considered to be a normal. But if it's anterior, it will usually come at a 10 o'clock position, 9 or 10 o'clock position. I have seen most of them are at a 10 o'clock position in closed mouth, which suggests that the disc is anteriorly displaced. While in case of open mouth, this is an intermediate zone. When the intermediate zone aligns with the line from the center of the condyle, it's usually the normal position. And again, if it's at 11 o'clock or a 10 o'clock position, the condition is anterior disc displacement without reduction. I hope you are aware of the term with and without reduction. With reduction is when the condyle moves anterior, the disc also is anteriorly placed. Sorry, the disc is anteriorly placed, and while opening the mouth, the disc comes to its normal position in the open mouth. That is with reduction. And if the disc doesn't come to its normal position while opening the mouth, it's without reduction. Now see, yes, this is a clear-cut picture nicely showing about anterior disc displacement with reduction. This is a closed mouth view. I hope the arrow is visible. This is the disc. See the posterior band here. See the intermediate band here. Okay, it's going much more up to 9 o'clock position around. And see, this is the intermediate zone lying just at the same normal position. So this is anterior disc displacement with reduction. You can also see the picture here. Most of the time, we also use coronal sections. Also, we should use coronal sections to determine whether the disc is medially displaced or not. As per research and as per the findings, the most of the common type of disc displacement is anterior medial disc displacement. Posterior is definitely a rare one because directly there is an attachment posteriorly. This is anterior disc displacement without reduction. See, the disc is anteriorly placed in closed mouth. While opening the mouth, there is no translatory movement of the disc as well as the condyle. The condyle is not moving and the disc is also not moving much. We can also categorize, or we can say that it could be a stuck disc. That is, the disc is not able to move from its position. Last, an important point to differentiate, the most important one, definitely. If the pain resolves by giving an auriculotemporal nerve block, it's a disc disorder. And if the pain resolves by giving a local muscle block, it's definitely a muscle etiological disorder. I'm just showing one or two cases. It's a nice case of protractive co-contraction. You can see that I'm not giving much force on the Easter, and you can see the co-contraction movements of the patient. Probably one more thing, important case which I wanted to share. Yeah, this is also one of a rare case. One more point I wanted to add on in history to differentiate disc disorder is the patient would characteristically say, "Sir, I feel my jaw gets locked while opening up. Lock while opening. It just opens a bit and it gets locked. And after a few while or after doing certain movements, my jaw opens to normal." So that is anterior disc displacement with reduction with intermittent locking. Here is a wonderful case of this. Patient is able to take the mouth towards mandible towards right side but not left side and reduce mouth opening. And now see, the way the patient is able to open the mouth. It's just magic. Yep. Yeah. Now, why we say it as an anterior disc displacement? See the mouth opening after removing the lock. It's normal. It's up to 37 or 38 mm. Why we say it's anterior disc displacement with reduction? Because it's the same patient. We see in a closed mouth, the disc is anteriorly placed. In the locked position, see the disc is anteriorly placed. It's not getting back to its normal position. But when she can open it, the disc is much posterior to the contact. Yes, the joint is subluxating a bit, we can say by this thing. But it was typically anterior disc displacement with reduction with intermittent locking. So finally, to conclude, some say focus on management rather than diagnosis. Many say focus on diagnosis rather than management. But what I believe is focus on etiology, and rest all will be taken care of itself. There are a few wonderful things which I am thankful for. My guide, Dr. Jigna Shah, she always tells, and it was the first day I remember of my post-graduation, she was, remember that no two patients having same disease will present with the exact same complaints of pain. And that's why treatment plan for each and every patient is different in case of TMJ disorder or orofacial pain. Thanks to definitely Dr. Jeffrey P. Okeson sir, who has been with a motivation for me to focus on this wonderful aspect of pain. And yes, thanks to my wonderful patients for helping me study more about pain. The important aspect, before people can begin something new, they have to end what used to be and unlearn the old way. Thank you. This is the contact information. And thank you so much, Nopcon, for having me here. It was wonderful educating the youth and the dentists on this wonderful topic of orofacial pain and TMD. Thank you, Dr. Anupriya, for the same.
Thank you, sir. Sir, actually, we have a few questions coming up.
Hello, sir.
So, sir, in case of
Sorry for
unilateral
interruption. Can I ask one question?
Yes, sure. You can.
Yes, you can proceed.
Sir, what is T-scan, sir? How it is helpful in diagnosing?
See, considering T-scan effect, what I believe T-scan is a factor, it gives good analysis about the occlusal aspects, at which points there is higher occlusal contact and where is high muscular load. But I believe T-scan should be used in a cases where we have pre-data. That's my point of opinion. I'm not saying that it's wrong. T-scan is definitely good and it's helpful in implant prosthetics, many other field. But my point of opinion is T-scan in OFP and TMD helps in many cases when we have the pre-data, which I feel. There is no pre-data of T-scan available. That's my opinion. I don't use T-scan in my practice, but with the help of other modes, I am able to diagnose and I am able to make patients pain-free.
Okay. And about MRI, sir,
Yes.
is it dynamic MRI helpful or static one?
See, dynamic is just, it would be opening. You can see the MRI when the mouth opens and closes. Both of them are same. It's not a, it would be a good presentation though. You can show the patient the dynamic MRI. That would be a good one.
Yeah. Fine, sir. Thank you.
It's my pleasure, buddy.
One from the questions session, sir, like from the chat box. In case of unilateral pain, we can differentiate muscular pain from TMJ pain using separator. If patient having bilateral pain, then how we can differentiate between TMJ and muscular pain?
Yeah, nice question. What happens many times, if one joint is affected, probably there are 80 to 90% of chances in 3 to 4 months, the other joint would be affected if it's not treated. And so in those cases, muscle blocks helps. You can start by injecting one joint with a auriculotemporal nerve block. And if the pain on that joint gets resolved, and if it's a disc pain, likely the opposite side disc pain will also resolve. When we are treating here with bilateral disc displacement disorders, We usually treat one joint first, which is more of a painful and which has got a history of longer duration. And if that joint is treated nicely, I think the other joint adapts well. That is the base of TMJ adaptation.
Thank you, sir. So I think there's no other questions from the question session, sir. So actually, thank you, sir, for explaining us how to actually differentiate whether pain is arising from the muscle or from the disc and how to treat them with all your real-time patient videos and photos. And thank you for sharing your personal experience of diagnosing the patients. And that was the main take-home key point from this session for us. Thank you so much, sir.
Thank you.
So from now on, the session will be carried forwarded by Dr. Sonal Yerpude, and she is actually a private practitioner from Thane, Maharashtra, practicing since 2003. She is also an orofacial pain specialist, TMD mentor, and speaker. She is a fellow in orofacial pain and dental sleep medicine and has completed her aesthetic dentistry certification from New York University College of Dentistry.
Dr. Anupriya, Dr. Sonal here. So let's just concentrate on the speakers for today. Okay. I'm talking tomorrow. So you can continue with my introduction tomorrow. Thank you so much, Dr.
Okay, ma'am.
Thanks to the speakers who have been so wonderful sharing their knowledge. And now I'm Dr. Sonal Yerpude, also the organizing secretary for this conference. It's my pleasure and a great I feel humbled that I'm introducing my mentor here, Dr. Davis Thomas, sir. He is a licensed dental practitioner who is leading in the field of orofacial pain and postgraduate training. He focuses on the treatment of complete cases for craniomandibular disorders, orofacial pain condition, and treatment of obstructive sleep apnea. His education in dentistry includes a Bachelor of Dental Surgery from Kasturba Medical College of Dentistry, Manipal, India, Doctor of Dental Surgery, New York University, that is NYU College of Dentistry, Masters in TMD and Orofacial Pain from Rutgers University, New Jersey, Masters in MSc and in Medicine from the University of Sydney, Medical Sciences, Australia, and MSc in the Clinical Management of Pain, University of Edinburgh, England. Dr. Thomas has had over more than 25 years of experience as a practicing dentist and as a mentor in orofacial pain faculty all across the globe. And it's an honor to have you, Dr. Thomas, here, Dr. T, as we fondly call him. So the stage is all yours, Dr. T, and I know it's going to be a very enlightening session. Welcome to India, Dr. T, again. Thank you for joining us. Dr. T, you'll unmute yourself, please. Dr. T, there is a share screen button down.
Yeah, I'm not.
It has been a wonderful session up till now, and we've got too much of knowledge, I would say, regarding orofacial pain practice and how we should be managing and the differential diagnosis also. So it is wonderful that so many participants have actively participated and registered. And tomorrow we have a very active day, and I'm sure everybody is looking forward to it. Now, the speakers who are presenting today are actually the mentors, and I would say the mentors of mentors in dentistry. I think we have Dr. Thomas here again. So we'll just see if he's connected.
Can you hear me, Menti?
Yes, Dr. T, we can hear you. You may share the screen now.
I'm just going to select this one. I believe my topic is systemic factors influencing the experience of pain.
Yes, Dr. T.
Okay. I'm not sure if you finished introduction. I believe you did.
Yes, Dr.
Meanwhile,
T.
I had to.
And
Okay.
in fact, you are a person, you don't require an introduction. So just speak, and we are all
Okay.
we are all ears to listen to what you're saying, Dr. T.
So thank you, Dr. Sonal Yerpude. She's one of my mentees and one of the best I've ever had. I'm so honored and privileged to present something that right now she's introducing me as a speaker as well. Good morning or good evening to everyone. It's around 5:30 here in the US. I'm on the East Coast in New Jersey. And as you know, probably I'm a faculty at a couple of universities here and a few in India as well. I've been doing orofacial pain for some time, and I'm proud to present it along side by side with my mentee students. I see a lot of names on the list, and I'm very happy for them, and I'm really proud of them. So we're just going to look at the surface, the tip of the iceberg in terms of this. This is one of my peeves in medicine, has been the systemic factors that can influence the experience of pain. And the reason I selected that is one of the reasons was what I believe is my strong basis foundation in medicine that I had from around 30 years ago when I was in Manipal to now. And that has prompted me to, at this point, sort of publish robustly in that field, and also to bring to our colleagues who are listening right now attention the fact that we cannot treat pain, and it's not really treating pain, the term is managing pain. You don't really cure pain most of the times. You're managing the pain to some level of attention that the patient can live with for the next foreseeable future. I strongly believe in this, Tamasoma Jyotirgamaya, and it's the slide that I have in every one of my presentations. And it basically, as you know, says the light of knowledge, eradicating the ignorance, darkness of ignorance. What is the scope of this presentation? It's not much. I have approximately 30 minutes, I believe. And it's really not congenial to a full discussion. So what we will do is a just brief introduction of how systemic factors can affect pain experience in the patient, and not recognizing systemic factors leading to failure of clinicians to address the patient's pain successfully. We'll probably touch base upon genetics and stuff like that, but not too much in this presentation. So why do I have this? Well, there's one basic fundamental thing is pain is universal, but the threshold of pain and sensitivity of pain is not same in every patient. If you look at these images, you understand, I mean, this is bleeding. This is that hooks going in through their flesh. And here we are talking about how to control the patient's 2 to 3 out of pain, 5 out of pain, 10 pain. When you look at this, I don't know what the heck this is, but how do you subject yourself to this? So two concepts that we need to understand is pain threshold and tolerance. A patient who says, you're tickling me, but it hurts me, we need to take it for granted that it is hurting the patient. The pain is what the patient says it is. I've heard so many clinicians saying, I've numbed you up for 3 cartwheels of anesthetic, you cannot be in pain. The question the patient might want to ask the dentist is, why don't you jump into the chair? Let me numb you up and let me show you that it might not always work. So patients' factors, genetics, epigenetics, systemic, environmental, robustly affect your treatment of pain. I know there's around 75 plus people joined today. So this realization is very important in understanding the experience of pain and why we might at some point look at some failures in patient pain management. Again, I have no explanation relatively whatsoever on this one. We can talk about descending modulation of pain. There are so many systems at action here, but what makes them tolerate this pain? And if this patient is showing up to you with level 5 out of 10 pain, does that mean it's really level 5 for me, for example? I don't think so. So their threshold and sensitivity to pain, of pain and to pain, is most important, and it varies widely. There is one condition called congenital insensitivity of pain, and this could be completely congenitally insensitive, or it could be partly insensitive. The problem with that is pain, as you know, is defensive. So these people injure their organs, their appendages and their tongue and their cheek forever. And pain, the defensive nature of pain is not there in these cases, and therefore they go through considerable morbidity, not mortality, maybe that too, but morbidity for sure. And it's sometimes these results are catastrophic. If you have a patient such as this with low pain sensitivity, meaning high pain threshold with you, the complaint should be seen as more robust because they don't complain usually. And by the time they complain, significantly something is happening. These terminologies, I don't want to go through it. I want to let us understand that pain is not switch on and switch off. It is a series of batons being transferred from a first order neuron to a second order neuron to a third order. And once the third order is finished, you have the fourth order sitting in the somatosensory cortex. Any systemic factors that can affect any of these or the receptors, can robustly affect the patient's feeling of pain. And there are so many that affect this. What humbles me down as a pain management physician is when you look at one single C fiber. C fibers, as you know, C stands for chemical. So initially they thought it was sensitive to chemicals. Now we know that it's sensitive to multi or polymodal fibers. If you look at the one end of a single C fiber, and we have millions that carry pain and other sensations, if you look at one, you will be thrilled to know how many types of receptors is at the end of a single. And this is not all inclusive. This is just the beginning of knowledge of pain. So when we categorize patients as, okay, this is chronic pain, it's really not true. There's a IASP definition, is International Association of Study of Pain, is 3 months or more. But is that possible? What if the patient has 2.5 months of pain? So take the principles that we're seeing with a pinch of salt. Anything in the systemic circulation, systemically with the patient that can affect any of these, can this affect the patient's experience of pain? Can this affect the way you treat and manage this pain? And the answer is a robust yes. So I looked up for this presentation that I do to multiple dental associations in the United States. I always look up what is prevalent in the US. For you, most of you are from India, I'm assuming. What you should look at is what are the most prevalent and incident diseases in India. We have 1.34 billion people in India. And if any case you think did not exist, it is there. So the knowledge of the most common, at least, diseases and entities that are in India have to be known to you. The lack of that knowledge is the beginning of a failure. And let be a physician or a dentist, is a beginning of failure in pain management. So if you look at all these conditions in the US, I was surprised when I looked it up. And unless you look up literature, you don't begin to see septicemia. I mean, the US is so proud of our medical education and our medical facilities. Septicemia is the number 10 out of the top 10 things that affects US population. I really, it's not an advice. As colleagues, we should look at what are 10 diseases in India that can affect pain. If you have those walking in, and then you can do permutations and combinations of these, right? Heart disease, respiratory disease, diabetes with cancer, stroke with something else. And now the picture changes. You cannot treat these patients by merely looking at some solitary factors in the muscle or the joint. We will fail. So my advice is that from the basics of 30 years of experience in the US and 20 plus years in orofacial pain is that please learn systemic factors that can affect pain. This is the chronic disease, chronic. This is not even acute. Diseases that affect the US population. How many of us are familiar with what affects the Indian population? For example, dengue is not common in the US. It's very common in India. And if we think dengue will not affect musculoskeletal structures in the orofacial area, we are wrong. And there's so many other ones that will be prevalent in India. So please find out for your full education in pain. The second thing that I looked up is, this is for another lecture, but now you can apply to India as well. What are the top 12 medications that our patients are on in the United States? Because I'm talking to them in the US usually. So in India, let's find out what is applicable in India. If this is India, how many medications you'll be on? And why am I showing you this, right? Because our topic, the purview of our topic today is what? Systemic factors that affect the management of pain. And this is not just connecting or touching the face and finding out what the masset is painful or something else. This is about the patient. I ask my students all the time, what is connected to that joint? What is connected to that muscle? What is connected to that tooth you have in question? And the answer you should be giving me philosophically is that the rest of the patient is connected to that tooth. The rest of the patient is connected to that one masseter. The rest of the patient is connected to the TMJ or both the TMJs. Why am I showing you this? I'm just giving you 12 most common used medication in the US. Atorvastatin, we know it's a statin. It has the potential to induce myalgia. What does myalgia mean? Muscle pain. So can that be in the TMJ area? Of course it can. So what would you do? If you see a patient on atorvastatin and the patient gives you a history of 3 months of muscle pain, you need to ask, when were you put on atorvastatin? Was the dosage changed? This is all clinical pulse I'm giving you. Dosage was changed. How much was it changed to? And when did that happen? So it's crucial to have this knowledge. Atorvastatin, the statins do cause muscle pain. So you need to know. And even if the patient switched from, let's say, Lipitor to a generic name in India or Israel or something like that, you need to know what did they switch to. Thyroxine, of course, if the patient has hypothyroid, there is no way really that patient will not have some level of muscle pain. Hypothyroid is one of the biggest factors in muscle pain in women. So to have a full knowledge of the patient's medical history is not just paramount, it is crucial. And I'm repeating that word, crucial, to know this. Lisinopril. These are all the captopril, enalapril, lisinopril. These are the most common ones in the US. I really advise you to find out what are the common most medications that your patients are used to when they show up on you. Why is it important? Because these medications, one after the other, I will show you in a separate presentation, because this is a 2-3 hour presentation, this is one slide. What will happen is you have all these medications affecting the patient's pain experience. And if we are unaware of it, and this is 2020, this is 2018, I looked up always the current most literature, and that's my guiding light. I will tell you all of these medications have an effect on pain. And I invite you to find out what the effect is, because we are beyond the purview of this 30 minutes presentation. So what are the red flags for dentists? A patient has been grinding teeth for 10 years, they say, but the pain is the last 3 months. What do you infer from this? What do you understand from this? The untrained clinician says, oh, that's because of grinding. Grinding of teeth is unusual to cause pain. Grinding of teeth don't cause pain. Grinding of teeth cause muscle hypertrophy, if there is, and there's so much literature out there. So the patient feels jaw tired on chewing. What is your inference? It's not due to grinding of teeth. That is what the muscles are functioning, meant to do. If muscle hypertrophy caused pain, Arnold Schwarzenegger will be rolling on the floor with pain. So that is not true. Hypertrophy, large muscles do not cause pain. I implore you, if you have a patient such as this, look up the systemic factors. A patient is so routine to see for bruxism to have their bite adjusted. I mean, the literature on this is so robust that bite changes do not cause bruxism. Eye points don't cause bruxism. Why are we dentists still telling other dentists to adjust teeth? This is robust literature in the last 25 to 30 years. The patient feels tired in your chair, opening the mouth for some time. Have we thought about why this patient feels tired, where the other patients sit there and they have no problem? So we should look at the patient as a whole for systemic factors that affects their pain. The last one, patient scheduled for extraction, which is stressful, and they're sleeping in your chair. Look for sleeplessness and obstructive sleep apnea in those cases. They robustly change pain. I'm not sure where this marking came from. If your organizer can either delete it or maybe disable that feature, that would be great. So can bruxism cause pain is the question. These are fundamental questions we should be asking in pain management. My robust answer is bruxism does not cause pain. So why does the bruxism cause of pain? Look up at other factors. When did it start? Why is the patient bruxist? Is it secondary bruxism? Does the patient have pain elsewhere in the body? Will be my question for this. So let me ask you this. What is the most common etiology of muscle pain in the human body? This is the literature. This is the evidence. This is what we need to really learn to understand pain succinctly. What are the most, if I ask 78 of you on board right now, what are the most common etiologies of muscle pains? Forget masseter and temporalis and all that stuff. What is the most common muscle pain etiology in the body? Because we should start there, systemic factors. What are the most common diagnoses with myalgia? Muscle pain. How come we can separate TMJ musculature from the rest of the body? It is absolutely nonsense when we separate that. It's a part and parcel of the body. It's the same skeletal muscles. It's a similar physiology of the joint. There is some specialties for every joint, but orthopedics will dictate that it's a similar joints. These are synovial joints, which is elsewhere in the body too. What are the most common diagnoses of myalgia? Now you take it to the joint, the TM joint. What are the most common causes for arthralgia? Arthros means joint, algia means pain. This is succinct education. Now, a patient has been grinding for 10 years. What makes this patient painlessly, happily grinding ever after for 10 years to convert into a painful bruxer, quote unquote? It's just quote unquote, painful bruxer in 10 weeks. It's not the bruxism, it is something else. It behooves us to find out, and that is the real clinician. It's not looking for just the masseter and injecting the masseter, putting a plate in every mouth. That is not medicine. And that is why medicine looks at us and laughs. And I'll show you a slide on that. Medicine looks at us and laughs because we created it for them like that. So chronic bruxism has minimal pain. This is literature now. This is literature. If you take all the audience, 78 of you, and look who are chronic bruxers, most of it might be, and most of it are not complaining about pain. So that is literature, right? Chronic bruxism, most chronic bruxers don't complain of pain. So when does the most likely to bruxer complains of pain? I'm just talking about one factor that is systemically affecting pain in a bruxer. So I implore you, it's not an advice, it's a colleague's discussion, that if you have a bruxer in pain, look for the systemic factor first before you start injecting those muscles. You can do it palliatively, but why don't we look at the systemic factor? Because that is what a physician would do. We are proud to be the physicians of the stomatognathing system. Let's take that physician word back into our realm and say, we're not drillers of teeth. We are not only for the TM joint, we are physicians of the stomatognathing system. So I would implore you to look at systemic factors. There is ample literature. So muscle, what is the most common cause of myalgia? Ischemia, muscle ischemia. It could be quantitative ischemia or qualitative ischemia. Now, along with that, now we go back to dental school for the first year and physiology and start learning something called sympathetic nervous system. We have separate lectures for this in our courses. Sympathetic nervous system. If you look at one of these, and this is not dental journals, we are looking for neuroscience, because that is where the secret lies. It's not just dental occlusion textbooks or oral medicine texts. We have to look at everything. And I implore us to look for medicine. So I looked at rheumatology literature and I said, you know what? Let's take a patient that goes to rheumatologist. This is their Bible or Gita for rheumatologists is this textbook, Kelly and Firestein's. I have it behind me. But I'm just saying that it's a 2,000-page textbook. Why? Because they are educated in that. And if a same patient goes to rheumatologist and does not complain of this, but complains of the arm pain or leg pain, do you think they're going to just press there and start injecting it? No, they're going to do blood tests. So rheumatology, this is ACR, American College of Rheumatology, and EULAR, European College Against Rheumatism. They look for things like myofascial pain is part of it, joint hypermobility, metabolic myopathies. And what do? We sit there and we look for the bite and then, how much the patient is swallowing. All good. Not saying don't do it, but I'm just saying let us be the physician of the stomatognathic system. If a rheumatologist is looking for this, we are licensed to do blood tests for these patients, and we should. There is enough evidence, and this is the entire textbook is on one thing called bruxism, because this is one of the most common things that we dentists will come across, a grinder complaining about pain. I implore you to look at systemic factors before, unless you're doing palliative care. So when a patient presents to you and says, I grind my teeth and I have pain now, how many of us have that teaching, have the knowledge to ask and look for any of those global pain conditions that the patient might have? Because without the knowledge of that, you're treating locally, more than likely that will fail. And that is the biggest thing I've seen, even with some seasoned clinicians. So what is the most common cause of joint pain? I'm looking at medical literature, not just dental, medical literature. So forget the TM joint for a moment. You look at hip joint, you look at costochondral joints, you look at the elbow joint. What are the most common causes for joint pain? Is it osteoarthritis? Maybe. So then what is the other question you asked? I mean, we all have some level of osteoarthritis. Once you reach 30 years of age, we all have some level of osteoarthritis. Can someone please mute your audience? I'm just going to mute you. Okay. And the second one is rheumatoid arthritis. Why is this important? Rheumatoid arthritis, because 1 to 2% of your general population, I'm talking about 1 to 2% of your general population is rheumatoid positive. That means out of every 100 dental patients you have seen, 1 to 2 of them were rheumatoid cases. Do we know this type of literature? And now, if you start seeing TMJ, TMD facial pain cases, is this number going to increase or decrease? I would argue it's going to robustly increase. This is the knowledge that we as pain management physicians should have. How many orthopedists do you give a diagnosis of arthralgia on a patient's swollen knee? They don't. They would say, okay, you have capsulitis, you have synovitis due to this, and then we're going to treat you this way. But when it comes to TMJ, arthralgia, that's the best we have right now. So we really are on the fundamental baseline value right now. We are not even a really big science as much as I have seen. And then there is Botox Festival, the Plate Festival. I'm just telling you, from the literature that we know, if a patient is in pain, you need to look at their systemic factors that can affect it. 1961, Dr. Ramford published this paper in JADA, Journal of American Association. And he said, any type of occlusal interference with nervous tension initiate bruxism. We know from the literature now this is wrong, but he observed certain things and he published it. 62 years later, if we believe the same thing and we treat people with the same philosophy, how far have we grown being the physician of the stomatognathic system? I implore us to stop that type of nonsense. Bruxism may be eliminated by occlusal adjustments, Ramford wrote in JADA in 1962 or 61. 62 years later, if we're still believing this, then to what level have we professionally grown? We are not becoming and maintaining the physician of the stomatognathic system. And then he also wrote the occlusion has to be adjusted to centric relation. You know what happened to centric relation, right? 1986, glossary of prosthodontic terms changed centric relation from the most posterior superior position of the condyle to the most anterior superior position of the condyle, diagonally opposite. So things in medicine change. And then this type of junk comes out. That this is 2011. I don't know what they're smoking, but literature is there, ample evidence. We cannot be the blind leading the blind. That is what is happening in dentistry. We've become cultic. Let's stop that, right? So much evidence that bite has nothing to do with TMDs. So much. And it's increasing by the day. But meanwhile, we are 63 years ago and we're stuck there as cavemen. And that needs to stop. Now, this is literature, right? This is robust literature that is now coming out. This is 2021, British Medical Journals and their associate journals. So what do we see? People grinding their teeth have some metabolic and some hormonal disturbances. That's one finding. This is new. You have a higher level of C-reactive protein in them. What is C-reactive protein? Well, we go back to the basics, to physiology and pathology in first and second year. We find out that C-reactive protein is the evidence of generalized inflammation in the body. This is only the beginning of this type of literature. And if you're getting stuck in 1961, what level have we become the physician of the stomatognathic system? We also know that when they did cohort studies, that the inflammatory markers, and this was one of my research in rats, I'm a crazy dentist, research in rats for sciatic nerve was inflammatory markers, IL-1 beta, IL-6, and TNF-alpha. Some of us might be wondering, what the heck is he talking about? Well, these are markers of inflammation in the human body. This is literature too, and this is 2021, 2022, 2023. They are at a higher cardiovascular risk. Now we are seeing some different profile of these patients. And still the jury is out there. There is no conclusive evidence of anything, but this is 2 years ago. And then literature has come out more and more on this. So these articles and the ones that have come out in sleep medicine robustly ask us to look up these patients, which we think are only grinders of teeth, and look for other markers. It might at some point save a life. So let me tell you this as a philosophical thing. In pain management, what makes medicine look at us and laugh? We have become seriously cultic. And this is the problem that we see in dentistry in general, in the field of orofacial pain in particular, I strongly believe, TMD and orofacial pain. Too many non-scientific, it worked in my hands, so therefore, why don't you try it? But we have guidance, right? We have so much guidance. In the US, in dentistry and in TMDs, there is this California cult, the Las Vegas cult, the Florida cult. There are cults, plural, and many, many cults, and then subcults. It is despicable. It is really abysmal. And I've sympathized with these cults because there is enough evidence for us to be guided the right track. Please let us follow science, evidence, and the literature. This is my mantra. And I showed you Tamasoma Jyotirgamaya for a reason, that the light of knowledge will automatically eradicate the darkness of ignorance. Let us practice as much as we can evidence-based dentistry. I'm giving you a clinical poll. You have a patient who's complaining about pain bilaterally in masseters or anterior temporalis or whatever you want to do, any muscle. Let's become the physician of the stomatognathic system. Let's start somewhere. Why don't us take a couple of patients? There are 80 people joined now. Why don't we take a couple of patients and do what we're licensed to do? Why don't we just do some blood tests, right? We'll start with the CBC with differential. Remember, the biggest reason for myalgia etiologically, if you look at physiatry literature, orthopedics, neuroscience literature, is not grinding of teeth. It is ischemia to that muscle. It could be quantitative or qualitative. And there are other factors, so like micronutrients and other factors that can affect it. Let's start with 1 or 2 patients. Let's robustly learn ourselves and teach our colleagues how good it could be to become and reconnect to become the physician of the stomatognathic system and not drillers of teeth. We can look at CMP with electrolytes. Why do I tell my students to do this? By the way, this has been adopted, at least at our program and in Rochester. I was instrumental to be part of it. If you suspect anything systemic, let's do a base workup, right? This is the clinical poll I'm giving you. ESR, these are things we forgot that we can do. If you have any doubt that there is probably some autoimmune component involved, such as rheumatoid arthritis, or any other autoimmune, please, let's order some blood tests. Palliatively, yes, I'm all for treating these cases, but do not, name them as such. TMD is the worst diagnosis that I can give a patient. I mean, what does it even mean? And then we have criteria for temporomandibular joint disorder. Can an orthopedist give you this diagnosis? When you're walking, limping into an orthopedist office or practice, and you have a swollen right knee, and after all the tests, he's saying you have arthralgia. What does that mean? Arthros means joint, algia meaning pain. Yeah, I know that, Sherlock Holmes. I have arthralgia. That's why I walked in your office. So let us take back the physician of the stomatognathic system. And this is just the beginning. And we in orofacial pain are able to guide our students succinctly. And I think we can do it more based on research, science, and literature. I think my time is up, and we have several other slides. I will be more than happy to entertain you with those at some appropriate point. It is not fair. I'm a military man. I start on time and I end on time. It's now 30 minutes and my time is up. Thank you so much for listening. I'll take a couple of questions, if any. Remember, this is not the end of this presentation, but the organizers warned me with the gun on my head saying not more than 30 minutes, and I'm okay with it. Thank you all. I love India. I'll be there in another month. I'll be there. We have amazing courses going on. If you have to be part of it, please let us know. Thank you. Appreciate it.
Yeah, Dr. D, we have a question for you. I'm sure everybody has many questions for you, but right now, this is Dr.
Sure.
Ratu. She's asking if occlusion has nothing to do with TMD, why are DTR treatments in selected cases immensely successful? Such cases, the biochemistry of a person should not be an issue. What are your views? Thank you, sir.
Sure. First of all, I've never looked into what this DTR is. I'm thinking it's something to do with occlusion. So one thing I will tell you is this. This is the first, I have a book here. There's 14 manuscripts in this. And certain programs in the US have, I mean, if you talk about literature, certain programs in the US, orofacial pain programs, have recommended this as a recommended reading. And this is not because I edited this, none of that. The next one is going to publish, this is 14 of them, with around at least 1,000 citations in this one book. And the next, this is Dental Clinics of North America that India considers very high. When I was in Manipal, we used to use Dental Clinics of North America as our textbooks. That was Physician of the Stomatognathic System. So there is at least 2 chapters here that just talk about occlusion and its current literature that's connecting or disconnecting from TMDs and pain in particular. The next one is due, again, I'm contracted and I'll be the only guest editor on that, systemic factors that affect prognosis in dentistry. It's going to come in fall 2024. There's going to be 15 manuscripts. And I've invited from world around, and there are so many of these researchers in that as well. I strongly recommend you to get a copy of either this or that or both and look up the literature. Let me tell you this. I'll just tell you one thing. There's so much to discuss, but we used to think high spots on a crown, a single high spot or an amalgam, can now trigger the patient to chew on it. I used to be taught this too in dental schools. They'll grind on those and flatten it out. You know what the literature shows on electromyogram? When you have a high spot, the muscles of mastication reflexly, I want to make the term, reflexly relax on that night when I just created that. So there's so much to learn and so little time. I don't see a shred of evidence right now that occlusal abnormalities can cause TMDs. And I'll rest my case there. You might want to look up literature, or we can actually share the literature. You can contact me. Thank you. Great question, though.
Thank you, Dr. T, for all the pearls of wisdom. And I'm sure everybody from now on will look at orofacial pain practice differently as I am doing it. Thank you so much,
I hope
Dr.
so.
T. Thank you so much, Dr. T, for all the knowledge share. And next we have Dr. Sandesh Mahekar and Dr. Ajit Shetty, sir. So I would like them to please unmute themselves. And I would start with Dr. Sandesh Mahekar, sir. He needs no introduction. Is Dr. Sandesh Mahekar there? Yes, sir.
Yeah, I'm there.
Yeah, so Professor Dr. Sandesh Mahekar is a postgraduate in TMD and orofacial pain from Tufts University, Boston, and a diplomate of American Board of Aesthetic Dentistry. He is an adjunct professor in Department of Restorative Dentistry, Rutgers School of Dental Medicine, New Jersey, USA, and was an honorary advisor to the
Sonal, just cut it out. Sonal, just cut it out. Next.
Okay. Okay, sir. Okay, sir. I know. I mean, you're one person who needs.
My time will go away.
Okay, sir. So, and Dr. Ajit Shetty, sir, also needs no introduction, but I would like Dr. Ajit Shetty, sir, also to switch on his camera, please, sir.
My camera is on.
Okay, sir. So the stage is all yours. This is an extempore, I know. So I would just like to know your both of you please guide us regarding this whole fallacies of orofacial pain practice and temporomandibular joint disorder, and the whole fallacy that occlusion is a key to it, not a key to it, whatever, doctors. I mean, we just want to listen to what you.
Sonal, me and Ajit are of the same batch, graduated in 1977. My first question to Sonal to you, when did you heard about TMD, orofacial pain and sleep apnea in India?
India, sir, say around 12 years back.
12 years back. Now I'll tell you the background, how it started. I appreciate Davis' lecture. No comments. It was way back in 1999. I was observing Dr. Noshir Mehta in Tufts University. And 99, remember. And he was treating people with sort of a muscular pain in occipital area, sternocleidomastoid and this. I was told that I had spondylosis, so I sat on the chair and I said, Noshi, just check me up. He checked me up and he gave a splint. Sooner my pain went away. Okay? So I observed him again in 2002, 99, 2000 for 2 weeks, 2001 for 2 weeks. In fact, 9/11, I just left. On 9/9, my associate was still there. 2003, I again observed him. 2004, see, I used to do, this is my passion. I mean, I just observing and trying to implement that in my patient's mouth as an aesthetic dentist. The point here was to try and relieve the discomfort pain the patient is having. So in 2004, I was sitting with Nori, who is the dean of Tufts University, Noshir and Dara, and they were talking about they're starting master's course in TMD orofacial pain for 3 years, MS course. They had 5 students, they want 1 student. I rose my finger. So they said, you got a good aesthetic practice. Why you want to join? I said, I'm not going to do orofacial pain because orofacial pain is physician job. I can do TMD where the occlusions are involved. And I want to introduce this subject in India. If my pain is gone, my 25 pain, no, I think about maybe 75 to 100 patients pain in those 5 years is gone. Let youngsters learn and go ahead with this particular branch of dentistry. And in my slide, which I prepared in 2008, talking in 2008 or 2007, the last sentence was that Davis was speaking, be the physician of dentistry. Now comes my next sentence. First, all of you listening to this lecture, answer 4 W's. Who you are. You are a dentist or you are a orofacial, you're a dentist first, or you're a physician, or you're going to sleep apnea like medicine. First, identify yourself what you want to do in future. That's what I identified in the past, that I'm a dentist. I don't want to get into those systemic diseases, etc., because I got good practice, but one should not forget the occlusion. Occlusion, but the muscles of mastication. The technology has changed from silver filling to zirconia, which is the worst material. But the muscles of mastication is the same, as we say. In automobile industry, we have gone from Fiat to Ferrari, but tire is still round. It has not become square. So first you understand whether you want to become a physician, like what Thomas was speaking, or whether you want to become a dentist, where there could be malocclusion, and that malocclusion can cause less digestion, and that digestion can cause systemic problems. So one has to go to causative factors. Second W is on whom you are treating. You are treating on the patients who come to you in a daily practice, and they have got this problem. I started my practice looking at the anterior teeth of a 21-year-old girl, totally atreated. How can it atreate this age? She wanted laminate veneers. I said, no, there is some problem. There's an envelope closure problem. Did ortho. Muscles were relaxed. She was fine. And then we did what she wanted. Third is when to do Third W, when should you do dentistry? When should you do physician? If I ask the physician, can he understand dentistry? He will not. So it is holistic approach between two of them. Don't segregate both of them. Whatever the literature can say in all over the world, human beings are different. And if you are getting the results, we can write the literature. The literature is written by all of you who has experience and experience and experience. Third is, why are you doing it? If you get the answer of why, touch the patient. If you don't get the answer of why, don't touch it. And the last come, how to do it. Then you learn whether you want to become a dentist with occlusion, etc., or you want to become a physician. Let me tell you, it's very difficult to be both. Very difficult. Physician is a medicine guy who, on palpation of stomach, tells you whether you got gas or a problem. Systemic disease are very, very important. By the way, friends, I'm sitting here talking to you. I had my heart bypass surgery just 13 days back. So I know what is myalgia pain, I know what is statum pain, I know all this pain, etc. But friends, being a basic dentist, I will not discard any changes into occlusion which can affect the muscles of mastication, which can give some type of discomfort, some type of discomfort. You can't say pain. I'm not talking, my pain is not orofacial pain. My pain is the pain what my patient tells me. So once I do that, after that, if the patient says, I'm still not happy, I have got a girl called Dr. Ruchika Sood, orofacial. I know my limitations. So friends, my last sentence is, you should know a limitation, and the good doctors know what not to do.
Yeah, that's an insightful thing, Doctor. And Dr. Ajit Shetty sir is also there with us. So I would like Dr. Ajit Shetty sir also to throw some insights on the same.
Yeah, hi guys. It's indeed a awesome platform, and I'm here 3 lectures as yet. And Dr. Davis Thomas seems to be somebody approximately in our age group, maybe a little younger. And he's trained in India. And one thing that I really feel is, I don't know what is your target audience at this moment, 80 or 100 people that are there. How wise are we? Because let me speak about myself. When I graduated 45 years ago, we did not know anything about occlusion. And as I see, even the Indian context, even today, no faculty is here who's teaching the O of occlusion. So this is what we really know about. Now, those of us who have experienced it, I got into occlusion because one day I was a keynote lecturer at an implant conference, because I happened to have, along with Sandesh, brought in aesthetics and then I brought in implants, then I brought in lasers. So I tried to be there at the cutting edge of dentistry, so to speak. Having said that, a lot of us here don't even know the occlusion. And I've been chasing occlusion very passionately for the last 25, 26 years. How much do I know? I'm still at the O. Okay, let me first be absolutely modest. Yeah,
Agree.
I really like about Davis's concept is, may I call you Davis Thomas, or do I call you Dr. Thomas? So,
Oh, not at all. Dave is fine. Davis is
it's fine. Okay. So the idea is that we have, I mean, what I agree with Sandesh is that we have done a lot from occlusion. I can't share, and I will need a lot of time, where we've seen the whole body musculature rearrange itself by giving orthotics and working with it. But yes, I have not been looking at the systemic angle. Today, yours is insightful in that aspect. Ki now I have one more kida to check up. Ki bhai ye kya hai? What have I missed? This is my takeaway today for me. I'm excited and I'm looking forward to see what all factors I have been missing. But yes, we have done a tremendous amount of work, and we have done it with basic dentistry. So for those of you who are not as initiated with reading, I mean, most of us don't even know how to read good IOPAs. Let's be honest. OPGs are something which are still foreign to most of our country. So when we talk about MRIs and all that thing, by the way, my academic qualification is an MDS in oral radiology and medicine. I don't know how to read an MRI, I will confess. Maybe I can combat you with OPGs and stuff. Again, OPGs came after I graduated. But yes, since we have a machine, since we know how to read an OPG or CBCT, it's another story. So I think we need to cater to an audience who is young, who's not so knowledgeable. Forgive me, my audience, if in case I am insulting anybody by saying what I'm saying, but I heard some of the questions. So I think I'm not completely off. Those of you who are more educated than me, I humbly bow to you. But yes, this is something which is exciting because the power of occlusion needs to be extremely, extremely well understood. And I am firmly of the belief that the younger generation today, the reason that most of us, see, we are about 50 years, 45 years in practice, me and Sandesh. Okay, that's a long time. And there are so many of people who are senior to me who have finished their practice, who have gone to their heavenly abodes, and who did not know anything about what is articulating paper. And the patient survived and everything happened. Having said that, is it important for me? Critical. I mean, when I say me, I'm talking on behalf of all of us here. Yes. So who needs to teach us? Okay, so starting from there is where we need to get, and I would suggest that all of us are always ready to help. Sandesh started the movement for aesthetic dentistry. I started for implants, and we all have been working together in all the field. I offer whatever little knowledge and information I have to spread the information, and I think attack the faculty today, because the examiner, neither the student, went to the last chapter in books of perio, prostho, restorative dentistry. So we never went to occlusion. So all of us are happily graduated out. I think that needs to be looked at. A good introspection is needed. Yeah.
Yes, that's nice.
I'm open to it. Sorry?
Sonal?
Yes, sir.
No, no, good. Any other questions you have or you want to?
Sir, so no, I just want your inputs on the whole scenario, sir. So what Dr. Ajit Shetty left, the last message, what he said, who are the right people to teach? Because, sir, you've been a faculty in many of the universities now.
So my concept of learning, when you learn dentistry for 4 years, 3 years amalgam, all the stuffs we have learned, it doesn't go in my head. How come a short courses can make you an expert in the particular subject which was not there in your dentistry only? So if someone wants to become like Dr. D or someone like you, they should follow their path. What did they do for so many years that they can speak so confidently? Unfortunately, what is happening, I'm conducting courses. I did it at New York University in India in 92. And then I saw people writing aesthetic dentistry NYU. I said, "Arey yaar, I got it as a CDE program." I cancelled that. I cancelled the international. I had got Buffalo University. I had got Baylor College of Dentistry. I had got NYU, even including Tufts was with me. But then people were misusing that international certificate as if they are internationally educated. Now, that's it, misguiding the patients and other dentists who have learned better, but they don't have international certificate. They feel that they have been cheated. International education is more important than the paper on the wall. So I believe that youngsters should get more knowledge on a particular subject. What I did in aesthetic dentistry, what Ajit did in implant, we did anterior, came back, tried on patient. We did posterior, came back, tried on patient. We did laminates, came back, tried on patient. So we did one step at a time and tried on patient, became a master of one subject first, then got into second subject. Today, as David said, I'm telling you, the reason I got this TMD and I wanted people to learn, there are hundreds and thousands of patients. Patients don't know. When I see their adhesion teeth, I said, "You got a pain in shoulder?" They said, "Yeah." How do you know? Your teeth are telling me. So the point here is, by the way, these I'm treating, but I could not treat full. David, Ruchika, I know orofacial pain. I did my thesis. But then passing and getting thesis, like Ajit said, being a radiologist, he can't read even MRI. I can't go further on this because I've got sufficient knowledge of other subjects. But what you mentioned is so true. But people should take time to understand and slowly implement and see the results rather than claim themselves that they're pioneers in this, they are this and this and this. That's number one. Second, I believe the best medical doctor looks at the pulse, do the physical examination, and then gets the MRI, etc. done. But I've seen people doing so-called TMD, orofacial pain, etc., getting all the different gadgets, and from the gadgets try to diagnose. It's the other way around. Friends, I gave 40 lectures on TMD, on T-scan. I love that T-scan. But I took one-on-one lecture understanding from Robert Kurtzen. And then when he started grinding the teeth, I said, That means reduction of the enamel is absolutely absurd. And so your T-scan is not working in the United States so much because tufts we don't have. We deprogram and then we check it up if it is necessary to touch. So T-scan is nothing but an electronic articulating paper. So one having gadgets and telling people that I'm TMD specialist doesn't go well. Thomas will agree with me, the clinical examination, history taking will give you diagnosis and planning, and then to confirm that diagnosis and treatment planning, you then treat the patient. So friends, don't fall to the industry that if you get this gadget. I visited one jaw tracking, he said 30,000, I said, nahi chalega. You're telling me to buy something to diagnose which muscle is the problem, which I can put a finger and find out which muscle is the problem. And then give me those figures and this and that. I said, first become a clinician here. First become a diagnostician. Then you learn what disease can be treated with what treatment, whether it's a physical treatment in the mouth or is a generalized treatment in the systemic problem. So that combination, David, I feel you take so much lectures, that combination has to be taught to the people that see, you understand the subject first and then decide to call yourself as a specialist. And by the way, before I end this answer, do not call your specialist in TMD orofacial pain in India. Dr. Sandesh Mayekar has gone to Consumer Court when he wrote as a specialist in aesthetic dentistry. The court said there is no post-graduation in this subject in Dental Council of India. You can't call you as specialist. You call as a special attention to these subjects. Thank you.
I just want to add one sentence. I tell my students, by the way, Sandesh, that was great. And Ajit, thank you for embellishing on that point as well. I see a couple of my students on the screen. I just want to say hello to them, Ruchika, Sonal, and then I see one of my colleagues from American Academy. Seema is on the screen also. Hello, Seema. Just one point and I'll stop. I tell my students the best scanner is between your ears, around 6 inches inside and about a couple of inches above, and that's called the brain. And I'll stop there. Fantastic meeting. Thank you. And I'll mute myself because I have to go to 2 other meetings after this. So if I don't disappear, I'll be listening on the background. Thank you so much. Appreciate it.
Thank you so much,
Thank
Dr. T. Thank you so
Yeah.
much. So continuing with Dr. Ajit Shetty, sir. So
Yeah,
now
I just want to add, Sonal, a couple of years ago when composites came into the country, the whole world of MDS conservative dentists said it will not work, that it will not survive on posterior teeth. I have been ridiculed on many a podia, and everybody said that I had very high testosterone levels and that it was all coming from there. guess what? There were conferences where I told, okay, I will do half the mouth with composites. And I'm talking about olden days. I'm talking about 25 years ago. And I said, you choose the lesser half and do it with your amalgams and let us see which lasts. That started then. Then in 1991, we started sharing information or teaching about implant dentistry. When some of the universities asked me, are you sure you're not teaching us some quackery? Will these nuts and bolts and screws actually do the job? And then came a time when aesthetic dentistry or composite dentistry, there was everybody claiming to have it as a part of their subject. Same thing happened today with implant dentistry. Now it is prosthetics and implants, perio and implants, so and so implants and implants. So what I'm trying to say is you have started a good move. Okay. And Sandesh and I are not getting any younger in age. So the best that to do
I
is.
got 20 years younger. This is my bypass just now. Okay.
Oh,
Same you.
sure. I'm just 2.5 years older to you. So that's good enough. So having said that, we are ready. We still have only one goal in life, and that is to share whatever information that we have. I don't say we're teaching. Mind you, my words are I'm here to share what I have. And this is a commitment that we do. And this is what we can available all the time. If there are any other questions, great. Let's
Well,
continue.
I want to add, I don't know the youngsters so well, because most of the time Ajit, you and me are on the stage rather than mingling with youngsters. I just want to tell youngsters, you have so much of scope in this particular field called orofacial pain. You got so much of scope to do good dentistry. And I'm talking, Sonal, let me know, those who are attending here are dentists or they are just now doing only orofacial pain?
No, sir. They are most of them are general practitioners or maybe specialists in MDS or anything like that. And some of them, few of them are orofacial pain practitioners.
Okay, so my suggestion is the first chapter, the first thing, as a dentist, you understand the occlusion, what Ajit was saying. In fact, Gordon Christensen, I told him, sir, I'm doing TMJ in this. He tapped my side, I'm practicing for 40 years. If you understand TMJ, let me know. Because what he said was, TMD is a dynamic issue. It is not static. So there are guidelines. There is no rule. So the guidelines are that. So my problem is that understand the occlusion. If you have learned your second BDS anatomy, and if you know the anterior cingulum fossa, if you know the importance of anterior guidance lateral excursion, if you know that occlusion very well, you will not give muscular pain to the patient, or you can't do anything to the disc and other stuff. What we are doing about wearing teeth, full mouth rehab, I'm still scared of so-called full mouth rehab because I don't know how the teeth are going to meet each other. So point is, first understand dentistry and occlusion, then understand if there is a malocclusion. Now there is a difference between malalignment and malocclusion. The malocclusion is where when you try to close the mouth, there is some touching and moving, etc. Is malocclusion, and most of the malocclusions are iatrogenic we create because our technicians will never give that angulation of fossa and inclined plane contact. Secondly, one should have a basic knowledge. If you want to grind any tooth, it has to be only fossa and not the cusp. You should know what should be the so this is basic dentistry, those who are doing dentistry. Once you understand this, then you go ahead and understand the implication of this on the muscles of mastication, which includes, masseter, pterygoid, all this sternocleidomastoid, trapezius, all the muscles, how your mandible is been held by all the muscles. And if there's one problem, which muscles can create problem, how it will affect the disc, understand. Then you decide, oh, I want to refer this patient to the specialist, maybe Sonal. So go with the patient to Sonal or call Sonal to your clinic, understand what the problem was, that is correct diagnosis, understand the treatment what she gives. So slowly you try to implicate the same thing to the next patient. That's how you start learning clinically. Getting certificate and not practicing. You know, Ajit, if you remember, you were my business manager for IDA Journal and I was editor. 1991 September issue of Journal of Indian Dental Association, I've written who is specialist. Specialist is the one who do one job 10 times a day rather than an MDS do one job, that job once a day and other time he does general dentistry. So specialist means if you want to call specialist in future of orofacial pain, then you should be concentrating from going from 1%, 10%, 20%, 50%. Have patience. Money will come. Money will come. Have patience. And the moment you hit the top line that you are the specialist patient referral, friends, sky is the limit. You don't know how many patients come to our clinic from different parts of the country. You don't know how many patients are coming from different dentists also. And the last thing I want to tell Sonal, whatever treatment you give, there should not be further damage to the hard and soft tissue of the patient. It should be reversible. So don't damage patient's tissue personally. And the most important thing, will you do this treatment in your mouth? Will you do this treatment in your parents' mouth? Will you do treatment in your family members' mouth? Yes, do it. I started TMD in 1999, was first patient is me. I understood what the problem was. And then I went ahead. And then I realized I can't solve all the patients. Then Ruchika Sood, very close friend of mine, according to her, because of me, she did this. She does the further part of it. So what we do at the end of the day, our motto should be the benefit of the patient and not the motto that I can do everything. Share, stop to the your expertise, share the other expertise, share the third expertise, and all three of you, TMD, orofacial pain, sleep apnea, all three of you can give a patient a beautiful life. Thank you.
That's a wonderful synopsis, Doctor. Dr. Ajit Shetty, sir, do you have any cases which you can share with us, like, some experiences with patients or maybe something? I know it's very impromptu. I'm asking you something out of line.
Let me see. I don't know how to do it.
Sonal, Anna, we'll have a special session on this.
Sir.
No, there's no point in showing half-heartedly. Yeah. If you want to show, you have to show full-heartedly the case. Both of us thinking of, I also wanted to put the slides, but then maza nahi aayega, baad mein kabhi baat karenge to. So both of us will come back to you what the best we are on, and we are definitely help you out. Thank you very much, because I don't time myself up.
It was very good of you. After surgery, you're still with us. Like, you're a source of inspiration, I would say. When next time, even if I have a headache, I will never complain now, because I have seen you standing here after 10 days of surgery and you're here like delivering a lecture. So it's a big inspiration. So
let me tell you, I had my surgery on 23rd. Okay.
So that's what I'm saying, doctor.
When I went to the anesthetist room, मुझे pain हो गया. He was talking, Thomas was talking over the pain. I got a pain when my anesthetist put the first needle. अरे यार, pain हो तो ऐसा. That was my dialogue. When I came down to ICU, I became so friendly with the staff, etc. I said, I'm enjoying. I gave a cake and I said, I enjoyed my ICU stay. Wow. Was I happy? Was I not getting pain? Getting pain. This. But I was diverting my and smiling and enjoying. So according to me, I'm not talking about the theoretical part of stem, brain stem, etc. According to me, pain should not reach here. Pain, I diverted. Just now I was sitting when Thomas spoke about statum. I got a little bit of ting pain in my muscles because of first time I'm taking statin. So the point here is, please enjoy what you do. I got pain, I enjoyed it. Today I'm speaking to it, I'm enjoying it. And this is what your life goes in. I mean, I myself, Ajit is saying, today I showed in the picture, this jacket is not for this course. I just did a video for my whole family is in Mexico. I'm staying in Taj Lands and Hotel with my mother. Why? Because I want them to be happy. So I am here. I did a video for my newly married couple to wish them, me and my mother, and shot this. So I made a jacket and it's sitting in front of you. The point here is very simple. अरे यार enjoy करो जो भी सीखते हैं. Enjoy your work will never work. So take this word, me and Ajit, we are enjoying what you do. We are not here to earn money. Money had come to us. Money, whenever we didn't have money, that also we enjoyed the work. So enjoying is the most important aspect of success in any profession, vocation, and life.
Yes, so that's like a pearls of wisdom that you have said. So, Dr. Ajit Shetty, sir, to conclude this whole session,
May I
one
just
statement.
take one statement? That's it. All you guys out there who are just starting on life, don't be in a hurry to call the next scan operator or scan seller. Don't try to do the T scan or any scan is not magic. The magic is the education about occlusion. So when you see that point, you have to know, is it a high point? Does it require equilibration? Does it require to be looked at? Does it require to be looked at right now? The DTR business, in my humble opinion, should not happen on first day, first show. There is only 1.5 millimeters of enamel, and that is designed to last 140 years.
Agree.
That has to be precious. So all you guys first learn occlusion, understand everything about muscles, about teeth, about anatomy, about movements, and only after that, think about buying gadgets. Gadgets will not make the man. The man will make gadgets and you will learn how to use it. Yeah, all the love. Thank you so much for...
One second. Anna, 1 minute, last sentence. As she said, like everybody should go fast. Let me tell you, child is born only after 9 months. You can't tell your gynecologist, I want a child after 3 months. Once the child is born, he first rolls, then he crawls, then he takes the support of somebody, then he walks, then he sprints, and then you go marathon. The same way applies to all natural stuff in this world. So nobody in this world can become a superstar in first 5 years. Experience matters a lot, and nobody can take experience what me and Ajit have for 45 years. Today, actually, we completed this year is 50 years of our dentistry joining college. Nobody can take the experience.
Congratulations, Dr.
And experience is something which is not written in literature. That's very important. Okay.
Thank you so much.
And lovely talking to all of you. Please become a good dentist and take care of your patient. Think the benefit of patient all the time.
Thank you.
Yeah, this was so
God will
insightful.
take care of you. God will take care of you.
Yes, God is there. God is there. So thank you so much, and I'm glad. I'm overwhelmed that you two could join today, and all these pearls of wisdom, the young generation, or forget about young generation. Now, after being in 20 years into practice, I feel it's my day one today. So this is like a change in practice, change in my scenario. So thank you so much. Thank you so much. This was really wonderful. And we have the next speaker. So if you can wait, we will let Dr. Seema Karu.
I think I'm getting out of it. I have to go for my exercise and all. Okay, thank you.
Yes, that's also all right. So, but thank you so much. And it was really insightful. And I mean, I would say I'm blessed that I got an opportunity to talk to you all, converse with you all. As a student, I'm always hungry for knowledge, but this is like wisdom which will be taking me forward now. So thank you so much, sir. And thank you, Ajit Shetty, sir, and Dr. Sandesh Mahekar, sir, the god of dentistry, as I call them always. So thank you so much for being a part of this Nopcon. And you all have really, you are the patrons here, and you all have really made this whole conference, given a directive, I would say. The whole agenda is now having a direction. There is a torchbearers, and they have given us a direction to follow. First, become good. Actually, I would say you all just gave us a guideline to become humans first.
Yes.
Empathize with the patient. Forget about everything else, money, everything else is secondary. And yes, if I don't do it on my mother, I don't do it on my patients also. So thank you so much, doctors. And it was really enlightening to be a part, to be talking to you all. I'm humbled, in fact. Thank you so much. Thank you.
Thank you.
Thank you.
Bye,
Sorry,
Anna.
Seema. Bye. See you. Take care. I'm going to hang on and listen to Seema and then I'll leave.
Okay.
Thank you.
So we have the next speaker is Dr. Seema. Just a second. Dr. Seema, if you could unmute yourself.
Yeah. Hi, everyone. Yes, I did unmute myself.
Yes. So Dr. Seema is Seema is an associate professor and chair of division of oral medicine and orofacial pain, TMD, Department of Maxillofacial Diagnostic Science at the University of Connecticut School of Dental Medicine. As course director and one of the two participating board certified orofacial pain specialists in Connecticut, she leads the clinical service and academical curriculum for orofacial pain and TMD for pre-doctoral students and residents at the school. Dr. Kurup was selected to be the program chair for 2025, is selected rather, annual scientific meeting of the American Academy of Orofacial Pain. Oh, that's a great deal, doctor. By the president of Council of Members of AOP. She is the chair of mentorship committee of AOP, and she holds dual fellowship of AOP and American Academy of Oral Medicine. Dr. Kurup is an active member in 9 national, international, dental and professional organization and several publications, and is a peer reviewer of 20 scientific journals. My God, that's a lot, doc. Prior to coming to US, she has an extensive career of over 13 years in academic and in specializing in oral medicine and general dentistry in India, Middle East and Far Eastern countries. So let's welcome Dr. Kurup here, and I can go on and on about her because I've got a good biodata about her, and that's almost 2 pages long. Let's continue with Dr. Kurup. Let's listen to what she has to say about orofacial pain practice. Welcome, Dr. Kurup.
Thank you. Thank you, Sonal, and thank you, organizers of Nopcon. So shall I just go ahead and share the screen first? How do you want me to do that?
Yes, you may share your screen, the green button
Okay.
now.
Can you see that?
No, now we can see orofacial pain diagnostic, a sneak peek. Yeah. Thank you,
Yeah.
doctor.
Okay. Well, at the beginning, I want to say thank you again to Nopcon. And I was just listening in to the previous speakers, Dr. Davis and Dr. Mayakar, Dr. Shetty, and it's interesting for me that I was wondering what I should focus on while I was listening to the conversations that were happening. So I just want to go ahead and say that what I'm planning to do today is just a sneak peek. And when I say a sneak peek, it's an ocean out there. There are a lot of different thought processes, I want to say, when it comes to orofacial pain and TMD. Like you heard, occlusion, not occlusion, maybe psychological considerations, it's in the head, sleep, so on. So a lot of these thoughts that go back and forth between people, between clinicians. So heads up to everyone, this is a sneak peek, and I was told that the audience is predominantly general dentists, and then there are a few specialists and maybe some faculty as well. So bear with me if some of the things that you hear are things that you know already, and some of the things are controversial, but then everyone is entitled to their opinion. So here we go. The objective here is, I'm just trying to minimize. Yeah. So the objective here is, at the conclusion of this presentation, you, the audience, should be able to understand what the orofacial pain umbrella is. Now, there's no term out there that's called an umbrella. This is something that I call it as such because there are so many things that come under that big name. And so the second agenda would be to sort of recognize what diagnostic criteria for TMD is. This is to say that you, the general dentist, should have some idea or should have a fair experience or exposure to how to diagnose that TMD. Like Dr. Davis was saying, what is TMD? TMD is also an umbrella term. There are so many subsets to it. You need to know what you're dealing with. Rather, you need to diagnose what it is before you even think about management, and then recognize the broad diagnostic process in a patient with orofacial pain symptomatology. And what I hope to do is maybe have you come with me on a journey with a patient, maybe like a case presentation, and broadly formulate management options. As you saw from the title from my slide, it's mostly diagnostics, but I do want to touch upon broadly on some management options if time permits. Okay, so there are some questions that I want to throw it out to all of you. Again, these questions are, some of them have very simple answers, some don't. Many of you may already know the answers, but keep these questions in mind while we go through this talk today. And again, like I said, the focus is for general dentists. So what is orofacial pain and why should I know about orofacial pain? I don't want to talk about the definition of orofacial pain. All of you know what it is. You can always pick it up from Google, or even if you have done the AOP course, you would know what it is. There are textbooks out there. Simply put, it is assessing, diagnosing, and treating patients with those conditions, that is, including but not limited to temporomandibular disorders, jaw and oromotor behavior disorders, neuropathic, neurovascular, sleep, and all of those chronic conditions that can affect the orofacial head and neck pain. And I have to tell you that one of the things that made me really happy in March of 2020 was that the orofacial pain, the specialty was recognized as a specialty by the ADA. And this happened during the time of COVID. So I was happy that at least there was some light at the end of the tunnel, during those dark times. And this slide here is just to show you, how much of lacunae there is when it comes to just, the patient's access to care when it comes to orofacial pain, and also the number of orofacial pain specialists that we have. And this is a statistic from United States from 2019. And obviously we may or may not have a statistic from India, but I just wanted to show you that there's so much of lacunae and a need for people or specialists to come out and treat these patients because of that, and that's one of the reasons actually I signed up for this conference, because I think it's a nice topic to have with so many learned speakers contributing their little piece, and you, the audience, think about all of these things, assimilate it, synthesize the information, and make your own educated decision. If you look at this slide, you may be wondering, what is this? This is such a busy slide. And I just want to use my cursor here and point out to the leftmost icon. What you see is the logo of the American Academy of Orofacial Pain. And this is the academy that worked for getting the field of orofacial pain recognized. And then you have the American Academy of Craniofacial Pain, which is also an proficient, very highly active academy that wants to educate people. So one of the reasons I shared this slide with so many of these icons is because there are so many of these associations that put in or share their knowledge about orofacial pain and or TMD for the audience. And it is, again, I wanted to bring it to your notice that it's you, the audience, who needs to pick and choose, decide what it is that you need to do. And like the previous speaker said, not go after money or not go after that particular device or what have you. And if you look at, there's the contribution from the International Association of Study of Pain. They have these special interest groups on neuropathic and neurovascular and so on. There's the INFORM, which is an international network that came up with the diagnostic criteria for temporomandibular disorders. There's the National Academies of Sciences, Engineering, and Medicine, which in 2020 came up with a consensus paper, and with a lot of specialists from the US and outside the US, extremely focused on TMD. And I think this was good because it brought in a lot of coverage and exposure to TMD as a whole to even practitioners within the US. And then all of you are probably familiar and know about Dr. Jeff Okeson, sort of the founding father for orofacial pain and TMD in the US and obviously across the world. This is a textbook that offers a guideline for orofacial pain from the American Academy of Orofacial Pain. And then you have the Facial Pain Association, which talks or dives deep into neuropathic pain and neurovascular pain. The International Headache Association also, or society, also has their input on headaches and its contribution to orofacial pain. And then you have a TMJ association, which is actually a patient advocacy group, and that itself is contributed a lot of information. And like Dr. Thomas was saying earlier, there are all these cults out there, and individuals possibly who also advocate orofacial pain as a whole. So again, I don't want to sound like a broken record, but with so many associations and so many thought processes, I would sincerely advise everybody to really take educated guess when it comes to decision making. And why should I know about orofacial pain? So you, the general dentist, have a responsibility to treat. Why? Because you are one of the first clinicians that patients may present with a problem involving oral or even dental issues, and that could have a referral pattern to the rest of the face. And dentists must responsibly treat. And what do you mean by that? Because if you are not responsible or accountable for your actions, you could be inadvertently causing certain types of orofacial pain. Maybe that occlusal, recalibration or rehabilitation entire, would you do that for your mother versus would you do that for your own patient? So it's extremely important that you're responsible and accountable for your actions. And dentists are often a part of an interprofessional team that contributes to holistic management. And I believe in this sincerely because a lot of times, you may notice something, but you may not necessarily refer your patient for that continuity of treatment simply because that's not your field. But recognition, being aware of it, and providing that access to care to that patient, referral to the right person is absolutely necessary. That brings me to the International Classification of Orofacial Pain. This is fairly recent. As you can see, it's from 2020. There are a couple of subsets here. And the first and foremost, what you can see is the orofacial pain attributed to disorders of dentoalveolar and anatomically related structures. What does that mean? It's basically dental, oral mucosal, salivary gland. And that's what you as dentists do. So obviously, that is a big component of orofacial pain. And moving down the list, you can see there's the myofascial pain, TMJ pain, and pain from nerves, pain from as a presentation of a headache, idiopathic orofacial pain. Many of you may know about burning mouth syndrome. And then there's the psychosocial assessment of patients. Previously, orofacial pain or TMD was they had it classified it as axis 1 and axis 2, where axis 1 predominantly dealt with biology or pathology, and axis 2 dealt with psychosocial or something up in the head kind of a situation. So bringing all of that together, what we need to remember that it's the body, it's the brain, and so anything that can contribute to a pain process is to be considered when it comes to orofacial pain. And that brings me again to the biopsychosocial modeling of pain. As I just mentioned, the brain. So as dentists, when you look at into the mouth and you see a cavity, you know what is to be done. You do a class 2, class 3, you go ahead and restore that tooth, and you have addressed the problem. Meaning what you have done is you have followed the biomedical modeling of pain, where you have identified a pathology and you have addressed it. Whereas with orofacial pain, it's more to do with the biopsychosocial modeling of pain, where all three of this have to go hand in hand for a patient to be absolutely healthy. And this modeling conceives the individual as a complex unit, and you really cannot separate the body from the mind. And this is where I want to, take Dr. Mayakar's comment, because he mentioned that he's just come out of a major surgery, which is commendable, and that he's right now in a hotel room wearing a jacket, a blazer, what have you, and trying to make people happy. And I was just thinking to myself, what he's doing when it comes to pain is that he's actually using distraction coping. He's actually coping with the situation in an excellent way to get over his pain. And that's exactly what you can use as a tactic for some of your patients. And I'm highlighting here some of your patients, especially those patients who are having chronic pain. And that's how this biopsychosocial modeling of pain can work, not only in terms of diagnosis, but also therapeutics. And then you have this slide here where I wanted you to look at that, the picture on the right side. When it comes to chronic pain, it's important for you to know that you should, in fact, know what type of individual has the pain rather than the type of pain the patient has. Now, not so in dentistry, because when it comes to dentistry, it's all mechanistic, meaning you know the problem, you address it. You don't necessarily need to know what that patient is all about, what their job is, what their social background is, nothing of that. But when it comes to chronic pain, there's a subtle difference here, because you are not just addressing the disease, you're addressing the illness. And illness is different from disease, and it's probably invisible. Patient, what you may see, may be smiling and focused and say they don't have that much pain here or there. Oh, I only came to you for my dental work and so on. But what they may be having is widespread pain, migraines, radiating, stiffness, and so on. So in order for treatment to be effective, it must be directed towards the source of pain and not the site of pain. So citing the example of the dentist again, and I was talking to you about the cavity. When you see the cavity and patient has pain, you know that that's the source of pain. Again, most of the time, that's the source of pain. And as dentists, you go ahead and you plug it in, you restore it, composite, amalgam, does not matter. You address the source of pain and the patient feels good, patient is happy, you're happy. But when it comes to chronic pain patient, many times you may look at a tooth, patient says, I have pain in that tooth, but you don't see an obvious reason. You don't see a rationale for that pain. You don't see a cavity. You may take an x-ray and look at it and see, oh, it looks fine to me, but there could be something else going on. And sometimes, and I'm saying, I'm not pointing fingers here, but sometimes doctors end up doing treatments that are not really necessary. And then patient, say, for example, you provide a root canal for that patient, assuming that maybe there's something there that I missed. And patient comes back to you and says, no, the pain still exists. So at some point in this pathway, you have to kind of take a step back and look at that situation all over again, because you may not be looking at the the source of pain. You are probably only seeing the site of pain. Okay, and that's why I have this picture here from Travel and Simons. Please have a look at this book. It's an excellent book, which gives you a lot of information. So if you look at this situation, there is a trigger point. The X mark is a trigger point in the posterior temporalis, and that can actually radiate pain to the teeth. And that citing that example of the teeth or tooth that is painful, but you don't see an obvious reason, what you can see here is the source of pain is actually the temporalis muscle, and it is not the tooth per se. So to me, orofacial pain is a differential diagnosis, as a differential diagnosis is a thinking sport. And you, the dentist, if the only tool you have is a hammer, as dentists, you may be having a mouth mirror, a probe, or a burr, the whole world starts looking like a nail. And, the other day I was listening to a talk by one of the eminent orofacial pain specialists, and he was telling that many of us as dentists, rightly so, we look at the burr, the different types of burr. We know that this burr we use for this one, that burr we use for this, but we don't necessarily focus on the hand that is holding the burr, or the kind of pressure that you apply when it comes to doing a treatment. That's just again citing an example to tell you that please take a step back every so often and see what you're actually doing for your patient. So what is TMD? And all of you will know what this is, but just some questions for you to think about. I mentioned the National Academies of Sciences, Engineering, and Medicine that came up with that consensus paper, and they found that it was a set of diverse and multifactorial conditions put together, almost 30, if I may say so, highly prevalent, significant public health impact. And it's also one of the most common musculoskeletal cause for orofacial pain. And you know that pain is one of the primary reasons why patients come to you. In fact, when I was practicing in India, many times, I've noticed that patients who have pain or, in other joints, their focus is on other joints, and probably that is justified, because if you can't move your hand, you're not functional in society and so on, whereas the pain in the jaw is vastly ignored. So in that sense, this kind of awareness is good. And predominantly, pain as a primary clinical manifestation is also accompanied by limited mandibular motion, tenderness to palpation, joint sounds, and disc displacements. Those are the clinical symptomatology. But over time, what happens? It leads to muscle tension, ear pain. In fact, 40% of my referrals here come from ENT doctors, because patients have ear pain, ringing sensation in the ear. Sometimes they complain of fluid sensation in the ear, and discomfort, altered balance, which could be another reason altogether. But they have a host of symptoms primarily focus on the ear. They go to the ENT and they say that, no, this is nothing to do with the ear, go to the TMJ doctor. And then patients come to me. So eventually what happens is they have headaches, parafunctional habits, increase in stress, depression, and obviously poor sleep. Someone who is having pain, I suspect, would not sleep well. So how do I diagnose TMD? And this is where I want to bring in a patient. So our patient today is Sandra, 37 years old. And if you look at her chief complaint, she has jaw pain. She points to both her joints. It gets worse with chewing and stress, gives her headaches. There's an occasional burning sensation in the lower left side of her mouth, next to the tooth where root canals and extraction was done. She knows she grinds her teeth. She's had migraines from when she was a teenager, and her sleep has changed a lot lately. So there's some background information. History is important, as Dr. Mayekar said. Spend a lot of time. For every orofacial pain patient, I literally spend 90 minutes or up to 2 hours just collecting history. And sometimes it may also have a little bit of clinical exam, and that could also be more extended as well. So history is important. Sandra is a software engineer. She's had some recent headaches. Family history is non-remarkable. She's married, minimal exercise. Her husband reports that she snores. So you do the extraoral examination, and we find that facial symmetry is within normal limits, slight forward head posture, and probably from having been exposed to some orofacial pain lectures that forward head posture is critical. Flexion, extension, side bends are slightly limited. She has no lymphadenopathy. Cranial nerves are within normal limits, some tenderness on palpation, trapezius, and all of those neck muscles. And so, since you already heard the patient's chief complaint, you know that probably she has TMD. As general dentist, it's now your call to decide, should I be doing a screening instrument, or should I go ahead and do a more confirmatory diagnostic modality? And you, the dentist, you, the dentist, can decide to do that screening instrument. And I strongly recommend that for every patient that comes to you, irrespective of whether they tell you about a TMJ problem or sounds or whatever, do a screening instrument. And this is one of the simplest ones out there. Just a couple of questions asking bare minimum. But if you do get a yes to all of these questions, then at that point, you can decide, should I be doing a confirmatory? Am I interested in continuing and trying to figure out whether this patient has a TMD problem, or should I be referring this patient to a specialist or someone who is more interested? That is your call. Now, if you do decide to do a DC-TMD or an advanced modality confirmatory test, you have the symptom questionnaire that the DC-TMD provides. And if you look at this, it has 4 sections: pain, headache, joint sounds, and lock of jaw lock. It can be a closed lock and an open lock. Now, why am I focusing on a diagnostic criteria? Again, just like that busy slide in the beginning that I showed you with contributions from so many associations, academies, individuals, cults, so to speak, you can have any and different type of diagnostic modality that you want to adopt. I just choose the DC-TMD simply because I find it fairly simple, and it also gives me the diagnosis fairly easily. I'm not saying it is, it's the best out there. Everything has a scope to improve. Just as all of us in life, we have a, scope to improve, do better, change, because change is the most common thing. So again, I just want to reiterate, this is just one criteria that you can use in your clinical practice if you decide to do an advanced or confirmatory TMD criteria or examination. So once you have all of that history that you collect with this symptom questionnaire, you move on to the examination. And again, DC-TMD offers you an examination form, which in the interest of those who are not well-versed, I just want to go over it, that you can see that they ask you about the location of pain, location of headache, incisal relationships, opening movements, pain-free, maximum unassisted, assisted, otherwise there's active and passive movements, the lateral and protrusive movements, joint sounds, locking, palpation pain, and palpation of supplemental muscles. And of course, you want to have a final diagnosis, which is kind of broken up into a pain diagnosis and intercapsular or internal derangements. And as you can see here, I've plugged in some of the findings that we got from Sandra. And if you notice, her maximum assisted opening is 44, which is not limited, because based on DC-TMD, anything less than 40 is considered limited. So then, you go ahead and do, I just want to focus predominantly on the muscle and TMJ pain with palpation. So what you can see here is that I found Sandra has pain. It is familiar. And in the temporalis area, it's familiar to headache, and there was no referred pain. What does this mean to you? Because based on DC-TMD, it's important to be able to replicate the patient's primary complaint. So during clinical examination, if you're able to replicate patient's pain, which happened in the last 30 days, you have familiar pain. And if that familiar pain is familiar to the headache that she experiences in the temple area, which is the head, so obviously it feels as a headache for the patient, then we have a possible differential diagnosis or a diagnosis of headache that is attributed to TMD. So that pain, which is replicated with some functional or parafunctional habit, could be diagnostic. And so Sandra also had familiar pain in the masseter. She also had familiar pain on the TMJ's lateral pole palpation. So this kind of is building up to a, fitting into the criteria. Now, please note this, for the diagnostic criteria to be complete, you have to have a positive history and a positive finding during clinical exam, meaning a positive familiar pain during clinical exam. And this is how you palpate across the temporalis and the masseter muscles using an algometer. And then you have TMJ sounds for Sandra. The examiner did find clicks on the right and the left joints during vertical as well as lateral movements, and there was no joint locking. So just to put it together, we found that she's not limited, but she does have familiar pain during routine functional movements. She has familiar pain on palpation of all of these muscles and TMJs, and the pain was familiar to headache, and we heard bilateral joint clicking as well. Intraorally, she had class 1 occlusion. Occlusion is something you must check because obviously you want to know if there's any high point. And if that is the case, then you have to alter your diagnosis or management. Rather than the diagnosis, I think it's more to do with the management, but knowing that is equally important. Good oral hygiene. You can see she has bare facets, multiple crowns. She has a Mallampati 3, which is the examination that you do to see if a patient, kind of a red flag for an obstructive sleep apnea. And then the soft tissues. And interestingly, palpation of the area around number 18, 19, and 20. And I want to say this is, I know in India we don't use this classification. It would be 3, 8, 3, 7, and 3, 6. 3, 7, 3, 6, and 3, 5. So it feels different, but does not trigger shooting or tingling pain. So feels different. And increased sensitivity to cold application to the gingiva, again, adjacent to number 19 and 20. And then here is a pan that we want to look at. Now, I want to tell you to the audience here that this is not Sandra's X-ray. I just use this as a, as a reference point. So this is not a good pan. You can see the soft tissues, not a great one, but fairly decent. The idea here was to show you she's had some root canal, she's got multiple crowns, some flattening of the teeth. I don't see any big changes in the condyle. You can see some calcification of the, the stylohyoid ligament. You can see the soft tissues of the ears and all of that. And then, I don't know why there's a problem. Oh, yeah. Okay. So coming back to the MRI. So you have the the pan, you have an MRI for Sandra. Now, if you look at the MRI, this is a sagittal view. It's a closed mouth view of Sandra's, and this is really Sandra's images. You can see that this is the condyle, and you can see the bow-shaped disc, which seems to be slightly anterior to the 1130 position of the condylar head. And in the open mouth position here, as she's translating open, you can see that the disc seems to be captured or seems to be more aligned in between the condylar head and the articular eminence. And on full translation, you can see that it's nicely positioned on the condylar head and it seems to have reduced. So I'm sure many of you already know the diagnosis, and that would be indicative of a disc displacement with reduction. So what is the task here? You have a differential diagnosis. So you went through the process of collecting history. You went through a clinical examination, a validated and evidence-based criteria or a clinical examination. And now you have a definitive diagnosis for some components and a differential diagnosis possibly for some. And look at that diagnosis. I want to show you here that this is that section of the exam form where we focus on pain disorders and intracapsular or internal derangements. And so if you look at that clinical examination, I showed you this just a couple of minutes ago about that familiar pain on palpation of the muscles and familiar pain on palpation of the TMJ, which is diagnostic, like I said, for myalgia and arthralgia. So she has myalgia and right and left, arthralgia because she had pain in both the right and left TMJs. And so this would only be conclusive or diagnostic if you have a positive exam findings and positive history. Both have to be there. And when it comes to the internal derangements, we did hear clicks for the Sandra for both the right and the left joint, which tells you that, there clinically that there could be a disc displacement. And you saw from the image from MRI, clearly there was a disc displacement with reduction. And so now it's up to you for dentists and all specialists to decide whether you want to do a screening test for all of your patients who have a pain diagnosis, and then you want to continue, or you want to proceed with a advanced modality to confirm that screening findings with DC TMD. And obviously imaging is 100% confirmatory. Clinical, not so much, but because there are different specificities and sensitivities for each diagnosis, but imaging would more or less be confirmatory. And then the axis 2 piece is what you also want to address, because like I said, the psychosomatic, psychosocial role that plays into chronic pain is very, very important. So when you manage a patient, you want to be truthful to both axes, so to speak. And then there are these different diagnostic procedures. At any point during your clinical examination, besides the DCTMD, you are not very confident about whether is this a myogenous origin, is it an arthrogenous origin. You always have different diagnostic procedures that you can use. And obviously, you want to rule out odontogenic pulpal involvement. You could use a cold test or an endo ice. And then you have the neural blockades that you can provide, spray and stretch, trigger point injections. All of these help you in narrowing down or ruling in and ruling out specific diagnosis that you may have in your head while you have, simply when you take the history. Let me tell you that when I take history for my patients, almost 70 to 80% of that diagnostic criteria or diagnosis is already formed in my mind. And however, I don't let it sink in until and after I have completed my clinical examination. And then there are these advanced modalities, and Dr. Thomas talked about the different blood tests and that you can do, and there's the quantitative sensory testing, but that's more to research-based. So I don't expect every clinician to engage in all of this, especially I don't expect dentists to engage in it. But if you do, and you want to take orofacial pain as a specialty closer to your heart, then please do so. So how is all of this going to help me in managing TMD? It's always treatment versus management, or both. What is it? Is it different? Well, I think it is, because dentists, like I said, coming back to that example of dentists with that cavity, and you restore the tooth, you have done a treatment. But when it comes to management, it's not only focusing on the treatment's disease, but you're also looking after the emotional, mental, and spiritual well-being. Now, you may wonder, what is it that as a dentist that I'm going to look at the emotional, mental, and spiritual well-being? Well, it's not necessary that you need to do that for all of your patients, but just that care, asking them about their background, involving them in that management, especially in chronic pain, is absolutely essential, because like I said, disease and illness are two different things. So also treatment and management. Sometimes you may need to use both. You'd actually treat a condition, and for the other things, you manage it. Like Dr. Mayakar had a surgical procedure to take care of a certain pathology, but he's managing it beautifully with some distraction coping as well. So ultimately, for the orofacial pain and TMD patient, multimodal, integrated or integrative, individualized therapies is what works best. But I will touch upon some details at the end of this presentation on how you can manage. Let's come back to Sandra. Now, you know that besides the TMD components that we diagnosed, like myalgia, arthralgia, disc displacements with reduction, she also has a diagnosis of bruxism. And how do we know that? From her history. She herself told you that she clenches, and then during clinical exam, you saw those bare facets and flattened occlusal surfaces on that pan. So you have a diagnosis of bruxism. And then you also have a diagnosis of headache associated with TMD. Remember that slide where I showed you she had familiar headache when you palpated her temporalis? That is a diagnosis for headache associated with TMD. But she also told you that she has migraines. She's always experienced this. So do you take it for granted? And this is a question for those individuals who are interested in practicing orofacial pain and not just general dentists. You want to find out whether it's truly migraines. Are you on medication? What is that history? You want to ask about some details of that headache presentation, like onset, location, frequency, and so on. Why? Because you want to make sure that there is a primary headache, that is, it is migraine, and then she also has a headache associated with TMD. I think it's important to know that a patient can have both a headache associated with a TMD and a headache from a primary headache, such as migraine, cluster, trigeminal autonomic cephalalgia, so on. I don't want to touch on that. It's beyond the scope of this presentation. But what you do need to know is that when a patient has a headache associated with TMD and a primary headache going on, and you, the clinician, manage the TMD, you treat the patient or you manage that patient with TMD, they feel good. However, if they have an ongoing primary headache, they're not going to feel that good because they still experience that pain. Tension type headaches. Someone who has a lot of tension type headache and a headache associated with TMD are never going to tell you that they felt really good. Oh, doctor, you saved me from this pain in the head, because you have addressed only one component. So here is where that interdisciplinary collaboration works. So even though you manage the TMD, you manage the headache associated with TMD, it's necessary that you refer this patient to an appropriate physician or a headache specialist to manage those primary headaches. Are we done now? It looks like we have almost completed. No, we are not. And what did I miss? Let's go back to Sandra's diagnosis. So you see there was something that she said she has some tingling, occasional burning sensation in the lower left side of her mouth next to the tooth where root canals and extraction was done. It sounds to me that anytime you hear a pain description like tingling or burning or, weird descriptors, it's inevitably something to do with nerves, correct? And that's where the International Classification of Orofacial Pain comes in again. And you see that number 4, the pain attributed to a lesion or disease of cranial nerves. And it could be, and I'm saying it's a differential diagnosis of post-traumatic trigeminal neuropathy. And why am I picking this one out? The reason I'm doing that is because there is a history of trauma for this patient. And she had multiple, she had root canals, she had crowns placed and all of that. So what this diagnosis tells you is that there's unilateral facial or oral pain following injury to the trigeminal nerve. And we know that it's the trigeminal nerve that's all over here. And there's continuous burning and or shooting pain in an area that has a clear history of trauma associated with the onset of pain. And then these patients will have positive and negative neurological signs and symptoms. What are these positive and negative signs? And I'm sure other speakers in this conference are going to touch upon neuropathic pain. That's a part and parcel of orofacial pain. But just to, quickly, positive findings are usually hyperalgesia and allodynia. Allodynia is where there's no pain impulse, patient feels or experiences pain, and hyperalgesia is an increased sensation to a painful stimulus. And negative can even be numbness, or it could even be dysesthesias or paresthesias. These are the hallmarks of neuropathic pain, and so also the post-traumatic trigeminal neuropathy. And if you look at this last sentence, it can happen with after extractions, implant placements, blocks, endodontic treatments, multiple extractions, and so on. So are you not thinking to yourself, this is my bread and butter? As dentist, this is what I do day in and day out. And are you telling me that patients will end up with PTTN? Well, some of these patients could could manifest with a neuropathic pain. The key here is not that you stop doing your work, obviously not. The key here is to be able to recognize as soon as the patient comes up with these weird or slightly off track abnormal descriptors of their pain. And you have an excellent classification, a diagnostic criteria within ICOP for PTTN. And I would ask you to review these classifications because you might be dealing with one or more of these conditions sometime during your practice without actually knowing it. So what is the referral here? Do you want to refer this patient to an orofacial pain specialist or a neurologist or definitely a headache specialist? Something to consider. And looks like we made it, right? No, but there's something more. And what is it that we missed now? Looks like it is the last piece. My sleep has changed a lot. And why is this important? Because it's sometimes understated or not really stressed that sleep and pain are very, very closely connected. It's almost bidirectional, I would say. Actually, it's more of chronic not sleeping can lead to increased pain. So all of you know this. Think of a day that when you wake up not having slept well, you're going to be cranky, more irritable, less concentration, you're quick to take offense, and you're just sluggish in general. So imagine a situation if you're actually not sleeping well and you're a chronic pain patient, you're going to have a perception of increased sleep. So it's absolutely essential to ask Sandra, why did it change recently? Is it because she's the mother of twins? And is the fact that because, she's taking care of twins, she's not able to sleep? Or is it that her husband snores? Or is she snoring for that matter? Just that history is important and trying to get an idea, or what am I seeing here? Is there an obstructive sleep apnea? I would suspect some degree of obstructive sleep apnea, but only because I saw a Mallampati 3 during the intraoral examination. And this is where dentists have a key role. Remember, I said that dentists are probably the first or frontline people, physicians or clinicians or stomatognatic physicians, whatever you want to call it, one of the first people to see this. Why? Because there are certain indicators that can lead you to obstructive sleep apnea, like Mallampati, the score, deep palate or high vaulted palate. Sometimes you see a lot of mandibular torice, and there's scalloping of the tongue because the tongue is large, and linea albas, and so on. So these are all factors that you can keep in mind. That is this patient a possible obstructive sleep apnea candidate? And so the mantra for management is, every patient is unique. You must be alert to any recent dental treatments that might interrelate with that onset of problem. You must be able to differentiate between those different conditions. Be very, very reluctant with irreversible treatment options, and try to direct your treatment as much as possible to a very predictable, reliable, and proven result. Always take into account your patient's thought processes and the possible cause of the complaint, because sometimes patient can actually tell you what caused the issue without even realizing that they have shared that information. And always remember that adaptation is possible. The human body is amazing and can adapt within the biologic limits and within a certain specific time factor. Keep that in mind. So bringing us to tie in all this together, let's talk about Sandra. There are lots of non-pharmacological therapies that you can use, and some of it sounds very simplistic, but they have a lot of effect. Patient education is absolutely important. I cannot understate the value that educating your patient will go in terms of managing and or treating this patient. They become a willing participant. Sometimes you need to involve the family. And I'm talking about orofacial pain, where you're dealing with a chronic pain patient. If it's a patient with an occlusal discrepancy, then yes, you can address that high point and make sure that, the occlusion is balanced and so on and so forth. But if it's a chronic pain patient, having understood that there are multiple inputs to the brain, you may want to involve the family. And there are a lot of these self-care modalities as well. And again, these are the multitude of non-pharmacological methods that you can use, which evidence is, equivocal for certain modalities. I wouldn't stress one procedure over the other. They all have shown some degree of pain management. So I'm not advocating for one over the other, but definitely it seems to have an effect. And don't discount placebo. Placebo is a huge factor that is now coming up in evidence-based management, because it actually potentiates endogenous opioids. So take all of this into account. How many of you wouldn't like to get a nice neck massage, and how good you feel after that? So imagine if it's a patient with pain and you get that. Sounds very simplistic, but it is a way in which your brain feels good, and you want to try and give those little tidbits of tender loving care. And there's, of course, the occlusal therapies. Nobody's discounting the benefits of splints, or you want to call it by any name. I want to you to be aware that there are certain people in companies. Recently in the US, there was a case against certain manufacturers of tooting their horn on how appliances can bring about big changes in their mouth, and it has actually brought about bad consequences. I want to say, I don't want to dive deep into that, but they have occlusal appliances has its merits depending on where you use it. You should know why you're giving an appliance and for what purpose. And then, of course, jaw manipulation can help. Pharmacotherapy is big when it comes to always use the step ladder fashion when it comes to using medications. However, I do want to say that even though I used pharmacotherapy after the non-pharmacological methods, I cannot stress the importance of using certain medications when you need it. Just think of that patient who has a 8 on 10 pain and is in severe pain or has been experiencing this for many months or years, and you tell them to engage in jaw exercises. When you're in pain, do you want to do exercises? So you want to break that pain cycle and bring them to a situation where they are more open to your non-pharmacological therapies as well. As far as Sandra is concerned, we can think about trigger point injections, Botox, maybe even joint injections. We did not take a CBCT for Sandra. What you saw was just a pen and MRI. So maybe if I took a CBCT and I saw some changes in the condyle, it would have been something that I can think about. Or if she had limited mouth opening, I could think about a joint injection. But it's not the first line of treatment. I want to highlight, I just said that in the eventuality, if something were there, we could think about it. But trigger point injections, whether it's dry needling or with medication, is something we can do if we end up with the trigger point in the masseter muscles or the temporalis or even the neck, because remember, she has migraines. And Botox is an approved management or treatment for migraines in the US. And so referrals, please do not hesitate to provide referrals for your patients. Especially for Sandra, I would refer her to a physical therapist, because when I did the clinical exam, what I found was she had tender neck muscles and all the splenius capitis and so on. She would definitely benefit from some physical therapy for her neck. Remember, she also had forward head posture. For every degree forward tilt of your head, there is more of weight or pressure that the spine is taking on, or the cervical vertebrae is taking on, and that can be a reason for her neck pain or tenderness. So physical therapy absolutely must. Do I want to send this patient for counseling? I know it's not a thing in India to, to use that for as a mechanism, but for those individuals who are in chronic pain, remember the axis 2 and distraction coping. You don't need medication. It could just be simply the act of talking to somebody and getting some good feedback or guidance. Hey, why don't you walk with me? Why don't you do some exercise? Exercises are definitely one of the best endorphin releasing mechanisms that we have naturally. So engage in all of those things. And so coming back to that mantra for management, please know all of these things are absolutely necessary. Keep this in mind. Be very alert to recent treatments. Be very reluctant with irreversible treatment options, and adaptation is possible. And referrals, I cannot understate the importance of, overstate the importance of referrals in your clinical practice. And with that, thank you. And thank you for listening in, being a great audience. And I'm open to any questions that you may have.
Thank you so much, Doctor. And it was really amazing listening to you and the Sandra story. You actually captivated us and kept us hooked on. So, what is happening to Sandra? What did you do? How you dealt with the whole thing? And the storytelling was really, really, really amazing. Way to put it up. In fact, that cleared so many doubts for us also as a new clinician or a seasoned clinician. Thank you so much, Doctor. And I don't see any questions as such for.
Hello?
Dr. Sonal, are you there? Yeah.
Yeah, sorry for the disturbance, and thank you so much, and thank you so much, Dr. Seema, and Dr. Noodle can continue from here on. We have some presentations from the faculty members. So over to you, Dr. Noodle. Thank you, Dr. Seema.
Thank you. Have a good conference remaining. Thank you.
Thanks, Dr. Seema, for joining from US. And we have privilege that we have 3-4 international speakers, and you are among them. So it's nice connecting with you, and we'll try to bring you further in our other programs when we are doing any programs on orofacial pain. Thanks for joining and giving your insight that all about orofacial pain. We have Dr. Anupriya Lakshmanan. She is there. She is moderating from say 3 Porcelain. Dr. Anupriya, are you there?
Yes, I'm there.
Yeah. So, Dr. Anupriya, we are now moving towards the end of the session today, and we have a paper presentation for faculties and all, and we have there are 6-7 paper presenters from faculty category, but 1 or 2 have to leave because they have some personal. They are trying to, because we are lagging for say half an hour. So they're supposed to start by 6 o'clock, but now it is almost 50 minutes delay. So that's why. So now we are calling upon the first speaker, Dr. Alimuddin and Dr. Amna Fatima. Dr. Alimuddin, are you there? Could you please share your slide and start your presentation? We have Dr. Sonal with us. She would be,
Good evening, sir. I'm in the session, sir, presently. Shall I share my PowerPoint presentation, sir?
Yeah, please.
Okay, sir. Please give me a minute, sir. So can you see my presentation, sir?
Yeah, it's visible. Let's start, yeah.
Okay, so I'll just put that on the full screen, sir.
Dr. Alimuddin, we have 10 minutes, so try to cover the this in.
Right, sir. I'll do that, sir.
Yeah, I'll be very strict regarding the timing itself. I'm timing you also, so please be very careful about the timings. Okay.
Bullseye, ma'am. I'll try to stick to the timeline as much as possible.
All the best, doctor.
Thank you, ma'am. Good evening to one and all. Today I'm going to be presenting a topic on hot tooth. In the dentistry, it is known as symptomatic irreversible pulpitis. Now, going back to the introduction, the mandibular molars are the most clinical tooth that gets affected by the condition called as a hot tooth. Now, let us put me a little scenario in the clinic. The patient visits the clinic with severe pain in the lower right or the lower left portion of the tooth, and the dentist advised the emergency access opening for the root canal. The patient complains of pain or the consumption of the cold water. But what happens when the dentist ends up hearing the chief complaint? He ends up giving the anesthesia. And after achieving the anesthesia, the patient complains of severe pain. That's when the patient attempts to stop the dentist from moving ahead with the further procedure. Now, the introduction is the dentist has to withhold the given treatment for the patient. That'll lead back to a little embarrassing situation where the anesthesia given up, you call this inferior alveolar nerve block, does not create any kind of profound anesthesia. Then the moment patient and dentist ends up putting a burr on the surface of a tooth structure to do an access opening, the patient experiences immense amount of pain. So this condition is basically called as a hot tooth because of the condition where there's a lignocaine. The lignocaine channel inside the given portion of the tooth structure or the soft tissue becomes highly resistant. So we're going to be going back that in the further slides. Now, what are the sites? The mandibular molars are the most predominant sites where you have a defective restoration with the presence of the prevalent micro leakage, that is the mandibular molar. The second one is a traumatic site that is common in the maxillary incisors, and the mandibular molars are the most difficult to anesthetize when you try to go with the coronoid notch palpation or the externally with the help of anterior border of the ramus of the mandible at the level of the pterygomandibular raphe. You miss up a notch, you end up injecting anterior or the lingual to the inferior alveolar or the lingual nerve, thereby leading to the failure of the anesthesia. Now, patients with the anxiety about the dental treatments. Generally, the patients are very apprehensive and predominantly anxiety. They have a walkable anxiety when they undergo the dental treatments. Now, what are the symptoms? What the patient exactly try to complain when they have? They have a severe pain in response to the cold. They might have a severe acute
Doctor,
pain.
please share your slides. Your slides are not visible, doctor. It's just a screen that is visible. So share your slides, doctor.
Okay, ma'am.
Share screen is not on.
Ma'am, in front of me, the slides are moving, ma'am, but I really have got no clue why it's not been visible. One second, ma'am.
Press the escape button, go back again and come back.
Yes,
Okay, ma'am. I've gone to escape, ma'am. I'll go back to the present slide.
Yeah.
Is it visible, ma'am, now?
No, share the slide first. Press on the slide, share slide button.
Can you see, ma'am?
No. Continue the way you are continuing then.
Actually, ma'am, in front of my laptop, I can see my screen in the slide share mode, ma'am.
Dr.
No.
Alim, continue the way you are doing. Slides is moving. When you
Okay,
do
okay,
slide
okay,
share,
ma'am.
no, will stuck actually.
Okay,
So
sir.
continue the way you are doing. Yeah.
Okay, sir. The signs and symptoms basically in the hot tooth condition is the patient complains of pain in response to the cold. Later, that pain gets relieved by the medications or probably even by the consumption of the hot water. But the most probably the pain radiates to the region of the auricle or even to the region of your temple and the maxillary teeth. Now, what are the signs and symptoms? In such cases, the patient have got deep restoration of the caries. There would be a severe pain on tendons and percussion, prevalent of a fracture line that might permeate coronally, and radiographically there would be a thickening of the periodontal ligament, and the last but not the least, the most important, the failure of the local anesthesia. Now, what does it mean to have a hot tooth? Now, technically, hot tooth means a very painful tooth which is very difficult or stubborn to anesthetize. The profound numbness would not be achieved clinically by the injection of the local anesthesia, with the lignocaine being the main component. Now, this basically we diagnose as a symptomatic irreversible pulpitis. Now, in such a condition, the mandibular molars are the main tooth which is difficult to anesthetize. The clinician alignment of the needle pertaining to the site of injection varies a lot, which allows the given anesthetic solution to diffuse away from the anatomic site. Now, there are different theories. I'll get back to the most accepted one, which is rightly is tetrodotoxin resistant channels. Now, there's a special class of sodium channels on the C fibers, which are called as tetrodotoxin resistant channels. In such a situation, in a case of an inflammation, the neuroinflammatory reactions start and the sodium channel expression on the C fiber shift from the sensitive to the resistant. That means these sodium channels becomes relatively resistant to lignocaine. So when they become resistant to the lignocaine, it ends up causing the numbness, but still the pain sensation still lingers all the way when the clinician tries to have an access on the surface of a tooth structure. Now, researchers have found these channels to be much more resistant, 5 times more resistant than to the tetrodotoxin sensitive channels. Now, how exactly we try to manage a hot tooth, rightly called as symptomatic irreversible pulpitis, is we try to educate the patient regarding the condition of the tooth, and we try to reduce the anxiety of the patient. We might try to give a diazepam 10 milligrams, and we try to reduce the anxiety of the patient. And we can give a short morning appointments, probably early in the morning, and pre-medication, probably a painkiller by name paracetamol or any other painkiller, any non-steroidal anti-inflammatory drugs, probably a night before the sleep or followed by 90 minutes prior to the procedure. We make sure that there should not be no driving and the patient can be accompanied by a friend or the relative, and the duration, making sure that it should happen early in the morning. Pre-medication, you can give an anti-inflammatory 1 hour before the treatment. And the most important, what kind of additional anesthetic injections we might give to achieve anesthesia. We can give an infiltration in the duration and other supplemental injections like intraligamentary or the intraosseous that can be added as in supplemental injections. Intraligamentary, basically it will deposit your anesthetic inside the periodontal ligament space. You can introduce the needle directly inside the gingival sulcus and in contact with the tooth, and that's going to give maximal penetration of the anesthesia inside the root and the crestal alveolar bone. You can repeat the same injection even on the distal portion of the tooth structure, but here the back pressure would be developed for this technique, and there would rather be a blanching of the soft tissues. So that would be a sign of the success. Now, other method would be intrapulpal. Now, intrapulpal, the needle would be bevel and would be rightly be aligned inside the coronal orifice. And this is going to be a slightly painful injection, as the cartridge of the needle and the bevel would be at right angles. And the forceful injection of the anesthesia would allow the percolation inside the given orifice, thereby inside the canal. So this injection has to be given under strong back pressure. Now, in the few cases, anatomic limitation might be noticed. More importantly, earlier they used to use the bupivacaine as the anesthesia other than the lignocaine, but the bupivacaine is cardiogenic. So we cannot use the bupivacaine as the main anesthetic to be used as a symptomatic pain relief in the cases of a hot tooth. But nonetheless, how would we try to resolve a situation? We would use an anesthesia with an articaine than with the lignocaine. The articaine has got a thiophene group that is capable of dissolving your lipid molecules and thereby causing the penetration inside the membrane and causing adequate anesthesia. Lignocaine as such has got much more resistance in cases of a hot tooth, where simple reason inflammation has got more amount of an acidic nature, that is a low pH. So what happened, the ionized form of the anesthesia tends to get reduced, and in spite of having a profound anesthesia, the patient still has a pain. So the articaine, the 4% articaine would rather be much more effective than in comparison with the 2% lignocaine. Thank you.
Yeah, very good presentation, doctor.
Thank you, ma'am.
Unfortunately, we could not see your slides. So that's okay.
My apologies, ma'am. Actually, I couldn't understand the technical glitch.
That's okay.
Dr. Alimuddin, do Dr. Amna Fatima is with you? She is a co-author, co-presenter.
Yes, sir. Yes, sir. Actually, sir, she's trying to join in from the other laptop.
Okay.
There was some sort of a technical glitch which she's still trying to encounter, sir.
Okay.
Earlier, she tried using a mobile, but laptop she was trying to encounter still the same issue, sir. She couldn't able to sign in, sir.
Okay. Okay.
And Sonal, ma'am, actually, so to speak up, I was able to see the slides, ma'am. My apologies that because of the technical glitch, you couldn't be able to see my slides. My humble apologies for that, ma'am. I'll try to rectify that in the next conference, ma'am, which probably will not happen up, ma'am.
That's okay, sir.
Dr.
All
Sonal,
the
do you
best.
have any question to Dr.
No, hot
Anu?
tooth, hot tooth. I've been dealing with hot tooths and hot teeth rather for a long duration of time, but till the time I was ignorant about it. Over a period of time, I've understood my technique was wrong somewhere in a diagnosing and treatment planning and all. So maybe you have already covered those points. So very well put up actually. But only thing is that the slides were not seen. That's the only drawback. But you have covered the points very well, doctor. Thank you so
Thank
much.
you, ma'am. Thanks a lot,
Thanks,
ma'am. That means a
Dr.
lot to me.
Yeah, thanks, Dr. Alimuddin, for sparing your precious time and coming and sharing your presentation. It would be great indictment to all our the delegates who are in the meeting room, and it is going on records as well, so people will watch it in future and take advantage. So moving on to the next presenter. Thanks, Dr.
Thank you, Nurul
Alimuddin,
sir,
and-
for the presentation. Thank you, Nurul sir, for the chance for giving in the Nopcon conference. Thanks a lot, sir. God bless, sir. Thank you, sir.
Okay. Can I call upon Dr. Anu Vijayan? Are you there in the meeting room, Dr. Anu? Could you please share your slide?
Yes, I'm here.
Yeah, please.
It's showing host disabled participant screen sharing.
No, you share. I think it is, you can able to share now. I have made you co-host. Yes. Dr. Anu, your slide is visible.
But I'm not able to. Yes.
Your first slide is visible.
Is it changing, sir?
Yeah, it's changing as well. Yeah, it's changing.
Okay, I'll start with my presentation.
Yeah.
Some people dream of making money. Some people dream of owning a Porsche. Some people dream of having a holiday home in the sun. But if you live with pain every day, you have only one dream, to be pain-free. Good evening, one and all. I'm Dr. Anu Vijayan, faculty in the Department of Oral Medicine and Radiology, to present my paper, Unlocking Relief with Nootropics, an Adjunct in Pain Management. Orofacial pain, as defined by ICHD-3 in 2018 and ICOP 2020, is a pain occurring mainly or exclusively under the orbitomeatal line, anterior to the pinnae and above the neck. And a pain, when it is persisting for more than 3 months, it is said to be chronic pain. In case of orofacial pain, chronicity is defined when it's occurring on more than 15 days per month, lasting for more than 4 hours daily for at least last 3 months. And we know the pain pathway. Whenever there is a tissue injury, the pain is transducted through the primary first order neurons. It is crossing to the midline, to the dorsal horn, where it's synapsing with the second order neurons. It is getting transmitted to the third order neuron, where it's synapsing in the thalamus, and it is perceived in the sensory cortex. The pain perception is not only through this ascending pathway, but there is a descending modulating pathway also. So whenever there is a balance between the pain perception by this ascending and the descending modulation pathway, the patient receives or perceives the pain in a minimum intensity. Now, when does this pain in an acute stage get converted to a chronic situation? So when there is a synaptic plasticity or a neuroplasticity, when there is change in the central nervous system components that modulates the pain, or when there is central sensitization. So you can see in this table, which I have put in the right-hand corner, the red arrows are showing the ascending pathway and the blue are showing the descending pathway. So from the peripheral tissue, the injury, the signals are transmitted to the spinal dorsal horn, and it is reaching the brain stem, which have the periaqueductal gray, rostroventral medulla, and the locus coeruleus. And it is going to the higher center, that is the brain, but there is an overlap with the corticolimbic system and the pain-perceiving sensosomatry system. So we can see that this prefrontal sensosomatry system and the limbic system are associated with perceivance of the pain and also the emotions and the mood. So the brain regions are not activated separately, but they are functioning in a correlation, so that whenever a patient has a change in the emotions and the mood, it can affect the level of perception of pain for the patient. And we know the conventional modality of management for the orofacial pain falls under anti-inflammatory medications like NSAIDs, opioids, and steroids. Psychotropic drugs like TCAs, that is tricyclic antidepressants, SSRIs and SNRIs, anticonvulsants, and the non-pharmacological methods like exercises, cognitive behavioral therapies, physical therapies, tense therapy, laser therapy, and so on. The commonly used drugs which are used for the management of the chronic orofacial pain falls in the category of the psychotropic drugs, that is the tricyclic antidepressants and the SNRIs and the SSRIs. Now, today in this presentation, I wanted to highlight about the new group of drugs called nootropics, which are called as the smart drugs, which can overcome the side effects of the conventional psychotropic drugs like dry mouth, dizziness and fatigue, insomnia, sexual disorders, cardiac diseases, suicidal ideation for the patient, hyponatremia, and when used in combination, they can cause serotonin syndrome for the individual. So to overcome the side effects of these conventional psychotropic drugs, we can use the new modality of drugs called as nootropics. So what is nootropics? Nootropics are those drugs which are called as cognitive enhancers or the smart drugs, which conventionally is given to the patients or individuals to increase their memory and learning capacity. But in addition to that, nootropics have the capacity to modulate the secretion of the neurotransmitters and alter the neuroplasticity, which I said earlier is the cause for the development of chronic orofacial pain. So, the naturally available nootropics are the mains mushroom, ashwagandha, ginseng, rhodiola rosea, L-tyrosines, and L-theanine, which we get from certain plants in the nature. And these are available in the markets in the form of MindLab Pro, which contains this Brahmi and the rhodiola rosea, which have action in the secretion of GABAergic neurotransmitters. Resveratrol 200 milligram, which is available in the grapes and the berries, which again have action on the dopaminergic and the serotonergic pathways. We have the pyracetams and the L-theanine, which is present in the green leaf extracts. Again, these have anti-inflammatory and analgesic actions also. So, conventionally, these nootropics are acting in the brain by releasing the activity of the neurotransmitters, protecting the neurons, increasing the brain growth factors, and reducing the inflammation. Now, some mechanism of action of these nootropics can be used to manage the pain. That is, analgesic and anti-inflammatory properties, improving the mental focus, which is helping better management of pain for the patient, increase the release of the neurotransmitters and reduce the pain signals, reduce the anxiety and improve the mood, and finally, reduce the stress for the individual, and thus it acts as a natural and effective way for management of pain. So the advantages of these nootropics are it enhances the cognitive capacity of the person. It acts as a natural drug with pharmacology of the psychotropic drugs, with minimal toxicity and side effects, improves the focus and reduces the fatigue for the individual, and improves the sleep quality, again, which is in contrast to the SSRIs, which we give for the patients. But the disadvantages are dependence, nausea, liver damage, and palpitations. So to conclude my presentation, I would like to say pain is inevitable, but suffering is optional. Pain has three dimensions: sensory, emotional, and cognition. Sensory is how the individual perceives the pain, emotional is how the individual feels the pain, and cognition is how the individual interprets and responds to the pain. So I believe nootropics can elevate the emotional and cognitive dimension and subsequently alleviate the sensory component the person is perceiving the pain. So thus it can act as a natural modality, as an adjunctive modality in the management of chronic orofacial pain with minimal side effects. These are my references. Thank you.
Very good presentation, Doctor.
Thank you,
Dr.
ma'am.
Anu, one question I would like to ask, since it is a dependent seek factor is there, so how would you want to tackle that? Like, because we are weaning off the other medicine or drugs, what you were mentioning, as against the nootropics. So the most important factor what we are looking at is non-dependency.
Yes,
So
ma'am. Yes.
something which should not be given for a period of time. Like, as we all said, the whole conference congress, we've been mentioning that if we don't do it to our parents or ourselves, we don't do it to our patients. But these seems to have some amount of dependency. So is there any combating thing, or it is some one of the drug which can be treated as an option for it? Like, do you
Actually,
think?
ma'am, when I went through the articles in the literature, Few articles, it's not like many human trials has been carried out with the nootropics for the management of pain. Nootropics are given for the patients for improving the memory and the learning capacity. I could get only 2 articles which is carried out in the rats for the chronic pain, not orofacial pain, chronic pain, the management. So it's not like it's a completely proven disadvantage like dependence. Maybe it's with the natural, like in Ayurveda, they give these things for the improvement of the memory and all those things. Maybe out of that, they told the dependence is there. But for the pain, it's not yet proven that dependence can be produced by the nootropics.
Okay, thanks a lot, doctor. So we can try maybe some human trials
yes.
that have been conducted very well, and we have some data to really prove it as an evidence because we work on evidence in science. Thanks a lot. It was a good insight, doctor. Thanks for joining.
Thank you, ma'am.
Thanks, Dr. Anu, for coming and sharing your presentation of Content 23. With your permission, Dr. Sonal, should I move to the next presenter?
Yes, please go ahead, sir.
Yeah. So, Dr. Altaf Malik is the next presenter. Dr. Altaf, could you share your slide, give your brief introduction, and present your presentation? What's the title of your presentation? Dr. Altaf, if you're taking time to settle down, I think you're moving somewhere in your premises. So if you not able to present in, should we move to the next presenter? Dr. Altaf will take you the after Dr. Padmavati. Dr. Padmavati, are you there? Could you unmute?
Yes, sir.
Yeah, please share your slide.
Okay, so just a moment.
Mhm. Please give your brief introduction and title of your presentation, and then move forward. Dr. Altaf will take you after Dr. Padmavati.
Sure, sir. Sure, sir. Sure, sir.
Hello, sir.
Yeah, it's visible.
Yeah, it's visible. Okay, sir. Just a second. I'll just adjust it. Okay, so shall I start my presentation, sir?
Mhm.
Yeah, okay. So a very good evening to everyone, to my co-presenters, to the judging panel, and to the audience, and last but not least, to the organizers also. So when we say pain, so the according to the pain, according to medical, we say it to be an unpleasant sensory emotional experience associated with actual or potential tissue damage or described in terms of such damages. Yet it all takes, and it has various names according to their anatomical sites or types and etc. Such as we say as orofacial pain or myofascial pain, which we had an extensive lectures by these great doctors, by these great people. So yet at the end of the day, it all comes down to one thing for these people is pain. Again, it being a non-quantitatable menace for both the physicians as well as the patients. So what we try to do here is with the pain that we try to do quantitate the factors which is causing the pain, such as the inflammation of a muscle or whatever the causative agent is. So when we go for the diagnosis, and again, the topic of this is going to be on TMD and myofascial pain. So for that, the diagnosis, it starts from the basic of a physical examination of a clinical history and up to the recent ones being the 3D fusion imaging. And one such thing, in between is that there are newer USG in town, which we know as elastosonography. So which brings me to my topic, that is the evaluation of masseter and temporalis stiffness in internal derangement of the temporomandibular joint using the elastosonography, which is a shear wave. Again, I have to be specific as there are many classifications under the elastosonography, being the strain and stress and shear wave. We've used the elastosonography. And I, Dr. Padmavati, I'm here to present my paper. So the background, and I'm not going to touch on to the TMDs or the pain receptors pathways, as it is being extensively talked by others. So what I'm going to mainly focus on is my study and the USG. The study and the background literature to it. So the muscle edema may be involved in provoking muscles pain or fatigue. So an increase in these edematous soft tissue areas actually raises the intramuscular pressure, which consequently raises the hardness, which leads to the muscle stiffness of the patients, presenting to the internal derangement, which associated with myofascial pain involving the muscles of mastication. So the need of the study is because the current literature and evaluation of myofascial pain of TMDs is sparse using the technology of USGs, like the elastosonography. So there is which is, as it is a non-invasive, and it may find its application in the diagnosis as well as the prognostic evaluations of the TMD, which would help the physician or the specialist in the treatment of these patients. So our objective was mainly to evaluate the masseter and temporalis muscle stiffnesses in the patients with internal derangement of TMJ. So the study setup was, it was done in our college, Srihar in Chennai, with a prospective type of study and a period of 3 months. I'll tell you why it was a very short study. And we had certain inclusion criteria and exclusion criteria. Basically, we had an age of 18 to 35 of both male and female, and patients who were clinically diagnosed with TMJ internal derangement with myofascial pain. And exclusion were the people below 18 and above 35, and who does not have any pain or anything. So the group inclusion criteria, people who fit in were put into group A, and the people who fit into the exclusion criteria were put into, that is the normal healthy patients, were put into group B. So the sample size we calculated using the difference of two mean formulas, where the total of 30, where group A was allocated 15 and group B was allocated 15. So the proposal was formed and was submitted for a grants commission to our college. And that was why the 3 months short period and with a small sample size, because we were fixed with a budget and a timeline of 3 to 4 months. And the IAQC board approval was obtained. So we had two methodology involving, that is a qualitative method and a quantitative method. As we have spoken, always the pain has mostly been a qualitative analysis for us. So the patients were screened in the OPD, and according to the proforma, which we have, I'll be showing it in the next slides. And the patients were selected, were categorized into two groups, and they were made to undergo the quantitative method of evaluation, that is the elastosonography, where the patient was placed in supine position, and the thickness and the elasticity of the both right and left masseter and temporalis at rest and at occlusion were both recorded. So this was the machine which we've used, Toshiba Zapilio 500, and this was an extensive proforma which we had used during the patient history and the clinical examination. So I've just put in certain images, like it's really a lot of images. Like for 30 patients, you take the elasticity and the thickness of right masseter. Say for right masseter alone, you have to take it for the, there'll be 4 pictures just for the right masseter, being the thickness, the elasticity of at rest and at occlusion. So just put up just 4 pictures to show how it works. The top two were the pictures of a group A, that is the case. You see the right masseter at rest. Again, this is an elastogram. When you apply after the B mode, like something usually like a USG, and when you apply the elastogram position, you get a elastogram where it depicts the area from blue to red, and it shows the elasticity in that region with the waves. As this is a shear wave, we are not giving pressure. Shear is where the vibrations, through the vibrations, the elasticity is felt. So self-explanatory. The first 2 pictures are of a case, and the last bottom 2 pictures are of a control. So the results were, again, we had both right and left being compared. We did not have much of significant results in many categories, but just in right masseter at rest, and they were statistically significant in right temporalis at occlusions, elasticity, and the T is the thickness. It was not much of a clinical statistical significance we were able to find. So we thought this was probably because of the smaller sample size, and we did not have an age and sex, matched sample size. And, we had to categorize the people with TMD with just myofascial pain. We didn't look into the other categories also, as this is just a small pilot study. So this is the graph regarding the previous table. And again, this is the results where we had no statistical significance between the case and control. And this is the graph to it. In moving ahead with the discussion part, as we've spoken in the first slides, the literature is being sparse. There have been just four, I can hardly count out the studies, but there have been just 15 studies using elastosonography, that is shear wave. I'm not speaking in terms of strain or stress, I'm speaking in terms of the shear wave. So there was a study in 2019 by Pollack et al. Discovered using the shear wave that a reduction in stiffness of the anteriorly dislocated discs was below 8.667 and can indicate the patient with a TMD. This is a study where the author tried to come up with a number, a quantitative number. If this is below this, we can tell the patient could be, can develop TMDs. And the second one is by Olshaway et al. Like he had two studies in the same year. One was with the 30 healthy children and another one was a 40 healthy adults. So the first one with the children, he tried to assess the masseter's stiffness on both sides, but did not have, again, much of a statistical difference, something like us. And in the 40 adults, what he did was not just assess the masseter and temporalis, but he also tried doing it with a chewing gum, like he did with 10 minutes of interval, a baseline and chew for 10 minutes, and then a second, the examination, and the rest for 10 minutes and another examination. So something like that. But again, he said that it had a significant tool in assessing the muscle stiffness during the rest period or the chewing period or the baseline period. And the next one is the Osterk et al. 2020 employed that it be a normative study of the disc and the masseter muscle in the young people. So he proved that it to be a non-invasive way of showing TMJ disc and masseters. So moreover, the opening of the mouth increased in the masseter stiffness, and the disc and muscle stiffness were independent of the age, height, or stiffness of the BMI. So moving ahead with the other literary reviews, whereby Arda et al. Or Badia et al. Or Herman et al., Joy, Takishima, or Toka, where everyone tried to assess the masseter's stiffness, but they came up with not much of a statistical significance due to various reasons. But here, if you've noticed in Herman et al., he tried to get a mean value, like again, a quantitative number, how we saw in the temporal disc, in the previous slide here, when they said it to be below 8.66 kilopascal. Here he told that when it is 10 point plus or minus 4.3 kilopascal, the stiffness, the patient with an increase of an age could have, some kind of TMD disturbances. And here Joy et al. In the year of 2015, he had said that the masseter, to a mean of 15 kilopascals, with sex and age, and it being repeated, and there had no effect on its elasticity. And again, Toker et al. In the year of 2023 being the recent publication where they used the SES for the bruxism patients, while the results were not statistically significant, still the researchers, they did find to conduct on a largest group of study groups. So the literary review is that, again, it is not just being used, in the head and neck, or it started with the liver cirrhosis and the liver diseases. Now in head and neck, we use for the salivary gland neoplasms, lymph node metastasis, clefts, soft tissues, nerves, tendons, fascias, and ligaments, and fibrous lesions of oral cavity like OSMF, carcinomas, and implantology, etc. So the limitation of my study is that I would have think that it's to be the smaller sample size. and it is not age-sex matched, as I've mentioned before. So the futuristic overview for this study is what we are trying to do is now we have submitted a proposal for a larger number of people or sample size with age-sex matched, and to be a longitudinal manner of study, with the help of a therapy. Like say we have a TENS or an ultrasound, we try to see again with the baseline during and how with each and every sessions when the patients are coming in, because the patient can say that the pain has gone down, but we need to, it is again a qualitative one. Here we are trying to quantitate the results which the therapy is giving us. So I conclude is that the shear wave elastography is an objective and non-invasive. It creates a potential of, great potential in using and monitoring the changes of the muscles of mastication, not just that, and also the disc stiffness in clinical practice for us. So these will be my references, and thank you so much for everyone to listening it to be, very patiently. Thank you all.
Yeah, thank you, Dr. Padmavati. It was indeed an enlightening session because something new you spoke about. Only one thing is that you already have covered in your shortcomings for this whole presentation was
ma'am.
that we don't have enough sample size over here, and
Yeah.
have not conducted rather. But what I would say is it's a good move, good initiative. Are you taking into account the occlusion part of it also, since you're
Yes,
talking
ma'am.
about
Yes,
bruxism
ma'am.
or functional
Yes, ma'am.
activity?
Yes, ma'am. Actually, yes, because actually the study for information, the study was conducted in the year of 2017 when I was a UG student.
Okay.
So we didn't have much of a time or anything left for us. So that time in my HOD, he's very keen on occlusion because he believes that occlusion plays a major role in TMD. So in the extensive proforma, which I showed you, the 4 pages, occlusion is a must for him. So we take into the occlusion, we get the orthodontist opinion, when the patients were being selected. So again, that's why it was a very small sample size we had to keep. We didn't have much of a time. You need to get yeah, that was the reason. And the occlusions were considered, ma'am, for the,
Because masseter, when you're talking about masseter, the most important aspect when we talk
yes,
about rehabilitation also, so
yes,
all
ma'am.
these factors have to be taken into consideration because
Yes, ma'am.
ultimately, as we all are concluding, we are a dentist first.
Yes,
So
ma'am.
thanks a lot, doctor, and a very enlightening session, very nicely conducted, I would say. Thank you so much. Dr.
Thank you.
Nuzul, we can continue.
Yes. So moving to our next presenter, Dr. Altaf Malik. Dr. Altaf, could you share your slide?
Yeah. Good evening. Thank you, organizers, for giving me the time. And I'm very thankful to Dr. Nurul Anwar sir and Dr. Sonal for moderating this session. So here I'm actually speaking about, we all know internal derangement. It is actually internal derangement. We all know that it is an affliction which affects almost, we can say, about 20 to 50% of the population. And lot many modalities are being tried. And we all know that we have to move from conservative to more advanced. Like nowadays we operate, I'm basically from surgery background. I work in Government Dental College, Srinagar. I have done a lot of work in the TMJ area. And there is something small work which I am actually sharing over here. TMJ, as we know, it is the most complex thing. We can say a simpler joint, but with most complex action in the form of muscles of mastication, which are always in action. And what makes it more complex is that the joints have to move both the sides to permit any action. And there is always large force per unit area. And there is the fibrocartilage, which has got limited repair capacity that makes it in a way unique. And there are teeth which are subject to wear and tear, and then they can actually affect the occlusion. So inflammation, we all know it is a biological response of body to harm stimuli such as pathogens, damaged cells, or irritants, and it is sometimes protective, and if left untreated, it can go destructive. TMD, it is basically a collective term embracing large number of clinical problems that involve masticated musculature, the TMJ and associated structures. This is the classification which most of us are familiar with. We need not to go into detail. The internal derangement was actually term coined in 1814. Basically, it was actually used for knee joint, but now it is so much used for the temporomandibular joint that it gets actually identified with TMJ only. That mechanical
Doctor, could you
fault in
share
a
your
joint,
slides?
which was later on more specifically used to displacement of the disc. Now,
Could you share
according to
your slides,
consensus
Dr.
meeting,
Excuse me,
yes,
can you
yes,
share
ma'am.
your slides, please? Your screen is
Yeah.
not moving. Share your slides, please.
Okay, ma'am. Just a ma'am. 1 minute, ma'am. Is it visible?
Your slides
Go to the
are
full screen
visible.
mode. Go to the full screen mode.
Full screen mode. Yeah, I have put it on the full screen mode, but is it now?
Continue, Dr. Altaf.
Okay.
Dr. Sonal, please
So,
compromise this with small visibility.
So do one thing, doctor. You can press a down button so that the slides keep moving, and whatever we can see, then we can.
okay, ma'am. Okay, ma'am. So sorry for that. I don't know why it has happened. We all know that whenever there is trauma in the form of anything, the joint reacts in the form of small bleeding or hemarthrosis. And if that bleeding gets organized, then we may go into a phase from synovitis, which is basically inflammation of the synovial membrane, and it can go into a disc adhesion, limiting the disc movement, and then it may go into the disruptive change. So whenever there are biochemical changes in the tissue and synovial fluid, if the response is maladaptive, we get altered joint biomechanics, which reduce motion and causes pain, and which is actually counterproductive in both the ways. If we go basic thing that disc displacement with reduction, this is the normal joint moving, and this is when the disc moves in the synchrony with the condyle, and this is what we call as disc displacement with reduction. It gets reduced after the joint moves of its own, and that is usually stage two. But at stage comes once the disc does not come back, it doesn't recapitulate. That's wherein we call it as the closed lock. So what are the actual clinical features in such patients? They usually start with the pain, limited mouth opening, episodic clicking, and the joint tenderness, deviation to avoid the pain, reduced mouth opening, and prevalence. It is in different literature, 5 to 12% of the population, but recent literature says it is usually 20 to 40%. Most of them have usually pain, clicking, and anxiety. That's what brings them a disorder which is actually shared by so many people. So if we sum up, it is somehow a normal going to clinic, to clicking, to episodic locking, a full lock, mild wound changes, and TM joint destroyed if not controlled. So what are the treatment options? Treatment options are usually conservative, which we are all familiar with. We start with the splints, though they are not recommended as of now. There is a lot of literature saying that they should not be given because that they actually take joint to rest and that may cause more damage. Pharmacotherapy or TENS for relieving the pain, or the main area presently being focused is minimally invasive management in the form of orthocentric or arthroscopy, and invasive management in the form of surgery. So non-surgical therapy, usually it is diet, pharmacotherapy, physical therapy, TENS, ultrasonography, what was being talked just now, high voltage stimulation. And these small occlusal adjustments, though literature favors that actually a stable malocclusion does not cause internal derangement, it is an unstable. But anyway, remove or extract, usually a third molar is extracted for that. If sometimes it is impinging, reshape a high point, orthodontic treatment. We are not actually in favor of that presently. Restore, replace, and TM joint surgery, sometimes if the joint is usually in stage 4 and 5. But what I'm presently focusing on is minimally invasive procedure in the form of orthosynthesis and arthroscopy, usually stage 2 and stage 3 disease, when the mouth opening is usually less than 23, less than 30. Orthocentesis, by definition, we know it refers to an lavage of the joint space, and it is actually orthopedic literature is very much flooded with it. What it means. Objective of orthocentesis is cause lysis of adhesions and joint lavage, which helps to relieve painful hypomobility. The disc objectives are to eliminate restrictions on the disc and lateral capsule, to wash out microscopic debris resulting from breakdown of auricular surfaces, to irrigate the joint of enzymes and prostaglandins, and to stimulate the normal lubricating properties of the joint. So we do usually follow that Holman-Helsing line. We draw a line from lateral canthus of the eye to the lobule of the this canthus, lateral canthus to the tragus, and then from 10 we draw a line from 10, midpoint of this 10, and then to below, then 20 and 10 to this 10 below. That is actually for the two needles which are to go into the superior joint space. So these are the landmarks, and this is how we go. We place a needle over here and a needle over here. So we have done a work on many patients, and we have seen whenever the orthocentesis is done, if it is almost 80 to 90 ml of ringer actinium are pumped into the joint, it helps in reduction of the pain and increases the mouth opening in the subsequent follow-up, and in fact it leads to reduction of the joint sounds, which are called the clicking or sometimes grating sounds also. We have done another study wherein we actually compared plain orthocentesis by two needle technique with orthocentesis, and once we gave a steroid, additional dose of steroid, but we found those steroids have limited advantage, not that advantage that it can be said that it was more advantageous than the orthocentesis only. So that orthocentesis alone is actually superior or has got almost equal results if orthocentesis is actually combined with a steroid and then or any other like hyaluronic acid, which is a lubricant. And then we have another study wherein we compared double needle orthocentesis with single needle orthocentesis. We found that they were equally effective in relieving the pain. These are certain depicted pictures. These are the two needles, 10-2 mark and 20-10 mark. And this is a simple cannula. This is very simple technique, and patient does not have to invest much on the money. See, these are simple cannulas, 18-19 gauge needles, and they have been inserted. This is the ejection of the fluid. This is the video of one of the patients. I don't know whether it runs. No, it's not working. So coming down, this is actually once we have done MRI. This is the initial phase. You can see that how disc is stuck. And in the follow-up of 3 months, the disc is relieved, and at 9-month follow-up, disc is totally relieved of by doing orthocentesis. So our results say that orthocentesis with two needle or single needle orthocentesis with steroids, they help there are significant improvements in the follow-up. But if we compare orthocentesis with single needle, two needle, or orthocentesis with steroid or without steroid, they are not in a way much having any improvement other than the orthocentesis alone. That is actually basic idea of presenting this presentation, that orthocentesis alone can be actually helpful in relieving the patients of TMJ pain and of the limited mouth opening. So in our study, actually the VAS scores decreased from 6.4 to 1.15, and the mean mouth opening improved from 33.55 at 1 week to 42.15, which is significant. And this has been published in the PubMed journal. And these findings do not support the clear superiority of one treatment protocol to others in achieving pain management in TMJ inflammatory joint disorders or short-term or 6 month follow-up. The difference between various treatments is not significant. Orthocentesis alone can actually help in relieving the patient pain. Hydraulic pumping procedures described by actually Mukarami and popularized by Nitzen, who have won a place in the therapeutic management of TMDs. TMJ orthocentesis is supposed understood to include lavage of the upper joint, hydraulic pressure and manipulation to release the adhesions or the uncurved disc phenomenon, that is the stuck disc phenomenon, or the suction cup effect of the disc, and improve motion, and therapeutic injection of the steroid can be done if the orthocentesis is carried out. Single steroid, only steroids are not effective. They can be actually very harmful. If continued, they may cause condylar resorption. And to conclude that orthocentesis, rather being an alternative to arthroscopic surgery, would be indicated for patients with acute TMJ closed lock, refractory to medication and mandibular manipulation. So this is how I leave final thoughts. TMJ orthodontics is the least invasive and simplest of all surgical techniques, has proven to be highly successful in establishing a normal range of mouth opening in patients with closed lock. Final thought is that TMJ actually is the area which is very gray, and it needs a multidisciplinary approach, and role of minimally invasive procedures like orthosynthesis and orthoscopy cannot be undermined, though surgical, there are candidates in stage 4 and stage 5 disease which need to be taken up for this surgery. Thank you very much.
Thank you, Doctor. It was really a nice and insightful presentation. And any contraindication that you might suggest?
Ma'am, the only contraindications, 2 to 3 contraindications, God forbid, if we suspect malignancy in the area, or if it is an ankylosis, then and in acute infective stages, like in the places wherein we get actually people from which have got septic arthritis. So actually, the needle injection may actually promote the more infection over there.
Yeah, perfect, Doctor. Thank you so much, Dr. Nurul. We can continue further.
Yes.
Thank you very much. Thank you for giving me the time.
Thanks, Dr. Altaf, for
Thank you, sir.
joining and presenting your presentation. Now we have Dr. G. Rupashri. Dr. Rupashri, are you there? Could you please unmute and share your slide? After that, Dr. Sunal, there is one more presentation, and that would be the final one. Dr. Rupashri, you are there in the meeting room. Yeah, your slide is visible now. Yes.
Can you
Go
see
ahead.
the screen, sir?
That's visible. Go ahead.
Yeah. One sec, there is some technical glitch, yes. And let me put it to the slide share. Yeah. Good afternoon, good evening, one and all. This is Dr. Rupashri from the Department of Oral Medicine and Radiology. This paper comes to you from the M.R. Ambedkar Dental College and Hospital. So basically, today's topic of my presentation is recent advances. Basically, I'm concentrating more on medical management than on surgical aspect. So what sparks interest in trigeminal neuralgia is that we have opened a orofacial pain clinic in our hospital. So we do get a lot of patients, and we are treating trigeminal neuralgia. And the thing is, it is very refractory. Whatever we do, whatever treatment modalities we procure, they come back. So this has triggered a challenge in me to go for some of the recent advances in the treatment of trigeminal neuralgia. So we all know pain. Pain is something very unpleasant sensation or emotional experience, and it is actually subjective to self, and pain is not the same for everybody, and pain does not require any presence or loss of tissue damage. So we all know all this. So there are definitions, various definitions of trigeminal neuralgia. The most accepted one is from the International Society of Study of Pain. However, the more descriptive way of defining trigeminal neuralgia is from HIS, that is International Headache Society. Painful, it is defined as painful unilateral affection of the face characterized by brief electric shock like pain limited to the distribution of one or more divisions of trigeminal nerve. So pain is commonly evoked by trivial stimuli including washing of face. So these are all called the trigger factors. So the other names that are given is tic-doleric, trifacial neuralgia, and Fothergill's disease. Tic-doleric is something like which gives a painful jerking sensation. Yes, it is a truly agonizing condition in which the patient may clench the hand over the face and experience severe lancinating type of pain associated with spasmodic contraction. Hence, the feature has led to the use of this term. So there are various types of classification. We all know the most ancient classification was given in 1934, which was classified as classic and true, and later as idiopathic, primary or secondary, later than typical and atypical. These are the types of facial trigeminal neuralgia: typical, trigeminal, atypical, pre-trigeminal, multiple sclerosis related, secondary or tumor related, and trigeminal neuropathy or post-trigeminal neuralgia and failed trigeminal neuralgia. So what are the various etiological factors? That first is the vascular factors. Here you can see this is a very clear picture where there is no compression. There is an easy flow of the blood supply in the trigeminal area, and here you can see that there is compression. So this area there is compression and there is an altered flow of blood here. So other etiology that can be suspected is the infections, multiple sclerosis. We can, whenever there is multiple sclerosis, we can expect bilateral trigeminal neuralgia, post-traumatic intracranial vascular abnormalities, and some of the viral etiologies. So this is one of the picture where you can see this is the intracranial tumors and this is the non-affected side, unaffected side. And here you can see that the distorted nerve which is beneath the tumor. So this is the pathophysiology. Any atherosclerotic blood vessels pressing on the roots of trigeminal nerve, which causes focal demyelination. So what is focal demyelination? Focal demyelination at the site of compression may also allow electric spread of electric excitation between the adjacent sensory axons, which causes aphatic transmission. So these aphatic transmissions are something like a short circuit which within the trigeminal nerve, which might explain the electric jolts of pain within the patient neurological system. So this causes the intense episodes of pain. So this is the progression of pain over a period of time. Early in the period of the disease course, the period of remission is very less. As the disease progresses, you can see there is a lot of periods of remission. So the incidence is 8 in 1 lakh. Age is 5 to 6 decades of life. So females are have most predilection than the males. Right side is more affected than the left side. The third branch is more commonly involved than the second and the first branch. So here you can see the most common branch is the third, that is the mandibular branch, which is followed by the second and the first branch. And here you can have a distribution of trigeminal neuralgia in all the three branches. Okay, so this is the division what you can see. It also affects 3 divisions and it can rarely have a bilateral approach also. So this is the places where you get the trigger points, like in the second branch, the skin of the upper lip, ala, cheeks, and the upper gums. In the third, that is the mandibular branch, you can have the lower lip teeth or gums or the lower jaws. And the rarest occurrences in the maxillary region, where you have supraorbital ridge as a trigger point. So this is the various clinical features. Let me not go into the details of it. So we have something called as the White and Sweets criteria. So there has to be 5 criteria for us to call it as trigeminal neuralgia. First and foremost, pain has to be paroxysmal. Pain should be provoked by the light touch, or they should have a trigger point, should be confined to the divisions of the trigeminal nerve. Pain should be unilateral. Clinical and sensory examination should be normal. So whenever we elicit the history of the patient, we have to look into all these components. We should ask the chief complaint, how, when, what starts, what triggered. So all this plays a very important role. History of presenting illness, of course, and the onset, location of the pain, quality, intensity. So the trigeminal pain is very different from others. As I was mentioning, it is an aphatic type of a pain where the patient experience excruciating electric jolt-like pain. So they do have aggravating and relieving factors, and they also give the history of past treatments. So this is the IHS diagnostic criteria for neuralgia. Again, it is a slight modification of the White and Sweet criteria, paroxysmal attacks of facial or the frontal pain that lasts for few seconds to less than 2 minutes, affecting 1 or more branches of trigeminal nerve. Pain should be at least intense, sharp, superficial or stabbing. It should be precipitated or triggered by a trigger zone, and patient can be entirely asymptomatic between the paroxysmals. and should not attribute to any other disorders, and there is no clinically evident, there should be no clinically evident neurological deficits. These are the differential diagnosis. What we can consider, the first differential diagnosis we can give is glossopharyngeal neuralgia, where they share a common trigger points along with post-herpetic neuralgia, post-traumatic neuralgia, migraine, sudden unilateral neuralgic type of pain, and tumors from the nasopharynx. And this is the medical management. So in our clinic, what is happening is we have all tried this treatment, like we have treated patients with carbazepine, and one or what 200 to 1000 to 200 milligrams. So they come out with pain again, 2 or 3 months they're okay, so they come back. So there is always a refractory case that comes. So as we went to, these are the various treatment protocols what we have followed, and we have been treating them regularly. So what the novel therapies, what we have taken recently is going through various literatures. We have tried in our clinic various, still all this drug trials are in the process, but what we are experiencing is lot of pain relief. There is lot of 50 to 60% of the patient have got relief from this. So we are doing the studies with vixotrigine with a placebo effects. So 10 cases of trigeminal neuralgia treated with vixotrigine and with the placebo. Still it is under trials. We do not want to reveal the thing, but what we have come to a conclusion is that there is a significant relief with this treatment plan. So next is, we have not tried this drug, but it is something very close to carbazepine, a third generation anti epileptic drug. So we are on a process on trying this drug, which is very similar to carbazepine. And yes, sumaperidine, so sumatriptan, we have tried this. Again, we have 5 patients we have been treating on this, and we are yet to get the results, but definitely there are some relief to the patients. So we are giving in a tablet form, 50 milligrams we are trying, and the other treatment modalities include intranasal carbon dioxide, which was always been considered as a pain modulator. We have not been trying this, but we have got a very good results with the first 2 drugs. The other drug includes the calcium channel blockers. In patients, they have been, the literature says that in patients there is a chronic pathophysiological mechanism with a monotherapy with sodium channel blocker is not sufficient in pain control, but they are usually used along with certain antidepressants. So other modalities that could be tried is topical capsaicin, lignocaine, misoprostol, and so on. So these are the non-pharmacological way of treating. Yes, in our pain clinic, we are definitely trying with the cryotherapy and low-level laser therapy. The rest of them we have not tried. And to conclude with, the treatment modality ranges from standard novel therapies and peripheral box to surgical procedures. Newer and novel techniques have been arrived that shows a promising results. However, we need to do a larger randomized control trial that is required for validation of such techniques. Thank you so much.
Yeah, thanks, Dr. Rupashri. It was really a good synopsis of trigeminal neuralgia pain condition, which is very difficult to decode, I would say.
Yes,
so
ma'am.
thanks a lot, and continue doing the good job, since it is on a trial basis also, you are experimenting with many things.
Yes,
So
ma'am.
continue doing the good job, and as of now, I would say we will get back to the whole scenario post 2-3 years down the lane. How you're
Yes,
doing,
ma'am.
we'll talk on that then.
Yes,
Thank
ma'am.
you
Thank
so
you
much.
so much, ma'am. Thank you so much for providing the opportunity.
Okay, Dr. Sonal, should we move to the next presenter?
Yes, please.
Yeah, okay. So can I call upon Dr. Ranajo Banerjee? He is a PG, he's supposed to present tomorrow, but tomorrow he is not available. So he said that he is willing to present today itself. So Ranajo, are you there?
Yes, sir, I'm there.
Please share your slide.
Is my screen visible? Hello?
Yeah, it's visible. Go ahead.
Okay. So good evening, everyone. So I am Dr. Ranojay Banerjee. I am a first year MDS student from GDC Aurangabad. So today my topic of discussion is imaging modalities in orofacial pain. So here we will look at the 2D and 3D modalities of orofacial pain. So first, to introduce the topic, first we have to know what is orofacial pain. So as we have listened to the speakers since 3 p.m. So I guess we already know what orofacial pain is. So it's any pain that refers to the soft or hard tissues of the head and neck region that we can say in orofacial pain in simple words. So the orofacial pain's pathophysiology is a complex type because it can be due to many causes like dental cause, it can be due to mucosal cause, musculoskeletal cause, neurovascular, neuropathic cause. So this variable pathophysiology and the complex anatomical structures of head and neck, as we know that there are so many nerves and so many blood vessels present in the head and neck region. So it makes the diagnosis of this orofacial pain quite challenging to the dentist. So for this, we have to take proper history, as Dr. Sandesh Maikar rightly said in the previous discussion, that we have to take proper history and then we have to do proper clinical examination, and then as a further modality we can move on to the imaging to further confirm our diagnosis. So as imaging modality, we can have two kind of imaging modality, like it can be 2-dimensional or it can be 3-dimensional. So first we have to move from the simple to the complex one. First, as we all do in the clinical practice, intraoral radiographs like IOPA, periapical radiographs we all take. And then there are bite-wing radiographs, occlusal radiograph. And also then we can move to the extraoral like panoramic, and then we move to the complex like CBCT, MDCT and MRI imaging, etc. So first we have to stick to the simple. So first, whenever a patient comes with a pain in the mouth, so we have to first ask for the proper history. And in 90% case, we can see there is a dental caries in the patient's teeth. So the IOPA radiograph is most commonly used here. And then we can treat accordingly, like we can use silver filling or you can use GIC or composite, whatever is required. And then we can use bite-wing radiographs for interproximal caries, as we all know. And occlusal radiographs can also be used in case of, suppose periapical radiograph cannot be taken as the patient cannot open the mouth widely. Or we can also use occlusal radiographs to rule out the presence or absence of salivary gland stones. So what we did here is first we took the simple things, what we have in the routine clinical practice like IOPA, occlusal radiograph, bite wing. And then if the pain is not identified or the diagnosis is still not confirmed, then we move on to the next, that is panoramic radiograph. So as we all know, it's an excellent screening tool because we can see a very broad anatomical structures of maxillofacial bone and teeth. And it's also the most commonly used extraoral modality in the routine dental practice. So if we cannot confirm the diagnosis by IOPA, we can go for panoramic radiographs. And in many diseases like osteomyelitis or some periodontal disease, or to get the overview of the pulpal picture of the patient, or also in case of maxillofacial bone destruction in such certain conditions like odontogenic cyst or non-odontogenic cyst or tumor, we can also take help of panoramic radiograph. And in also dentomaxillofacial trauma, as we have to see a lot of structures, so panoramic radiograph is also useful here. And also we can see the post-surgical infection or trauma following a tooth extraction by this panoramic radiograph technique. So when the pain is not associated with the teeth, but we can see it is associated with some other structures, like it can be an elongated styloid process, or it can be the ossification of styloid ligament. So then the panoramic radiograph or CBCT can become quite handy. And also we cannot miss the temporomandibular disorders, as we all can hear from since the afternoon, that the temporomandibular disease we cannot see in the other radiographs as well as in the OPG. So we can see the bony components of the OPG in the bony components in the OPG, and we can see if the lateral poles and central parts of the condyle are in the proper position and in the proper structural outline. So if any advanced bony disease is occurring, like rheumatoid arthritis or loose radiopaque TMJ body, we can see, or any traumatic disturbance of joints, it can also be identified using the OPG. So as we can see in this picture, that the 17-year-old woman presented in the clinic with a large radiolucent and multilocular lesion in the right mandibular molar region. And we can see in the radiograph that a straight thin septa within the lesion we can see. So we can identify it as a tennis racket-like appearance, and we can see it is a characteristic of odontogenic myxoma. So in this way, and then we can confirm the diagnosis by biopsy. So in this way, OPG can become very useful in day-to-day clinical practice for diagnosing orofacial pain. So next we move on to the complex ones like CBCT, cone beam computed tomography. So since the introduction of CBCT in dentistry in 1998, this three-dimensional imaging technique plays a quite significant role in the dental diagnostic science. Especially we can have the proper field of view and the resolution in this CBCT, and we can also adjust that which the other radiographs lacks, what we have discussed previously. So this CBCT, from the CBCT we can diagnose quite accurately, like the pre-implant or post-implant site evaluation, if there is an implant-related nerve injury or not, and if there is any anatomical structures near the apices of the teeth, and also the internal external resorption, if there is any internal or external resorption, which we cannot diagnose properly in OPG or IOPR. And then the morphology of TMJ we can see quite accurately, and in dentomaxillofacial trauma it's very accurate. And we also see if there is any if sinusitis is there, because sometimes there's a pain of sinusitis and the patient complains of the pain in the upper back teeth region, then we cannot find any pathology there. So in that case, CBCT can be a very important tool for us. So like in this case, we can see there's a pre and post implant site evaluation. So in this case, we can see a 30-year-old woman developed paresthesia 2 weeks following the extraction of left mandibular first molar and after the placement of bone graft. So after the removal of the bone graft, in the CBCT study, we can see a clear communication between the extraction socket, as we can see in the arrow, and in the communication between the extraction socket and the inferior alveolar nerve canal. And also in this cropped pseudopanoramic image, we can also see the bone graft fragments. Okay, so this is one interesting case. So another case, we can see a 68-year-old woman came to OPD with the endodontically treated maxillary right molar with pain, but in IOPA, the A picture suggests the IOPA radiograph picture. We cannot see any visible periapical radiolucent lesion. But when we perform the CBCT there, we can see that there is a mesial buccal root resorption, and also we can see the perforation of buccal cortex in the image C. Next, if we move on to another case, a very interesting case, a 34-year-old patient came to the OPD with pain, and the IOP was not that clear. But when we perform the CBCT, we can clearly see there is both the internal and external resorption of the 1-4 and 1-5. So these are the interesting cases that we can solve the proper diagnosis. We can give the proper diagnosis using the CBCT. And also we can see another CBCT case where a 56-year-old patient came with the painful mouth opening. And in radiograph, we can see that the condylar process is extended over the articular eminence. So we can say it's a case of TMJ hypermobility. And there are other radiographic criteria also, other radiographic techniques also, like MD-CT or multi-detector computed CT, which is commonly known as CT scan. So CT scan we can also use, and CT scan has a less signal to noise ratio compared to CBCT, and as a result, it provides a higher quality of image. And the specialty is it also offers both a bone window and a soft tissue window to enhance one at the expense of the other. So in addition, we can also use some intravenous contrast agents to enhance the soft tissue and vascular image details. So here we can also visualize the soft tissue details which were lacking in the previous other radiographic techniques. And we can also perform CT angiography for providing information regarding the carotid flow if the stroke or arterial dissection is suspected.
So, Banerjee, we have running, could you please, pass it
Okay.
Yeah.
Okay. So at last we move on to the MRI imaging, and the MRI is a beautiful and excellent imaging technique because it has a excellent soft tissue differentiation. So MRI can be used in the TMJ disc position and TMJ joint shape and other musculoskeletal disorders and neurovascular lesions. As we can see here, the T1 and T2 weighted MRI image of the same patient, and we can visualize the TM joint very accurately using MRI. So to conclude, I can say that the imaging modality is a very important tool to diagnose the orofacial pain and to manage it. But we have to first focus on the proper history taking and proper clinical examination. Thank you. These are my references.
Yeah, thank you. That was a very detailed presentation, and thanks for sharing, Doctor. And all the best for your future endeavor. You're still in first year, so all the best.
Thank you. Thank you so much.
So, thanks to all, Dr. Sonal. Thanks for you are with us for say from 3 o'clock in the afternoon. So it's a very say, marathon sessions actually, and long sessions we have so far, and very enlightening session. We have people who join from thousands of kilometers away from us, from US.
Yes.
There are 2-3 speakers, and they are the pioneers of this orofacial pain who brought this understanding and this specialty in India. Dr. Mayekar and Dr. Ajit Shetty and their extempore discussion. So that was very enlightening. So with this note, I am just giving you the brief that what we are going to discuss tomorrow. Tomorrow will start by 10 o'clock in the morning on Sunday. And we'll start with Dr. Cheena Singh. She is a academician in PGI Rohtak, and she will talk about trigger point injections or a conservative way to treating myofascial pain. Then we have a very prominent speaker joining from Kerala, Dr. Karthi Joy. He will talk about barrier dimension of neuromuscular dentistry. Then we'll talk something about how we use lasers for managing orofacial pain. A dentist, oral physician joining from Nasik. Then we have the big show on that, Dr. Ruchika Sood. She is from Mumbai and she is also a leader in orofacial pain management. So she will be talking on enigma on orofacial pain. Then we will be discussing about diagnosis and management of TMJ disorder. There is one orofacial surgeon, maxillofacial surgeon, Dr. Taufik Vora is joining from Mumbai. Then we have Dr. Varun Kunte. He will be talking about methods for treating myofascial pain. Then again, our organizing secretary, Dr. Sonal Yerpude, will join again. And she will be coming again tomorrow, and she will talk about role of appliance therapy in management of temporomandibular dysfunction. After that, we have a brief paper presentation for PGs. And then we have 3-4 anesthetists who are joining from various places in India. Dr. Sanjeev will come first. He'll talk about various nerve interventions to treat facial pain and what are the advanced pain intervention. Then neuromodulation is a newer technique that would be taken by Dr. Vijay Bhaskar joining from Hyderabad. Then Dr. Meenal Chandra will join. She will talk about very innovative plasma therapy, plasma treatment in TMJ dysfunction. Then there is a one, a specialist who is Dr. Navita Purohit. She will be joining from hospital from Mumbai, and she will be talking about ultrasound guided intervention in orofacial pain. Then we have Pratibha. She is joining Southern India, talking about diagnosis and management of trigeminal neuralgia. Then we have T.P. Chaturvedi. He is an orthodontist joining from Banaras Hindu University. We'll talk about temporomandibular dysfunction. Then we have 2-3 more speakers, Dr. Vaishnavi, Dr. Maithili. The highlight of tomorrow is that we have Dr. Sumit Gupta. He is again leaders in orofacial pain. He would be joining from Dubai, and he will be talking about thinking out of the box clinics orofacial pain approach. So this is what we are discussing tomorrow. And we have the opportunity for further, registration as well. Those who have missed the first day, they have the opportunity to join tomorrow. They can register. So whosoever is your known one, your batchmate, your classmate, your colleagues, you can convey that. They can join tomorrow. And with this, note, we are concluding today's session. It is at 11, I think 8:11. So I think we are, we supposed to conclude it by say 7:10. So almost 1 hour we are lagged in today's session. There might be chances. 1 hour.
1 hour well spent.
Yes. Okay.
Thank you, everybody.
Yes. So with this note, it's a very overwhelming response. We get some around 200 registrations so far, and there are people who are joining because what happened that there are people entered, they registered with the different email IDs, and while they are doing the logging in, they are with the different ID. So the system is not picking them up, but slowly and gradually the people are able to join, and all the people is joining and leaving. So we have say 80, 100 at any point of time. We have say 80 to 90 people. Tomorrow we are we have both the options we have, that anybody can watch it on NetSkill live. This is we are webcasting over there. We are doing on YouTube as well, and we are allowing them to enter into the Zoom room so that they can unmute and ask the question to the presenters, the speakers. So thanks all. Thanks Dr. Sonal again for making this happen. Without your help and support, this can't be, we can't able to do this Nopcon 2023. It's a great help from you all, from coordination with bringing speakers, coordinating with them, and yourself making yourself available with such a, because you are busy dentist, busy, but still you have given time and all. So it's a great opportunity for all of us, and we learned a lot. And tomorrow we have a powerful sessions and all. Thanks all. We are signing off now. Anybody if want to ask any question can unmute. Otherwise, we are signing off for today. Thanks all. Thanks all from the organizing team of.
I would say we continue with the questionnaire tomorrow. Then in chat session I'll be available, and whatever questions audience have put across, I was not able to answer everybody. I have answers to everybody, right from Dr. Davis's book and the availability of the local gel in India, the neuropathic gel. So I will share all the details tomorrow in the chat session. So keep watching chat session tomorrow.
Okay. Thanks all. Okay. Bye bye.